Hello, good morning.
Morning, sir.
Morning. Can I one second. Not able to. Is my video on? Video is not on, I think. Video is clear, right? Hello.
So you have switched on your camera?
Yeah.
Hold on, we just check.
Yeah. Morning, Vipin sir.
Shagir, can you please remove the spotlight so that we can see that everyone's video is coming up?
What you are saying?
Spotlight, please remove the spotlight. Dr. Fhno, you may try. Your screens are working.
My screen, yeah.
Yeah. So we can see that your network is very low. Bandwidth is very low.
There's some issue with the network. Yeah, sorry. Just some issue with the system. I think I'll disconnect and try and connect once more.
You may try.
Yeah.
Hello.
Yeah. I'm just trying to disconnect. It's not letting me disconnect also.
No, all the participants have come. Do we have Dr. Narayan Subramaniam, Dushit Mandalik, and Aditya Murli? And the chairpersons available?
Chairpersons are not yet available.
Okay.
Oh, I need to stop sharing. Yeah, that's the problem. Correct. Yeah, I'll just try and share screen once more. Okay. I'm just disconnecting and joining in once more. Just
Shagir, you may put the holding slide.
Dr. Dam, can you hear me? Dr. Bipin here. Hello.
Hi, Vipin. Hi. Good morning.
Hi, Dr. Dam. Yeah, good morning.
Good morning.
Actually, I just received a message saying Dr. Satish sir is busy with an emergency, so he's not able to join.
Right.
So maybe you'll have to carry on with
Yeah, I
one
he
chair.
wants to join. So I'll be the sole chairperson for this morning session, right, Vipin?
Yeah.
Okay, no
right.
problem. The other speakers, I hope, are there already. So
Good morning, Doctor. Dr. Dam, Dr. Bipin, Dushyant here.
good morning, Dushyant.
Morning, Narayan.
Good morning. So otherwise, we are all set, right?
Very good morning to all.
Hi, Harsh. Good morning.
Hi, morning, sir. Morning, sir. Morning, Vipin, sir. Morning, Dam, sir. Morning, Dushyant, sir.
Good morning, Harsh.
Good morning.
Good morning, sir. I just try to check if the screen is sharing well. Oh, sir is sharing right now. Was having some issues earlier, so
We have Aditya to join us, right? Aditya is supposed to join and Narayan is supposed to join for this session.
Yes, sir.
Narayana is here.
Oh, hi.
Good morning,
Yeah.
Narayana.
Hi, how are you?
Fine, great.
With the permission of the tech team, can I just try to share the slide once more? There was some hitch earlier.
Please go ahead. I think we should.
That's a good idea.
Yeah, so this is the right. I think it's sharing well. I'll stop sharing for now.
Can I also try once?
Yeah, please go ahead. I'll go after you.
I think it's working. Right, it is. Yes.
Is my screen visible?
Yes, it is.
Okay. Thank you.
Good morning, Dr. Varghese. So we may start at sharp 10. 1 minute.
Yeah, sure. There's no more delay. Actually, we have all of us here, and we will go start with all available participants.
Shagir, put the slides.
Step.
Right.
Should we start off the session? It's 10. Yeah.
Yes, please go ahead.
Yeah, I hope I'm audible to everyone.
Yes, sir. Loud and clear.
Okay, good morning, Fhno 2021. This is day 2, and we are from Hall B. At the outset, let me thank Alok and Vikram and Vipin and Elizabeth for allowing me to chair this session. Dr. Satish and I were supposed to co-chair with me, but he's got stuck up in an emergency, so I will be chairing this session myself. And welcome the speakers. We have a beautiful topic today morning. It's about the emergencies in head and neck, covering both the bleeding, the airway, dysphagia, as well as the neutropenia and the chemotherapy toxicities. It should be an interesting topic, and we have some very good speakers. I think the first speaker would be Dr. Harsh Thar, and then the others can take up one after the other, and we can have a small question-answer session if time allows. So Harsh, you start off the morning session today.
Yes, sir. Thank you so much for the kind welcome and the introduction. A big thanks to the Fhno, Vikram sir, and the entire team, Dr. Elizabeth, Dr. Vipin. And thank you for promoting me up the order and letting me open the session. Very much feel like Rory Burns facing Pat Cummins on day 1 of the Ashes. So the topic that I will be dealing with is bleeding in advanced head neck cancers. This, of course, is a very vast topic in itself, and I will be highlighting on the major points and the philosophy of treatment. Right, it's a complication that actually no surgeon can escape, or no head and neck oncologist can escape. It's a dreaded complication, happens to all of us. It is the biology of the disease, the natural tendency of the disease that brings us face to face with this kind of a complication. So there's no avoiding it. Practices across all centers are varied. There will be different protocols in different centers based on the availability of infrastructure and whatever expertise is available. And when one sits, look at literature actually comprises mainly of small retrospective series, and thereby which coming up with a very well-formed consensus or a very widely formed consensus often is not possible. One has to tailor-make treatment to the individual patient. And most importantly, this scenario is complicated or made more difficult by the fact you have to assess and act fast, think on your feet, take in all factors into consideration all at once, and then proceed with the management. So what scenarios are we actually looking at? We're looking at the treatment naive scenario where a patient commonly presents to us with a bleeding tumor. Of course, this is the most least of all the different scenarios. We see this the most least in our practice. Most commonly, what we see is post-treatment, post-surgical or post-radiation complications in the form of hemorrhage. And palliative or the unresectable scenario is the one that we most commonly face and the one that merits most discussion. The treatment naive scenario we will not discuss much because it's very rarely that a patient actually presents to you with a very large bleeding mass. Most commonly it's a tongue cancer or an oral cancer. Of course, there might also be lesions of the maxilla or the paranasal sinuses. And here it is the management is either one of two. You either go in and ligate the culprit vessel. For example, if it's a bleeding lesion of the tongue, you'll probably enter the neck into lingual artery ligation or the external carotid ligation, many times with the tracheostomy. Rarely enough, if one has already staged the patient prior and you have all the investigations and the patient can be taken up for emergency radical surgery, many times the treatment for the bleeding itself it becomes the actual curative surgery for the patient if that is allowed. But of course, this is very, very rare in day-to-day practice. Treatment complication, surgery and post-radiation blowouts. So surgery, this is often what happens. You've done a beautiful thyroid. This was actually a thyroidectomy with tracheal resection anastomosis. The patient bled on day 1. The most common finding that you get is a lot of clots. The principle here always is securing the airway and circulation first. That is paramount, because unless the patient is stabilized, one cannot go ahead with the emergency management as well, especially the airway. Again, access and exposure. Neck dissections, the most common source normally is the transverse cervical vessels, followed by the external jugular vein. And of course, there's a higher incidence in prior irradiated patients. Tips and tricks for the young surgeons: always get help. Whenever in this kind of a situation, the first thing that you do after securing the airway and arranging blood and arranging the theater is get help. That is what is going to actually get you through the procedure and be safe for the patient. Warm saline irrigation many people use, so that there is something called the diving phenomena. We use it often when we are doing endonasal surgeries. Warm saline irrigation, you're able to identify the flow of the vessel, the flow of the vasculature, and thereby focus, zoom in, and ligate the culprit vessel. During the procedure, it's important to maintain an optimal blood pressure, because many a times you have a small oozing vein, if you're not able to identify the pool of blood, and maintaining an optimal blood pressure will help you to identify the vessel. And of course, we also use the Valsalva very commonly. Very often we see post-thyroidectomy bleeds. This is a large analysis of the UK registry of the endocrine and thyroid surgery. 39,000 thyroidectomies were analyzed. The reoperation rate for bleeding was quite low, 1.4%, but you see the actual number, almost 450 patients over a period of 14 to 15 years. And on multivariate analysis, the following factors came out which actually impacted a higher rate of expiration: increasing age, male gender, resurgery, as in something like a completion or a redo surgery, total thyroidectomy procedures, surgeon volume, or as is obvious, it had an inverse relationship with surgeon volumes. But then again, if you see, the moment the surgeon volume threshold crossed 4 to 8, it plateaued, which means that even with experienced surgeons also will face this complication. Retrosternal goiter and nodal dissection, all of these were significant on multivariate analysis. Very important in today's day and age, the oropharynx. No talk in head and neck is complete if we've not talked about robotic approaches to the oropharynx. So the vasculature here again is quite intricate. You've got blood supply from the facial artery, the tonsillar branch. You've got supply from the lingual artery. At times, you may even need to ligate the superior thyroid, but that is very rare. This is the axial view, and one can see how the branches of the facial artery are very closely related to the superior and the middle constrictors and the tonsillar region, thereby which it's imperative that these vessels are ligated. This again is a large series from Eric Moore's group from the Mayo Clinic. Chart review of 906 patients treated for transoral surgery, not just robotic surgery, but also 2LM, transoral laser surgeries. 15.6% underwent a carotid system vessel ligation during surgery. That means that not all of them actually underwent a simultaneous vessel ligation. 5.4% had postoperative hemorrhage, and of this, 67% underwent a surgical exploration. In their series, there was no significant difference in post-op hemorrhage between those who underwent a simultaneous ligation versus ligation later during the exploration. However, the benefit of intraoperative ligation was seen in patients who were post-radiation. That was not statistically significant. So, tonsil, oropharynx, these are important areas. Of course, the oral cavity as well. A few snippets: importance of vessel handling during surgery. This was a rare case of an anastomotic site pseudoaneurysm, the stump of the facial artery that you can see here. And a likely reason postulated was use of monopolar diathermy at the vessel wall. So obviously the plastic surgeon was very angry with the head and neck surgeon when one had to explore this patient on the 7th post-op day. And this is an enhanced view, as you can see here. This is the posterior belly of digastric, which had to be sectioned to gain control. This is the enlarged aneurysmatic stump of the facial artery. This clip here, this actually is the pedicle artery which has been clipped, and this was the whole scenario within a pool of blood. So vessel handling definitely is very important. What one should do is, either use Liga clips or use a bipolar when one is handling near the important vessels which are going to be used for anastomosis, and not monopolar cautery, which many people tend to use. Beware of on-table surprises like a prominent carotid knuckle or even a high-rising subclavian. Special scenes like the ITF, of course, with the compartmental excision where you're not cutting through muscle, the incidence of bleeding is less, but of course there is a lot of bleeding at the skull base. Various techniques are used to control that bleeding, and it's important that one has ensured proper hemostasis before closure or before handing the case over to the plastic surgeons or doing the reconstruction when we are doing the reconstruction ourselves. The central compartment in thyroid is another notorious area. Many a times you end up doing a long thyroidectomy, a total thyroidectomy started with central compartment nodes, bilateral neck nodes, and then it's often helps if there is a second surgeon who takes a look at the end of surgery rather than the primary surgeon, because whose eyes are tired and who's not mentally in the zone. So getting additional help and support and getting verification that what you've done is complete, your hemostasis is secured, that always helps in these post-operative situations. So the recurrent and metastatic setting, this is a very good review by Robert Ferris's group, and it examines data from institutional database from Milan, as well as the market data source, that's the Truven Market Scan database from the USA. And what they were exploring basically was the association with bleeding with targeted and anti-EGFR therapy. And it was saying that there was a higher incidence with age more than 65 years, some association with anti-EGFR agents, but numbers are too small to derive reliable conclusions. Greater incidence seen during the first few cycles of chemotherapy, and a higher incidence of major hemorrhage if there have been instances of minor bleeding prior to the initiation of chemotherapy. As we can see from this table, that the first bleeding episode was most common with chemotherapy rather than just anti-GFR therapy, and first cycles were most commonly associated with bleeding as compared to second, third, or fourth line. In the palliative setting, where control of neck vessels is operated by the presence of disease, one looks towards interventional radiology. However, here again, securing the airway and ensuring hemodynamic stability is again very, very essential. I keep reiterating that point because that is something that we tend to miss. Data from the Tata Memorial Hospital, 26 patients over a period of 5 years who underwent palliative embolization. Most common sites embolized were the external carotid branches, the lingual, followed by the superior thyroid and ascending pharyngeal. Commonly used agents were PVA and gel foam. Obviously, cost constraints are a problem within our country. And bleeding-free period was analyzed and varied from 1 month to almost as large as 21 months. And the main issue here, the carotid blowout syndrome, modern trends in management, a very good review article by Fhno's group. This is the kind of scenario that we often come across and that we dread. Incidence varies from 2 to 4.5% of all head neck cancers. Of course, it is much higher in the post-radiation setting. Radiation doses of up to 70 grays have a 14-fold higher risk of carotid blowout syndrome. A prior neck dissection, especially in R&D, local wound infection, orocutaneous or a pharyngocutaneous fistula post-surgery, these predisposed to a blowout because a lot of damage to the adventitial layer of the carotid, which harbors the vasa vasorum. And importantly, 1-year survival rates for CBS are close to only 30%. It's a broad classification which has been proposed. Patent blowout is where you don't have an obvious hemorrhage. Carotid wall is found to be exposed or bare with minor wall disruptions. Can be found clinically or on imaging. Imaging indicators are presence of air around the wall, abscess or tumor sitting on the wall with fistula formation, and minor leaks on a diagnostic angiography. Category 2 is an impending blowout or a sentinel bleed, which we commonly know as, and that is early hemorrhage, which gets resolved only temporarily. And the third is a upper carotid system hemorrhage, which is a full-blown event, which is rapidly fatal if outside the hospital system. So how do we prognosticate? There are various prognostication factors, especially the tumor size, the tumor site, the age, comorbidities. This was a match pair analysis in the re-irradiated setting by the Japanese group, and they have come up with a scoring system which is based on carotid encasement by disease more than 180 degrees, presence of skin ulceration, and prior irradiation of the nodal basin. So based on this, they've formulated a scoring system which can predict which patients might fall in for a carotid blowout syndrome later on. So again, a reiteration of the same points. The acuteness of the bleed as well as the modality of management that one resorts to also impact your outcome, because there is a higher mortality rate with surgery. So what are the factors that a surgeon or a clinician needs to quickly run through his mind when faced with this scenario? It's the acuteness of hemorrhage and the patient stability. Of course, if the patient is not stable enough to be planned for an endovascular approach, one resorts to surgery. Outcomes, however, are not as great. Angiographic findings, of course, whenever you're faced with this situation, you do a diagnostic angiography. You look at the presence of cross circulation to enable a carotid artery occlusion. If there is good cross circulation, then you will be able to do a complete occlusion of the ipsilateral system. If, of course, there is a bleed towards the ICA and there is not, you don't have good cross circulation, you will have to go in for reconstructive procedures using stents and grafts. Most importantly, what we forget is presence of disease in the neck. We're faced with a situation where you have a blowout, you feel you can go into the neck, but it is often important to check the records whether you will be actually able to access the neck vessels or not. This is a flowchart that we've proposed. So you have a blowout, it's an acute situation, the patient is unstable, surgical ligation, or if the neck is anyways an open wound with the fistula, surgical ligation. Patient is stable, going for an angiography, localize the bleed. If it's the ECA system, we can go ahead with embolization. Of course, there is a risk of CVA, then we may need to stent. This again is a very applicable protocol, quite similar to the one already discussed from the Tata Hospital group. I'm not going in much into it, and this again proposed by the British system. So all of these actually look at whether the patient is stable or unstable. Unstable patients, normally you would go in for surgery. Unstable patients, you would go in for an angio. And here again, they've done a balloon occlusion test.
Just to interrupt, speakers allocated 15 minutes.
Yes, sir. I'm just done. Last slide. Right. So if the ECA is involved and you fail the balloon occlusion test, you need to do a deconstructive therapy. And if you fail the occlusion test, then you need to do a reconstructive therapy. So take-home messages: gentle handling of vasculature, limit diathermy use, high named vessels, double ligate. Always put in adequate vascularized soft tissue cover over exposed great vessels, and suture ligate all branches of the IJV. In the palliative setting, wherever feasible, an endovascular approach is preferred because survival rates are higher. Carotid artery ligation, always call for help. There will be some situations where one may not go ahead with the radical procedure, primum non nocere. It does not do any harm. With that, I thank you for your kind listening. Thank you, sir.
Thank you, Harsh, for enlightening us. This is a nightmare for all head and neck surgeons, a sudden bleeding, either pre-op or per-op. And
Right, sir.
all of us have had our share of experience, but it was very nice listening to your very valid points. Thank you.
Thank you,
We now move to the other complication, which would be the airway obstruction and dyspnea. Narayana will be speaking on that. And then we take the free flap, which Harsh also talked about, and later the neutropenia. Narayana, it's yours.
Thank you very much for that introduction. So I'll move right into the next nightmare that we all face quite commonly. Is my screen visible?
Visible, yeah.
Okay, so my topic is airway obstruction and dyspnea in advanced head and neck cancer. So it is a very difficult topic to cover in 15 minutes. I'm going to give you a practical overview. So we're going to cover approach considerations, evaluation of a patient with airway obstruction, treatment of acute respiratory distress, and finally establishing a plan of care. So the approach considerations are fairly straightforward. We divide them based on site. So you can see up here, we have the upper third, which is the laryngeal complex, the middle third, which is the most of the trachea, and the lower third, which is the lower trachea and the tracheal bifurcation. So it can be intramural, which is coming from the laryngotracheal framework, or it can be extramural, where you have thyroid. Sometimes you have large retrosternal goiters. You can have extensive nodal disease. So here what we have to remember is the site of compression determines the resistance to mechanical obstruction. So the laryngotracheal framework is cartilaginous, it's rigid, so it is resistant to external compression. It is usually displaced rather than deformed, whereas the posterior part of the trachea is the trachealis muscle. So esophageal cancers can often can often compress on the tracheal lumen far before other tumors. So the glottic chink, as we know, is the narrowest part of the airway, and this is often worsened by cord palsy, especially in laryngeal cancers. Tumor biology is also important. Squamous cell carcinomas tend to grow into the airway, whereas chondrosarcomas and adenoid cystic tend to grow along the airway and often present later. It's really important to think of underlying respiratory disorders like asthma and emphysema, which can complicate the presentation. Another approach consideration is a disruption in the normal airway physiology and reflexes. This is something that we don't really think of often. So we have multiple physiological upper airway reflexes like apnea, swallowing, laryngeal closure, coughing, expiration reflex, and the negative pressure reflex. So many of our patients have these reflexes abolished either due to pain or nerve dysfunction. You can have nerve invasion by the tumor. You can have radiotherapy. So many of our patients have aspiration. So this aspiration is often complex and multifactorial. Just as an example, if you have a patient with a laryngeal cancer, they have reduced swallowing. There's pooling of saliva and food in the pyriform sinus. You have a reduced cough reflex. And finally, you have airway spillage and aspiration. This tolerance to aspiration is highly variable depending on the patient's pulmonary reserve. So if you have a young, fit patient, they can tolerate aspiration. But if you have an elderly patient with a poor pulmonary reserve, they're likely to develop aspiration, pneumonia, and sepsis. So when we look at the approach considerations, we have to decide when to intervene for a patient. So there are two aspects to that. The first aspect is airway inadequacy. So when we think the patient is not able to inspire enough air to maintain homeostasis, and the second is airway protection. So the patient's unable to protect the airway from secretions, from food, and from other things that should not be in the lungs. So when we look at airway inadequacy, first, always important, make a basic clinical assessment, look at the patient for tachypnea, accessory muscle use, chest indrawing, and rapid breathing. So all of these are compensatory measures. So depending on how well the patient is able to compensate, we'll see a difference in their pulse oximetry. So if they're well compensated, we have to consider that once these compensatory methods exhaust or the patient is unable to compensate any further, they're going to worsen. Typically, stridor or noisy breathing, we see when there's a 50% reduction in the airway space. So we always have to take stridor very importantly. Arterial blood gas can also show us hypoxia. It can show us respiratory acidosis, and it can also show us the compensatory methods by the body. When we look at airway protection, we always have to look at symptoms of aspiration. So very often, if you ask patients, they have wet cough, especially when they're swallowing. They can have repeated chest infections. They can have mild or severe infections requiring hospitalizations. When we image them, we do either a chest X-ray or a CT thorax. Typically, you have the posterior segments of the upper lobe or the superior segments of the lower lobes that are involved, and you can have ground glass opacities. So when you have mild to moderate aspiration risk with a decent pulmonary reserve, you can look at conservative measures. So you ask the patient to do swallowing therapy, you ask them for compensatory head measures, head and positions while swallowing, you ask them to change the consistency of their diet. But if you have a severe aspiration risk, you have to protect the airway either through intubation or tracheostomy. So where you do which, we'll go into next. So how do we evaluate? You can do a video laryngoscopy or a bronchoscopy. So that gives us a good visual inspection of the airway, you can look for structural or functional obstruction. You can look at the glottic chink. You can find vocal cord palsies. It's important here to look for aspiration and penetration. That's something we often miss. Aspiration is when you have the saliva which crosses the level of the glottis, and penetration is when you have saliva at the level of the glottis. So that's something we don't look for very often. Laryngospasm and bronchospasm are very dangerous. So if you think the patient has a risk of that, do a very gentle evaluation, either in the operation theater or don't do it at all. CT and MRI help us identify the site and the severity of the obstruction. It helps us stage the disease and come up with a definitive plan. So our airway management in the acute setting has to be in sync with our treatment plan. So if you are planning to do a tracheal resection, don't do a tracheostomy if you can avoid it. Try and hold on until the definitive surgery. Similarly, if you have a palliative patient, hold off doing a tracheostomy as long as possible because it really impacts quality of life. Video fluoroscopy or modified barium swallow, it's good to identify aspiration and it helps us understand the etiology. If you have a patient on swallowing therapy strategies, you're giving them different swallowing exercises and things like that, VFS can help you see if there are any improvements with the therapy. So that's another important thing for aspiration. Pulmonary function tests are often difficult to perform when the patient has an airway obstruction. But if you really need to, there are tests that you can do like DLCO and ventilation perfusion scans. Just tell us that the patient has an underlying lung disorder, and that helps us plan the definitive management. Sorry. So we next move on to the treatment of acute respiratory distress. So the first thing we have to do is we have to look at the chronology. We look at whether it's acute, chronic, or acute on chronic. Most of them are acute on chronic. The patient will have an upper respiratory tract infection on top of a laryngeal cancer or something like that. So if you can tide over the acute on chronic symptoms, through nebulization, through oxygen and things like that, you may not need a surgical or an anesthetic intervention. You have to look at the severity, like I said, and you have to look at aspiration. So if you have severe respiratory distress or aspiration, you absolutely need to intervene immediately. So there are a number of approaches that we can look at. Thrive is one. So Thrive is transnasal humidified rapid insufflation ventilatory exchange. It's relatively new. It's used in microlaryngeal surgery. So this is through nasal cannulas, you can deliver up to 70 liters of oxygen per minute. So this is useful if you want to avoid intubation upfront, or you're not sure what the situation is, you want to examine under anesthesia. If your center has this, Thrive is useful. It can be as a stopgap. If you're going to need a definitive intervention, you should intubate the patient wherever possible. So you need a good anesthetic backup. An experienced anesthetist is always important. Next is tumor debulking. So this is a peculiar situation in laryngeal cancer, where if you have a bulky supraglottic or a glottic cancer, you are doing a laryngoscopic biopsy. If you can debulk the tumor, you may be able to avoid a tracheostomy. So you basically remove the proliferative parts of the tumor that are obstructing the airway, and you may be able to establish the airway and prevent a tracheostomy. If none of those things work, the patient has trismus and other difficult access, awake fiber optic nasal intubation is the treatment of choice. So the idea here is you do not give the patient a muscle relaxant and paralyze them. You make sure that you intubate the patient awake so you don't have any issues. If that is also not possible, we've all done tracheostomies under local anesthesia. Often you have laryngeal and hypopharyngeal cancer patients who cannot even lie down. They're completely platypneic. So you may even have to do a tracheostomy in a sitting position. So don't panic, try to keep calm. Tracheostomy under local anesthesia is quite common. The next area is if you have, say, an anaplastic thyroid cancer, or you have an extensive cancer in the front of the neck and you have limited anterior access. So this is another difficult area. Always do structural imaging. Look at the imaging very carefully. Look at where the trachea is closest to the neck. Try and plan your incisions accordingly. Another option is do a cricothyroidotomy if you're not sure if you can do a tracheostomy. So that will establish an airway. You can ventilate the patient for about 45 minutes until the CO2 buildup is requires another definitive procedure. Another option in an anaplastic thyroid cancer is an isthmusectomy. So you remove the isthmus of the thyroid and that gives you access to the trachea. In these anaplastic thyroid cancers, you may need a longer tracheostomy tube. So you have 110 millimeter tubes, which are longer. So they will go past the tumor into the trachea, or you can even use an endotracheal tube. If none of these work, if the obstruction is lower down, you may need a bronchoscopic intervention. So there are a lot of good bronchoscopic interventions. You have stenting, you have lasering off of the tumor, you can have balloon dilatation, you have microdebriders. So generally we preserve these for palliative intent. So when you know that these tumors are unresectable, you cannot do a tracheal resection, you can't do anything surgical, then you do this, you debulk the tumor, you put in a stent, and you possibly combine that with radiotherapy, and it lasts as long as it lasts. So generally, we don't do a lot of these procedures if we are planning for a definitive or a surgical intervention. Here are some interesting special cases. So we've all seen retrosternal goiters. So what do you do when you have a massive retrosternal goiter? So you have a retrosternal goiter that's going past the arch of the aorta, and you're not sure if it's going to compress the airway as soon as you induce the patient. So you usually do an awake fiber optic intubation. It's possible most of the time. You can use up to a 5 millimeter, very small flexometallic tube. You may need positioning of the patient. So if it's primarily on the right, you might need a tilt on the patient. If you're worried about a lower airway collapse, don't use a muscle relaxant. So very often, when you use a muscle relaxant, you're worried that the lower airway may collapse. So you can use dexmedetomidine, which is what we use in facial nerve surgery. So you can keep the patient under anesthesia without any movement, but you don't use a muscle relaxant. If the airway is inadequate, tracheostomy may be required early on for these. So in a series of around 17 massive retrosternal goiters that had gone beyond the arch of the aorta, only one had a failed intubation when they followed this. So most of the time you're able to manage. Only one needed a tracheostomy. Very, very rarely, you may need something like ECMO. So ECMO on standby in patients where sternotomy is planned and equipment is available. Tracheomalacia is very controversial. We've all read about it, but I don't think very many of us have seen it. So it seems to be described a lot in the earlier textbooks, but we haven't seen many cases of tracheomalacia, even with massive thyroid glands. Next is thoracic outlet obstruction. You can have it from thymomas, lymphomas, mediastinal masses. Importantly, very often you can have asymptomatic compression of the lower trachea or the main bronchus. So if you give those kind of patients general anesthesia and you don't realize, you can have a fatal airway obstruction. So again, you avoid muscle relaxant. It's important to have a rigid bronchoscope in the room. So a rigid bronchoscope may be life-saving. You cannulate the bronchus and you're able to maintain the airway. And you treat the underlying disease with radiotherapy, chemotherapy, or steroids. So I know I've talked about a lot. I'm not sure how much detail I could go into, but basically we have to establish a plan of care for each patient. So it's for any subsite, whether it's larynx, oropharynx, thyroid, oral cavity. So we decide, is the disease locoregional confined? Is the patient going to tolerate therapy? And what's going to happen to the airway with therapy? With radiotherapy, is the airway going to get worse? Is it going to get better? And how do we mitigate that? We have to manage secretions and aspirations. This is how we can lose patients after doing a wonderful surgery. Patient dies of aspiration pneumonia. Timing of the tracheostomy is very, very important. Delay them if you're planning for delayed surgery as far as possible. Admit the patient, observe them, use all of conservative measures. Similarly, in palliative intent, don't do a tracheostomy until you absolutely need to, because that really causes a reduction in the quality of life. Whenever you put in a tracheostomy, have a plan for decannulation. Unless it's a palliative patient who's not going to survive, always think of what your endpoint is when you're going to remove the patient, because patient's tracheostomy, because it makes a huge difference. So that's my talk. Thank you. I'll take any questions if there are some. Thank you.
Very well covered the stratification of the approaches for dyspnea, especially the aspiration part, which we often don't look into. We always consider the trachea and the larynx to be the source of the patient's dyspnea, and it's very important you do a video fluoroscopy and assess and understand the physiology or the cause behind. We will take the questions later, Narayana. Maybe we can go on to the flap complications by Dr. Malik, and then later on we can go there.
Thank you.
Okay. Thank you. Yes, Malik, you can start off. Your screen is, you can start sharing your screen, please.
Okay, sir. So good morning, everybody. Good morning to Team Fhno also for giving me this opportunity to share my views on this topic. Thank you, Dr. Dham, also for giving me this opportunity. I think I'm visible and audible.
Yes.
Yeah, so the topic given to me is the pre-flap complications and its management. It's a vast topic. I come from Ahmedabad. I work at HCG Cancer Center, and this is my team of surgical oncologists. And the team is very helpful, as Harsh and Narayana pointed out, that you should have somebody with you whenever there are complications. And I'm really thankful to this team to help me out on those situations. While going through this excellent book by Mardini and our renowned Dr. Fu-Chan Wei, I came across this complication chapter. And funnily, they have said that how the editor knows that we are so experienced in complications, So it is kind of a thing that is in a way flattery also. And it's a kind of a thing where self-doubt also comes, that are we doing a lot of complications, or our experience in the complication is too much. But as they have rightly pointed out at the end, is that good judgment comes from the experiences, and experiences come from the bad judgment. So whenever a flap fails, it is definitely a traumatic experience for surgeon as well as the patient. And you always feel that why this has happened to me. But there are certain reasons, and God always says that why not with you? Because if you're looking down to the causes, you may find something, and you may find something to learn also. So there are three phases whenever you are doing a reconstructive surgery, that is preoperative, intraoperative, and postoperative phase. All the three phases are very important when you are looking at complication. First is to plan adequately, so there are minimum chances of complications. Second is the execution, where you take meticulous steps to avoid complications in the afterwards. But even after you have done an exact planning and execution, there are chances that you may fail or you may have complication in postoperative period. So this postoperative care is very important when the complications arise. So we will mostly deal with this postoperative phase here. So whenever a flap fails or whenever there are complications, you have to first identify that what were the causes. There were reversible causes as well as irreversible causes. This irreversible causes of failure or complication, we should be taking care while the planning and execution, so it minimizes the postoperative problems. Postoperative care for any of the flap is very important. Our aims are proper healing to avoid complications and failure. And it can be divided broadly into two aspects: general care and flap specific care. The general care is adequate stability of the patient medically, that is adequate blood pressure, avoiding DVT, and perfuse the patient in a nice way. As we all know, that pain management is also very important post-operatively. There can be certain postural changes with the pain, where the patient is not comfortable, he moves his neck, and there can be a lot of complication due to that. So pain control is also very important. The patient should be adequately perfused, not hyper or hypoperfused. The temperature and posture, as I said, are very important. Mobilization, a surgeon has to give a real mandate depending upon what flap he has done, what is the situation of the microvascular anastomosis, and what is the lay of the pedicle. So that is very important post-operative instructions to be given to the patient. Now, flap related are the two things. One is the flap monitoring, and one is the early recognition of complication. So when we come to the flap monitoring, usually all of our post-operative patients immediate post-operatively goes to ICU or special care or high dependency unit where there is an adequate flap monitoring done. The clinical monitoring has remained gold standard despite of all the available technologies, and nothing is replaceable when a flap is seen by an experienced doctor or an experienced staff. The frequency of immediate post-operative monitoring should be around half an hour to 1 hour for first 24 hours. And then after hourly or 2 hourly for next 24 hours. And then it can be 4 to 6 hourly after that. Someone who is good at that flap monitoring needs to see the color, temperature, turgor, and capillary return of the flap and needs to adequately chart it. There are two aspects, scratch of the flap and prick of the flap. I think both are fine, and wherever you are comfortable as per your institutional protocol, it should be used. As I said, charting is very important because somebody coming after that first observer needs to have an objective result of that, and a good chart of all these parameters are really essential. Nowadays, photographs and with good mobile cameras, with good exposure and good photography, they become a valid objective point to compare your flap in future and can be put on your groups for the future references also. Post-operatively, avoid compressive dressing, avoid pressures and tight sutures. It may actually compress your flap or don't allow you to observe the flap. So keep that flap very visible in front of your eyes. Now, there are certain situations when there are buried flaps. So it can be utilized, monitoring segment can be utilized, or newer devices like Doppler, etc., can be used when the flap is buried. These are the issues which one will like to avoid while monitoring the flap. That is, inexperienced staff, flap is not visible, or the flap is buried, but the buried monitoring device probe sleeps or compresses. We had been victim to these problems in past, and the buried devices are also needed to taken with a pinch of salt. Post-operatively, whenever you are utilizing Doppler to visualize the vessels, the operating surgeon should be with the sonologist to tell them what are the vessels you need to look at. Avoid tight closures, hematomas, and compressive dressing, as I mentioned previously. A normal flap is of normal skin color, warm, and normal turgor with bright red blood on scratch. And the best time to have a standard benchmark flap scratch test is intraoperatively once the surgery is concluded. And that should be the benchmark which to be compared for the future scratches. Vascular compromises are the most dreaded complication which occurs in the immediate postoperative phase, and first 12 to 24 hours are the very important hours. And usually this compromises or this problems happens most of the time due to technical problems. So it is usually the intraoperative complications which we were not able to find out or we were not able to notice, and that slowly stages in and shows the signs in postoperative phase. So you need to be practical, you need to be very objective, and if there is a fault on the technical side, you need to accept that and clarify that and remediate that. The capillary return, scratch test, and Doppler test of the vessels is useful sometimes, and the operative surgeon should be with the sonologist, as I said, to figure out where the vessels are. And As soon as you find out that this flap needs to be explored, do not waste time, because these are the golden hours to salvage your flap. Here are certain vascular complications, as in the figure 1, you can see that the edge of the flap is kind of congested. In 2, you can see the venous congested flap. In 3, you can see a lot of edema, which is going to cause the venous congestion of the outer pedal. And in the figure 4, you can see it's a arterial complication and the flap is pale. So a pale flap is usually with arterial thrombosis, or it can be hypotension, or it can be vasospasm or external compression or kink of the mechanism. Here you need to identify the reason and correct the reason. And if you really zero down to the arterial thrombosis, the patient needs to be taken into the OT and do the necessary anastomotic corrections. In a congested flap, usually all the external compressions and kinks and hematomas can be the cause. First, try to rule out those complications. And after that, if you find that this is the venous congested vessel of your flap, you need to take the patient in and do the remedial measures. Anticoagulants and other agents, it's open to debate. There is nothing still very concrete to support or to deny it. It mostly depends upon your institutional protocol. But at the same time, remember that more anticoagulants can cause more bleeding, so less is usually more. So all the problems of general complications of prolonged surgery should also be at the same time seen while your flap is having some complications. Many a times this cardiovascular, respiratory, or vascular problems can actually mimic like your flap complication, or can be the cause of one of the cause of your flap complications. So you need to correct them also. Don't just look at the flap, look at the entire patient at the same time. So these are the 13 steps which are recommended by Fhno and Wei, and they are very important. That it is very important to recognize the existence of the problem. Then you need to diagnose the problem. First, exclude, is there any external problem or not, like compression, like posture problems, kink, which can cause the complication. Then you have to decide the definite decision for imperative surgical intervention. Here, you need to be very fast in your first 4 points because the golden hours are rushing. Then you need to inform the patient and family about the problem and need for the surgical intervention. You have the proper consent for the operation and explain the patient and the relatives all the possibilities of the outcome. You need to prepare your OT staff also. Many times, a lot of back-to-back OTs are running, and you may not find an empty OT or an available operative staff. So you need to side by side run all these errands and inform the operating staff and prepare your operation also. Pre-operative workup is also required. Are you going to need any fluids or any blood products or not? You need to prepare them also at the same time. Transport the patient in a proper position with preparation to your OT. In the surgeons, if the surgeon performing the re-exploration and the initial flap surgeon are different, they must communicate. And this is very important because only the operating surgeon actually knows, and he most probably knows in the back of the mind that where the problem has happened. So because of an experienced microsurgeon usually has an intuitive suspicion about what might have gone wrong. And the operative intervention is the last portion where the exploration, diagnosis, and solution are achieved. So all 13 steps, one by one, are very important whenever you are having a flap-related complications. We come across delayed complications of the flap also, even if the entire sequence and entire post-operative care has gone good. Here is the flap where the flap is very excellent. The flap was explored, reanastomosis was done, but then there was a fat necrosis and the patient ended up like this. A vascular compromise, which was corrected, but the skin sloughed off, and ultimately the patient ended this. Donor site morbidities are also very common, as well as such complications where the flap is either inadequate or there are certain problems of hardware. But these are all late complications and situations needed to be handled with a tailor-made approach for each of the patient. But important is that early diagnosis, rectification, prevention of failures, and discuss your complications with your colleagues. So you will learn more about your results and you will be able to tackle your complications in a better way. Thank you.
Thank you, Dr. Manlik, for sharing your experience. This is a huge topic, I understand, and it's difficult to shorten it within 15 minutes. But yes, I think one of your important take home, which I felt, is that teamwork. You should have a good team whenever you're going into these kind of complications handling, and the same team or the same surgeon addressing the issue is very important. We will take up the questions later if there is time. We now move on to Dr. Aditya for the next part, the last speaker of this session. Dr. Aditya, kindly take over your slides. Share your slides, please.
Thank you. I hope I'm audible and my slides are visible.
Yes, you're audible and your slides are visible.
Thank you. So I congratulate the organizers on organizing this fantastic event on such a under such challenging circumstances, and thanks Dr. Vikram for having me on board. So febrile neutropenia is something that all oncologists need to know a little bit about, because this is one of those true emergency in medical oncology, and this is also one of those areas wherein simple institution of antibiotics within time can and will make the difference between life and death. So starting off with some introductions, fever during chemotherapy induced neutropenia is what is febrile neutropenia. The incidence is less, especially if we talk about the older era in the treatment of head and neck cancers. More often than not, that involved treatment with surgery or with radiation with a mild dose of concurrent chemotherapy. So febrile neutropenia was not something which was dealt with that much by teams which used to deal with head and neck cancers. To define, fever is defined as any temperature one short of more than 101 degree Fahrenheit or a sustained temperature above 100.4 degree Fahrenheit for over 1 hour. Neutropenia with a neutrophil count, absolute neutrophil count of less than 500 or expected to fall below 500 over the next 48 hours. So in which setting do we see these levels of neutrophil counts? Whenever we try the multi-modality approach to treatment of head and neck cancers, especially when we are dealing with fairly intensive neoadjuvant chemotherapy protocols like a DCF protocol. Now, DCF is a chemotherapy regimen with more than 20% risk of neutropenia, and when a patient is on that particular protocol, we need to be aware that this can be one of the possibilities. So the cornerstone of treatment of febrile neutropenia is risk assessment. We need to understand if it's a high-risk patient or a low-risk patient. For example, if a patient is on concurrent chemoradiation and if the patient is getting only cisplatin, unlikely that there will be severe neutropenia or prolonged neutropenia. In such a scenario, oral therapy might be enough. However, if a patient is on an intensive IV chemotherapy protocol, or if the patient presents with hypertension, pneumonia, or new onset abdominal pain, that's when we know that it may be a high-risk patient and we may need to hospitalize. So this slide, I want to spend some time on this because this is the MASCC risk index scoring. It's important for us to, it's impossible for anybody to remember this, but have this app on the phone. And if we can put in the risk factors, that can make us decide almost on the spot whether the patient is high risk or low risk. So if we try and look at certain characteristics which are seen in head and neck cancer patients, if a patient has no hypotension at presentation, or if the patient does not have COPD, both of which are unlikely in head and neck cancer patients, this is the weightage that we give for it. If the patient is dehydrated, if the patient has got any other previous documented infection, again, that has a risk scoring to it. If the patient needs IV admission, that is an inpatient admission, that's also again a risk scoring to it, and obviously the age more than 60. So when we tabulate all of this, and if the risk score comes to less than 21, we know that patient needs to be admitted and needs to undergo intensive protocol. So at diagnosis, so whenever the patient presents to us, the most important thing to do is routine CBCs, RFTs and LFTs. But apart from this, we need to send at least 2 sets of blood culture. I emphasize it has to be 2 sets of blood culture, and if we are suspecting any other site like urine, stool or sputum, we send those cultures as well. Chest imaging is done only if there are any respiratory signs. If a patient has a central venous catheter, then 1 culture has to be picked from that. But if it's only a peripheral venous line, then 2 sets from there. The first step in the treatment of febrile neutropenia is empiric antibiotic therapy. We do not wait for culture reports. Patient is neutropenic, patient is at a high risk of developing febrile neutropenia, we start straight away with antibiotics. More often than not, monotherapy is what is preferred. And if we are doing monotherapy, we would prefer to add an anti-pseudomonal beta-lactam agent like piperacillin tazobactam or cefepime or carbapenem, which can be used. Generally, we would not want to give gram-positive cover, but there are mitigating circumstances. If a patient has a central venous catheter, and if the patient is hypotensive or severely tachycardic, that might be one of the chances that patient may have a MRSA. So in a MRSA, we need to put vancomycin, teicoplanin or linezolid. If a patient has had a previous documented ESBL infection, then we straight away start with carbapenem and we de-escalate rather than going on to the escalation process. Same thing with colistin also. If a patient has a previous documented ESBL infection and the patient comes to us in a very sick state with hypotension requiring supports, we straight away start with colistin and then try and de-escalate once the patient is stable and once we have the initial cultures with us. So the empiric antibiotic therapy for low risk patients are the ones that we manage on an outpatient basis, and we can transition them from IV to oral, and usual combination is ciprofloxacin and amoxiclav. We don't use levofloxacin so much these days. That's because there is a risk of mucositis also. However, if the patient has persistent fever or signs of worsening, then hospital readmission is needed. The first step, most of the times, most clinicians are able to do, but where we may falter a little bit is modifying the antibiotic therapy. So we keep reassessing the patient. If after 2 days patient fever has subsided, the cultures are clean, then that's a different path that we take. But if the patient for some reason has not had a fever which is subsided in 2 days, then we definitely need to add gram-positive cover. Along with that, I would also prefer that if we wait for about 4 to 7 days of fever before we add any empiric antifungals. I know with during this pandemic, antifungal usage has completely skyrocketed, but there are specific criteria for using empiric antifungals. So the duration of antibiotic therapy is usually dictated by the organism and by the site. A good thumb rule is that we continue antibiotics till the neutropenia resolves. So at least till the neutrophil counts pick up above 500, we definitely continue antibiotics. Antibiotic prophylaxis is something that is not very commonly done in today's day and age, especially not in patients with head and neck malignancies, purely because it does not work. And in fact, there is a tendency sometimes to use levofloxacin as a prophylactic agent, but when we do that, there is an increased risk of oral mucositis related invasive strep evidence organisms. So prophylaxis is not routinely recommended for low risk patients. Empiric or preemptive antifungals, this more or less done only in patients who remain febrile after 4 to 7 days of broad spectrum antibiotics but are clinically stable. If we are not able to get any of the signs of preemptive fungal infection, then we may have to withhold the antifungal treatment as well. Empiric or preemptive antifungal treatment is a no when we dealing with low risk patients who are on less intensive chemotherapy protocols. Antifungal prophylaxis is almost never recommended in this setting, maybe in hematological malignancies, but definitely not in our set of patients. Antiviral prophylaxis, again, a rare scenario to use antiviral prophylaxis is if the patient has had a previous documented zoster infection. But if there is no documented zoster infection, then again we can avoid use of antiviral agents. It is very important, and I'll spend some time on use of hematopoietic growth factors. Patients who are on an intensive therapy like DCF, they will have a risk of febrile neutropenia of more than or equal to 20%. So either we use a prophylactic pegylated GCSF or a PEG GCSF, or for whatever reason, if we have not used that, then definitely if patient does come with febrile neutropenia, we need to start growth factor support for them. CLABSI is another thing that we have to deal with, because most of the times DCF protocol is given via a central line. CLABSI is basically central line associated bloodstream infections. In such a scenario, it's important to take culture from two sides, both from the central and from the peripheral. That is purely because there is something called the differential time to positivity, wherein more than 120 minutes difference has to be there in the growth of organisms from simultaneously drawn cultures. When do we remove a catheter? There are specific guidelines for removing central venous catheters if a patient has a documented Staph aureus infection, if a patient has a documented Pseudomonas infection, a documented fungal infection, or a mycobacterial infection. Only in these settings we remove the catheter. Otherwise, we try and salvage the central venous catheter by putting an antibiotic lock and continuing systemic antibiotics over here. COVID has taught us a lot, especially hand hygiene and standard barrier precautions. I'm sure most of our head surgical colleagues are far better at using hand hygiene and barrier precautions than us, so I won't spend too much time on this. To sort of summarize whatever I have said till now, the first step in febrile neutropenia is trying to risk stratify between low risk and high risk. I repeat, high risk is somebody in whom we anticipate a neutropenic period of more than 7 days, or the neutrophil count dropping to less than 100. In such a scenario, we admit the patient and give them IV antibiotics. Usually empiric antibiotic is a monotherapy. There are certain exceptions to this, especially in terms of severe mucositis or worsening or worse clinical presentation, or indwelling central venous catheter. In case we decide that our patient is at a low risk, then outpatient treatment is good enough. That reduces the unnecessary burden on the healthcare system, as well as unnecessary use of IV antibiotics. In such a scenario, oral ciprofloxacin with amoxiclav is good enough. However, we need to observe for the first 4 to 24 hours in the clinic to ensure that the empiric antibiotics are tolerated and patients remain stable. So patient comes to us with fever and neutropenia, even if they are low risk, we need to observe them for the first 4 to 24 hours and before we take a call on outpatient treatment. In case the next step in the treatment of febrile neutropenia is to evaluate our initial treatment protocols. In case patient has responded to chemo, respect to initial antibiotic therapy, we don't need to do anything. However, if the patient is not responding to the initial 2 to 4 days of empiric antibiotic therapy, we need to escalate antibiotics and add antifungals if necessary. After 4 days of treatment, if patient still is not become afebrile, we need to do imaging like a CT scan of the chest and a serum galactomannan testing. If any of these are indicative, then antifungals is the way to go over here. Let me round off my talk by talking about a little bit of NCCN guidelines. NCCN guidelines talk about the definitions of fever, definition of neutropenia, both of which I've already said. The initial management should, initial investigation should include cultures along with CBC, RFT, and LFT. We risk stratify on our initial evaluation. The MASCC's risk scoring is a very simple calculator which we can have on an app on our smartphone, and we will be able to risk stratify our patients far better with this. Once we are determined that the patient is on low risk, we should not let the patient drift away. We need to follow up at least for the first 4 to 24 hours to make sure that the patient is tolerating the oral antibiotics and there is no clinical worsening. However, if for whatever reason we decide to do IV antibiotics at home. Generally, it is preferred to use a long-acting IV agent rather than a multiple dosing per day agent like piperacillin tazobactam, which needs to give once every 6 hours, in comparison to a carbapenem like ertapenem, which can be given only once a day. To conclude, febrile neutropenia is one of the medical emergencies when we talk about treating cancer patients, and timely intervention with antibiotics is definitely life-saving. I thank you all for patient listening and I'm happy to take questions.
Thank you, Aditya. Thank you for your valuable input on this subject. Like, I understand that febrile neutropenia, the decision would be that whether to go ahead with outpatient observation or indoor admission, and then indoor admission will follow escalation as it progresses, right?
Yes, Dr. Dan.
Yeah. 4-speaker session. First and foremost, I must thank the valuable speakers for sharing their experience and telling us this topic about emergency management, which we face in our own way in the daily practice, and everyone has their own little experience to share. And I have to ask the tech team, is there time for any questions? Is there any option of taking questions and answers from the speakers? Here, or Elizabeth, anyone from the organizing committee? Because I fondly remember.
No, sir, no questions. No questions.
Okay, because we used to have these lovely coffee breaks where we could interact with everyone, but well, those days are far away. I don't know when they'll return, but looking forward to them. Allow me to then end this session and we move on to the next. I can see Professor Madan Kapur is already there on the next session possibly. We'll catch up with all of you. Thank you so much.
Thank you.
Thank you all.
Thank you.
Hello. Good morning, all. Give me a clue when you wish to start.
So we may start.
Can we start?
Yes, sir.
Okay. Well, good morning, all. Once again, it's a special privilege to share this session on salivary gland tumor symposium. It's an excellent symposium, I can promise you that, because the subject titles which have been chosen are absolutely perfect, because anybody who is either learning or wanting to be a better parotid or salivary gland tumor surgeon, these are the questions that he will face every single time. And the panelists and all the symposia speakers will do justice. And I'm sure by the end of this session, everybody will be richer in experience and maybe all your questions will be answered through their lectures. So may I invite the technical staff to start with the first lecture by Dr. R. Ravi. Unfortunately, R. Ravi is indisposed. Unfortunately, he's been hit. So, as they say, he's a run out on the last ball when they just required one run to win. But that's how it goes. But he will still try to come and answer the questions later on. And may I ask the technical team to start? Dr. Ravi is a very renowned cytopathologist in Central India. And recently, he has started his own surgical pathology unit and is awarded by the Indian Society of Cytopathologists by a highly recommended felicitation award. So can I have the first talk by Dr. Ravi?
Ladies and gentlemen, friends, it has always been a matter of great privilege and makes me very happy to address this small talk in front of this august audience. Here, although I'm supposed to talk about parotid in specific, I'm generally going to talk about salivary gland tumors and immunohistochemistry. That always will make all of us understand better in general. In head and neck oncology, which I also practice, most of us end up doing FNACs and histopathology. And the commonest organ which is frequently FNAC'd or biopsied are thyroid, neck lymph nodes, and salivary gland. And also, of course, breast is another commonest organ. But then these are the three organs which are very frequently taken for FNAC or biopsy in most of the centers. In cytology, there is a lot of hair splitting, like for thyroid, there is Bethesda, for salivary gland, there is Milan. These are there because cytology is really not foolproof many a times, but then it may not give the exact histological diagnosis, but then it can put light on ROM, that is risk of malignancy or can commit malignancy, and reports should be in fact user friendly, that is surgeon friendly, so that a meaningful diagnosis can be given, which impression can help the surgeon for further management. In 10% cases, even after histopathology, we need immunohistochemistry. However, hematoxylin eosin is the stain of choice, and it's a gold standard in all salivary gland tumors because there is no tumor specific antigen available for salivary gland tumor. But then many ancillary and many other IHC markers are available, which is of great utility in not only arriving at a diagnosis, but also arriving at the prediction of clinical behavior of this patient after the surgery. So whenever we see any histopathology and especially salivary gland, what are the things we have to look for? First is assessment of cell differentiation. Obviously, whether it is epithelial or mesenchymal or myoepithelial or stromal. Cell proliferation, because cell proliferation will decide whether it is benign or malignant, and if malignant, whether it is going to behave in a milder fashion or in an aggressive fashion. And of course, like I told you, tumor protein expression, that is specific antigen. Within salivary gland, most of the times it is not available, but then still there are instances where we can use certain protein which can be of great utility in arriving at a diagnosis. Like usually there is no issue when you see pleomorphic adenoma, mucopathermoid carcinoma, adenoid cystic carcinoma, or Warthin's in cytology or in histopathology, but in a specific individual or in a specific instance, there is diverse histology, there are variants, etc., and which leads to diagnostic challenge. And in such instances, IHC is of great utility. In WHO, there are roughly 10 benign tumors in salivary gland and 23 malignant tumors in salivary gland. In clinical practice, how do we go about it? First and foremost is assessment of growth pattern. That is whether the tumor is infiltrative in nature or capsulated, etc., etc. Secondly, margins, which is very important, that even if you don't give a very specific, accurate diagnosis, if you give a reasonably correct diagnosis and you can comment on margins or borders, then it is of great utility for the surgeon for the further management. Architecture, yes, to arrive at a histological diagnosis. Cellular morphology and differentiation, again, yes, for arriving at an exact histological diagnosis, because there are certain instances where cellular morphology and differentiation can be of great utility for the management. And stroma, of course, like mesenchymal tumor or myoepithelioma, etc. Again, here it is very important to assess because it can also be of great utility for the further management. So how do we go about salivary gland tumor, whether it is parotid or elsewhere? It is assessment of cell differentiation, that whether there are 4 types of cells in the salivary gland: ductal, acinar, myoepithelial cells, and basal cells. The cells which are inside the lumen are ductal and acinar, and cells which are outside the lumen are myoepithelial cells and basal cells. We will call it luminal and abluminal cells. These are various markers which are available and which are commonly used in salivary gland. I will not go into detail, but I'll just, you can have a cursory glance. In the end, I have given some references which can be specifically looked for by somebody who is interested. This is pan-cytokeratin, epithelial membrane antigen, CEA, then calpunin, then GFAP. But then Ki67 is of great utility, which decides the cell proliferation marker, and it can differentiate between benign and malignant tumor, and it's a good prognostic factor. P53 is a good prognostic factor. HER2 is also of great help in certain diagnosis of non-invasive carcinomas, that is X carcinoma, etc. And of course, alpha amylase, androgen receptors, especially in salivary duct adenocarcinomas. All the 4 types of these cells are pan-cytokeratin positive and epithelial membrane antigen positive and carcinomembranic antigen positive in ductal cells. Acinar cells are alpha amylase positive, but then so many times when it becomes tumor, then so many times it loses its character of staining for alpha amylase. And of course, like I have already told you, there are many markers available for myoepithelial cells, and in a given context, it can be used depending upon the histology. So how do you go about it? See, if you see a lot of myoepithelial cells, then one has to decide whether the tumor, the myoepithelial cells, are they participating in the tumor or only they are part of the tumor. That is, if there are no luminal cell differentiation and there is myoepithelial cell proliferation, then it becomes a myoepithelioma or myoepithelial carcinoma. And if there is no myoepithelial differentiation but display acinar cell differentiation, then it becomes a acinic cell carcinoma. This is a rough way of arriving at a diagnosis. And 70% of the tumors of salivary gland will always show myoepithelial cell differentiation. There are many tumors where you will get both ductal and myoepithelial proliferation. There are certain instances, the list very useful for histopathologists, that there are benign tumors with myoepithelial differentiation, there are benign tumors without myoepithelial differentiation, malignant also likewise. The neoplastic cells from the glands and their luminal surface show EMA positivity, and this is of great utility because once in a while even myoepithelial cells stain positive for EMA and CEA, but then apical positivity decides that this is the tumor cells are ductal cell and not myoepithelial cells. Similarly, acinic cell carcinoma, alpha amylase, like I already told you, is a very specific marker, but it really doesn't help once it becomes a high-grade malignancy. And a recent report says that DOG1 may be of great utility in making a diagnosis of acinic cell carcinomas, but then it is still people are working on it. Myoepithelial differentiation, I have already spoken about it. Calpunin is of great utility. And of course, oncocytic and sebaceous differentiation. This is another headache for all the pathologists. We see plenty of oncocytes. Oncocytes are practically seen in all tumors. And then one has to be histologically very sure, that is conventional stain-wise, whether it is mucopotid carcinoma with myoepithelial cell reach or pleomorphic adenoma with myoepithelial cell reach, or it is myoepithelioma per se. And in these instances, immunohistochemistry comes to your rescue by doing markers for myoepithelial cells and also GFAP in pleomorphic adenoma, etc. Sebaceous differentiation is also seen, and sebaceous difference between sebaceous adenoma and sebaceous carcinoma becomes very difficult, but then that is by seeing the histology on conventional HND, but then in EMA it gives a very classical soap bubble appearance. There are problematic cases are like tumor with cribriform pattern, tumor with clear cell pattern, a tumor which is having both benign and malignant features, undifferentiated carcinoma, NHL, and lymphoproliferative disease. This cribriform pattern, the slide is not come very well, but then here Ki67 is of great utility, GFAP is of great utility in arriving at a specific diagnosis. And of course, like I told you, Ki67 in mucopotid carcinoma, adenoid cystic carcinoma, etc. If you see in this tumor Ki67, which is almost available in all laboratories nowadays, if it is more than 10%, then it is associated with poor outcome. And if it is less than 5%, it usually has a very good prognosis, that is no recurrences. Similarly, P53, HER2, and other markers which I have mentioned here, like BCL2, etc., are of great utility in deciding the risk of malignancy and the behavior of the tumor once the histology is available, so that the clinical oncologist and oncosurgeon can decide the further management after the surgery is done. This is a histology of salivary gland normal. And here in HND, so many times you may not see myoepithelial cell, but it's stained positive with calpanin. This is pleomorphic adenoma, various markers, more of interest for histology. This is from a textbook. And this is hemicopterid carcinoma, which was myoepithelial rich. Is almost, we ended up calling it myoepithelioma, but then we started seeing areas. So here again, more than marker, if you start seeing classical mucopaternal carcinoma like areas, then the diagnosis become mucopaternal carcinoma with oncocytic differentiation. This is one case where it was basal cell adenoma, but see, histologically, HND pathologists would realize it almost looks like adenoid cystic carcinoma, but then Ki67 was less than 1%, and this was a basal cell adenoma. This on cytology also was a great challenge for us. Tumors with both benign and malignant counterpart like myoepithelioma, myoepithelial carcinoma, cyst adenocarcinoma, oncocytoma, oncocytic carcinoma. Here, the markers are available for various myoepithelial cells, etc. But the conventional histology is more important to decide whether it has got an infiltrative border or how it is behaving. Of course, Ki67 and other markers are of great utility. Differential diagnosis of so-called undifferentiated carcinoma and malignant lymphoma, like small cell carcinoma, large cell carcinoma, lymphoepithelial carcinoma. Here, conventional markers are available like CKL, CA, chromogranin, cyanotophysin, etc. And this is routinely done in most of the laboratory and doesn't pose a problem for the pathologist to make a diagnosis, but of course, difficult to manage so many times for the surgeon. Like again, I will not go into detail, but then c-kit is very much useful in adrenal cystic carcinoma with MIP staining and androgen receptors and HER2 in salivary duct adenocarcinoma. It is necessary to fully understand that IHC should be considered a method that can be used to assist the final diagnosis and not that can change the HE-based diagnosis. It should also be recognized that exceptional and unexpected results are often obtained by IHC. Like there are specific chromosomal translocations which can be detected by FISH can augment the diagnostic accuracy and prognostic implication. Concept of high-grade transformation, effective therapeutic management by using molecular technique, etc. is of great utility, and very soon pathologists should not only give a diagnosis on cytology and histopathology, but also if they can comment on ROM the way they are done in thyroid, then it is of great utility, especially if you use cytology, histology, IHC, and molecular pathology. Secretory carcinoma, especially which was previously known as mammary analog secretory carcinoma, is distinguished by a specific genetic mutation, and that can both help differentiate it from similar acinic cell carcinoma and also make it susceptible to certain inhibitors. Like mucopaternal carcinoma, also various genetic abnormalities are described, not done in most of the institutes, but then it is of great utility, or maybe if it can be done, then one can decide on the prognosis part or can guide the patient that how she should be treated. And here also one can also comment on whether the patient is going to have a transformation of low grade into high grade tumor. Salivary duct adenocarcinoma, androgen receptors and HER2 are of great utility. Thank you very much. It's a very vast topic, but it's more of a specifically pathology oriented topic. Thank you very much for patient listening. Thank you very much. Ladies and gentlemen, friends, it has always been
Hello. Okay, can I request now the next lecture? I'm not sure whether you are able to hear me. It is on a very interesting topic, which is the challenges faced in management of recurrent parotid pleomorphic adenoma. And the person who's going to tell us all about it, because it is a very humiliating situation, very embarrassing. In fact, when you do a nice dissection, do almost a decent job of getting the tumor out and all the branches of facial intact, and patient smiling at you, and yet you end up getting a tumor within 17 or roughly thereabout time. Dr. Mudit Agrawal shall elaborate on management and challenges faced in such situation. He's from Rajiv Gandhi Cancer Institute and Research Center and New Delhi. Please, Mudit, go ahead and start the presentation.
Thank you, sir. Technical team, can you start the presentation?
Yes, sir.
Good morning, friends. We need to understand the challenges which we face in the management of recurrent parotid pleomorphic adenoma. So we know the pleomorphic adenoma is the most common parotid neoplasm. And if we do a standard surgical treatment in the form of open parotidectomy, the recurrence rate is quite low. So recurrence rate was quite high when we did enucleation in the tune of 45, that it needs to be avoided. And we are worried about recurrences because recurrences can lead to malignant transformation in 1.4 to 6 to 3%. So what are the time of recurrences? So usually these lesions recur in a very long time frame. So usually they have found that 7 to 10 years it takes for these lesions to recur. And if you do enucleation, then chance of recurrences, the duration is short. Other series have found that recurrences can happen up to 20 to 25 years even. So how does these recurrences present? So it can present in a solitary, a small form. You can see it in MRI here, small one in the parotid bed, or it can be in the multinodular form. You can see one nodule here, other nodules here. So these are the things we need to see when we image this patient. So what are the causes of recurrences? The pathology can one of the causes. One is myxoid type, which is hypocellular and which is associated with thinning of the pseudocapsule and presence of finger-like projections, which leads to high chances of recurrences. And other thing which we need to see is capsular integrity, which during surgery, we have to take that capsule should be not breached while doing surgery. You can see pathologist has to be asked whether the capsule is intact or not. So pseudopodia is one of the projections of the tumor capsule, which you can see, but it's well confined with the pseudocapsule here. But you see the capsule is thin here. So these are the chances here that capsule can be breached while performing surgery. And if this is breached, the chances of recurrences are high. Satellite nodule is a tumor nodule which is present in the vicinity of the tumor itself. You can see it here, but it is separated from the primary tumor by the fibrous capsule. So this is one of the major problems or major, if this is present, the chance of recurrences are high. So we need to manage these patients aggressively. And we need to find out on MRI, as we showed just now, that multinodular recurrences needs to be seen and surgery needs to be planned more methodically in these patients. And if larger tumors are there, the chance of recurrences are also high because of incomplete capsule and satellite nodules in these patients. So tumor spillage should be avoided at any cost in these patients. If tumor spillage happens, then chance of recurrence is 14-fold higher. So margins for pleomorphic adenoma surgery in a primary setting when we do it. So they have found that if tumor is present at the margins, then the recurrence rate is 17.6. But if margin is less than 1 mm also, and tumor is present, then recurrence rate is quite low. So if we take a higher margin, but we do a capsular breach, then recurrence rate is quite high. So one needs to aim at good margins, but one should not breach the capsule at all. So how do we diagnose, how do we do a diagnostic workup for these patients? So one need to do a FNAC for these to confirm whether malignancy is there or not. Secondly, we need to image them properly. MRI is preferable, but a CT scan can be done. So MRI, what we do, need to see whether the lesion which is recurred is solitary or multinodular in nature, whether extension to skin is present, whether deep lobe is involved, parapharyngeal extension is present or not, and if patient has been operated outside. MRI helps in planning from where we need to do it. Where can we do an antegrade parotidectomy or we need to do a retrograde one? So the management principle is to achieve a clear margin. R0, it should be aimed wherever feasible. And when we are near to the facial nerve, one should not breach the capsule. And if a recurrent disease is a unifocal, it can be well managed by the superficial parotidectomy with facial nerve preservation. But if we have a tumor in superficial or deep, large tumor, multinodular, multiple recurrences have already happened, and deep lobe is there, then we need to do a total parotidectomy with or without sacrifice of the branches or trunk with the reconstruction at the time go. And if previous scar is present, which needs to be excised, and soft tissue like masseter, muscle or skin should be resected with negative margins. Post-op radiation may be considered. Follow-up may be done for these patients annually as recurrences happens late. So the schema for management is patient is fit enough and single focus is there, then one need to do a superficial periodectomy with clear margins. If margins are not clear, then we need to convert into total periodectomy. If multifocal recurrences are there, then we need to do a total periodectomy. And if margins are involved or high-risk features are there, when patient might be considered for radiation. If patient is not fit for surgery, then patient can be put on observation or patient can be offered radiation therapy. So extracapsular periodectomy, if is done, is associated with high recurrence rate as compared to superficial periodectomy. So it should be done only in selected patients where the tumor is small and at the margins where you can get a good extracapsular extension, and should be done by the experienced team, but not in myxoid subtype where chances of capsular breach is already there. So facial nerve palsy, if you see in a recurrent setting, we go in a plane which is already fibrosed, already meddled with. So chances of temporary facial nerve palsy in this study was found to 90 to 100%. But it is not the case when we are doing a small recurrences and deep lobe is when the lesion is very well away from the deep lobe. So facial nerve paralysis will not be of such high tune. But in multiple recurrent cases, in permanent paralysis, also rate is quite high. So this data tells us that this patient needs to be counseled beforehand, that this paralysis can happen and we need to take care during surgery. We might need to reconstruct that also. So what are the surgical challenges? We need to plan out whether we can go for antegrade or retrograde dissection of the facial nerve. And we need to avoid the dissected area, and no paralyzing agent should be used while performing surgery. The tools which can help in nerve identification and preservation, first of all, is good anatomical knowledge and experience. Magnification by loop or microscope is used. I usually use a loop, and if required, a microscope. And nerve integrity monitor is a helpful tool if one is having it, or you can use a nerve stimulator as well. An ICG near-infrared camera can be used to unfire the peripheral branches when we're doing a retrograde periodectomy. So one of our patient who had a recurrent tumor which was confined to the superficial lobe. So you can see here, it's one more nodule is present, but it's well confined in the superficial lobe only, and you can see here. So this is the tumor, which is done like an incisional biopsy was done. And we did a superficial periodectomy with excision of the skin with negative margins. And then the skin was rotated by local rotation flap was done for reconstruction. So retrograde periodectomy, we need to identify one of the peripheral branches. Mostly, if tumor permits surgery has been not done, then we follow the cervical branch or a marginal branch, or we can follow the zygomatic branch even. So one of our patient who had a recurrent parotid tumor, and you can see the picture. So in this antegrade dissection would be quite difficult. If you see the CT scan here, you can see that it's a tumor which is there, which is involving the skin, and it's going to superficial as well as deep lobe. So surgery going to antegrade will be difficult. So we excise the skin and we approach in the retrograde manner. So what we did, we identified the cervical branch, which lies just superficial to retromandibular vein, and we then proceeded in the retrograde manner, identified the main trunk here, and then we identified, then further dissection was proceeded. So you can see here, a lot of fibrosis is there here because of the previous surgery, which makes entry into this area very difficult. So retrograde dissection really helps. So this was after full resection was done. So this is the immediate post-op picture showing the mild facial nerve paralysis recovered in 1 month time. So facial nerve may need to be sacrificed if patient is having a preoperative facial nerve palsy, or intraoperatively you are finding that tumor is attached to the nerve or its branches. So if we do that, local control in one of the groups is quite high. So it can happen that we might need to sacrifice if there's a history of multiple recurrences of failed radiation. So we might need to do this for getting a clear margins. So facial nerve monitoring does help in preserving the facial nerve, and the stimulus which we use should not be high. Otherwise, nerve will go into paralysis, and one should use these adjunct very judiciously, as they can give false negative results as well. So one of our patient who had a recurrent tumor in the superficial lobe only, but with skin involvement with multiple nodules, we excised the skin, and in this we used a nerve stimulator, which you can find in your operation theater with your anesthesia colleague, which they use it for putting a nerve block. So this can be used, but the current you have to see that 0.5 to 1 milliampere, not more than should be used wherever you find that difficulty in finding the nerves. So one of the studies which was done using IONM, where you get a mechanical stimulation audio signal and you can find out nerve integrity by Medtronic, and they found out that if you do use a facial nerve monitoring, the average duration of the surgery is reduced, and severity of the post-op facial nerve palsy after total periodectomy is significantly low, but was not found when we do a superficial periodectomy. So, and they found out the average recovery time of temporary facial nerve palsy was significantly shorter in these patients also. So the use of infrared camera in facial nerve is quite new, and it is based on the concept that direct visualization of vasa nervorum is done when IV ICG is done. So I will show you one of the cases which we tried on. So what you can see the marginal mandibular branches after injecting ICG. These are the fine branches. So it helps only in peripheral branches. You can see here buccal branches even. So one needs to be aware of the anatomy where it can be lying. Then one can view these branches, and you can see. But the thing about ICG is that once you inject it, it will stay for 1 to 5 minutes only, and after that you might have to re-inject it. But this really helps you in identifying these fine twigs, especially in a recurrent setting where peripheral branches you want to go for a retrograde periodectomy. So these are the buccal branches you can see here, which lies, and it helps in peripheral branches only because the tissue over them is less. So you can see the buccal branches here. So chances of re-recurrence is also quite high in these cases. One of the series showed that around 40 to 50% recurrence at 20 years is there. So these patients needs to be kept on treatment therapy. I will not go into detail because Dr. Gagan will be covering it, but I need to stress on one of the point that surgery will help these, radiation will only help those patients where you have done R0, R1 resection, not for R2 resection. So to summarize, in parotid surgery, we aim at clear margins, and one should not breach the capsule. And for unifocal recurrences, superficial periodectomy can be done, and multifocal total periodectomy can be done. Facial nerve monitoring usually helps, and sacrifice of the nerve or its branches may be done for getting a clear margins. And adjuvant radiation may be considered in these patients. I thank you all for giving me this opportunity to be with you all. Thanks a lot.
Thank you very much, Dr. Mudit.
Thank you, sir.
Wonderful presentation and touching upon the topics. I think there will be a few questions coming this way.
Yes.
We'll take them at the end of the last lecture.
Okay.
That's okay.
We'll do that. Yes.
Right, Mudit?
Yeah, right, sir.
Thank you very much. Now, the
Thank you,
next topic which is coming, as I said, the selectors have picked up absolutely brilliant way of this panel or symposia, because they're very frustrating and almost devastating at the end of surgery if the facial nerve either has to be sacrificed deliberately or it gets accidentally tangled up in the surgery and you end up getting a facial palsy. Nothing is lost, or not great thing is lost if you are some like Amit Chiram Singh with you, because he will tell you now next, should something have gone wrong and you have got a very sorry figure to cut, how can it still be salvaged? So it's a reanimation of facial nerve after parotid surgery, and in particular, the malignancy. May I request Chiram Amit Singh to start with his presentation. He's an additional professor at the Department of Otolaryngology at All India Institute of Medical Sciences, and looking forward to his lecture for, not just here, but in all platforms. Please go ahead, Dr. Chiram.
Thank you, sir. I'm just sharing my slide. So my topic for this presentation is facial reanimation after facial nerve resection in parotid malignancy. So facial nerve is involved in around 12 to 40% of malignant parotid tumors. But if you see the rate of the nerve, what excised during this surgery is around 48 to 59%. So many of the cases in which the nerve is not involved is also sacrificed. So it's almost around half of the cases where the nerve can be injured or nerve can be sacrificed as a part of the surgery. So what can we do in these patients? So the primary goal for facial reanimation is, first and foremost, is a corneal protection that is important. And second is we need some symmetry of the face at rest. And also if possible, we need to provide smile, both voluntary and possible emotional smile as well. So according to the time of the nerve injury or the nerve palsy, so we can divide into certain timing. If it is injured in the intraoperative period, we can say we can do an intraoperative reconstruction. But if the preoperative palsy is there, or if there is a paralysis is more than 1.5 years, we call it early palsy, and if it is more than 2 years, it is late palsy. Why we give this timing is, if it is more than 2 years, then we assume that the motor end plate goes into permanent damage. So even if we anastomosis nerve and it's not going to function. So when the nerve is excised in peritoneum, we can have certain intraoperative scenarios. There are mainly 3 types. The first is after when the nerve is parotid tumor is excised, we can have the proximal stump as well as the distal stump. Which is the most commonly one which we encounter. The next one is we have the distal stump, but we don't have the proximal stump. This is not that much encountered in the parotid surgery, because we can get the proximal stump by drilling the mastoid tip and getting the facial nerve stump in the fallopian canal. And the third one, if it is a massive tumors, then the distal stump of the facial nerve may not be available for nerve anastomosis. So in intraoperative period, or when we have an early reconstruction, when both the proximal and distal stump is available, this is the best scenarios if we can do a primary reconstruction, anastomosis of the nerve. For that, we need to have a tension-free anastomosis, and we do mainly the epidural anastomosis sutures with a tendon nylon. But if the defect is more, we cannot do a tension-free anastomosis, and then we have to put a interpositional graft or cable graft. The most preferred cable graft, which is locally available, is a greater auricular nerve, but we should be cautious in taking this nerve, because if the tumor is there in the tail of the parotid and we are expecting perineural spread, and then we have to be a bit careful. And then another nerve which is very popularly used is a sural nerve. So this is one such case in which the nerve is excised and a primary anastomosis is done, and we can get a reasonable outcome after even after radiotherapy. So in the intraoperative period, when the proximal stump is not available, what we can do is we can find some other nerve to innervate the facial nerve, the distal stump. So the commonly used nerve nowadays is the mesenteric nerve. We can also have a ghost facial nerve graft, in which we use a long cable graft like a sural nerve. We do an end-to-side anastomosis in the opposite normal branches of the facial nerve to the paralyzed side. Next is the hypoglossal nerve, which was popular in the previous time, either a whole nerve or the part of the nerve, or we can also do a dual innervation, and ansa cervicalis is also described. So coming to the mesenteric nerve, which is one of the common nerve to innervate the facial nerve. Why this nerve is, this nerve contains around 1500 to 2000 myelinated donor axons, which is sufficient enough to power the main trunk of the facial nerve, and it is locally available in the surgical area. Also, the masseter is activated in around 40% of the patient during normal smile. So how do we localize this nerve during surgery is, we can, there is a rough landmark which we have around 2.5 centimeter in front of the tragus and around 1.5 centimeter below the zygomatic arch, and we have to go into the substance of the masseter, and the masseter has got 3 fibers: superficial, intermediate, and deep. This lies between the intermediate and the deep fibers, coming just from the sigmoid notch and towards the angle of the mouth. So this nerve can get a pretty good length if we take the anterior branch, and if we cut it right at the anterior part, and we can pull it out and then suture it to the facial nerve. So this is one such case in which in the post-operative period, we can have a good, reasonable facial tone and a good smile. Though the patient has to practice a lot, because this is not a truly spontaneous or emotional mediated smile, so they need to do a lot of therapy. The advantages of this procedure is it provides rapid tone and motion recovery within 3 to 6 months. Effortless smile without clenching teeth can be achieved in almost 40 to 75% of the cases. The disadvantage is, as I have mentioned, this is not a truly spontaneous or emotional mediated, and though the patient can have effortless or reflexive smile. So the patient requires significant amount of motivations for retraining therapy. The overall time for the nerve recovery is around 5 months. And if you do a selective anastomosis, say zygomatic or buccal branch, then they can have a faster rate of recovery. Whereas if you put an interpositional nerve graft, then it can be delayed. So in our department experience, we have a small series in which most of these patients are not a parotid malignancy, but some jugular tumors or vestibular schwannoma or facial nerve schwannoma or petrous apex cholestoma. The duration, as I have mentioned before, it is from 4 months to about 18 months duration of palsy, and all these patients had grade 6 palsy, and the first mimetic activation occurred around 2nd to 5th month, and during a long follow-up, say more than around 1 year to 2 years, they have a good or excellent cosmetic outcome. Though we can achieve in one patient which has a long follow-up around 30 months, he developed a spontaneous smile too. So another important topic in the nerve anastomosis is the contractile facial nerve. This is the only one which can provide spontaneous or emotional smile in addition to improving tone. But the main disadvantage is if the denervation of the nerve paralysis timing is more than 6 months, then we cannot use this. It has to be less than 6 months. And to do it as standalone procedure, it has to be less than 6 months. So for more than 6 months to 2 years, we can do this procedure known as the dual innervation or babysitter. By this, we put a coarse facial nerve graft from the normal facial nerve to the opposite paralyzed side. And at the same time, we do anastomosis to the trunk with the local innervator. Most commonly is the masseter nerve. So by the time the nerve take to grow, this masseter nerve will take like a babysitting for making the muscle to still function. So what about the effect of the radiotherapy in this nerve anastomosis? Previously, it was thought that the radiation will have a negative effect on the anastomosis. So the they used to perform mainly the muscle reinnervation procedures. But with the more data in this nerve anastomosis with the radiation, there is not much of radiation effect. They still can have a good facial function after nerve repair, even if they receive postoperative radiotherapy, provided they have a normal or near normal function in the preoperative period. So what are the negative prognostic factors of nerve anastomosis? Is obviously the preoperative facial nerve palsy and its durations, and also in the older age group, they have a negative prognostic factor. This is a third scenario in which the distal nerve stem is not available intraoperatively, or we have a delayed palsy. So what we are aiming here is mainly the mid face reanimation, that is a smile reanimation, and the facial tone. For that, we mainly use a functional muscle, which is a regional muscle, or we can also use a free muscle transfer. The regional muscle, which is commonly used, is a temporalis muscle, or the masseter muscle. More commonly is the temporalis muscle. So in the autonomic temporalis tendon transfer, what we need to take is the tendon of the temporalis muscle. We know that it is inserted into the coronoid process, both medial and lateral, and along the anterior part of the ramus. So we can cut the coronoid process and then remove the bone, so we can get a long temporalis tendon. To approach the site for the suturing of the tendon, either we can go through the nasolabial groove, or we can go through the incision of the parotid incision. If the parotid incision is already there, then we can use that to reach this area and suture the tendon. So where to suture this tendon is important. It depends on the patient's smile. Like most commonly is the Mona Lisa smile, then the canine smile, then that smile. For them, we have to fix in certain areas near the commissure. We have to know the vector of the smile when the patient smile on the opposite side, and then according to the vector, we can suture the tendon near the commissure. If the tendon is short, then we can use a fascia lata to augment the shortness of length. So this is one patient where we have done this autonomic tendon transfer. Though she can achieve good tone and some smile, but she need to practice a lot, and this is purely a voluntary smile. So we can also use free muscle transfer, which is a very important topic in this. And the most commonly muscle used is a gracilis muscle, which is sutured from the angle to the fascia over the zygomatic arch. And after the anastomosis, either we can do this procedure as a dual sitter position, or as a second stage procedure. In the first stage, we put this cross facial nerve graft, and in second stage, we do the anastomosis with the gracilis muscle transfer. So what is the difference between this regional and free muscle transfer? There is no difference of the facial features at breast, but if we see the oral commissure movement or excursion, the free muscle transfer does better than the regional transfer. Coming to the upper third reanimation, that is the eye reanimation. What we are mainly aiming here is for the eye closure. Here we can do both the static procedures and the dynamic procedures. And the more common one which is used is the static procedure, that is a lid loading procedure or Godwell implants. So in lid loading procedures or Godwell implant, first we measure the palpebral height, and with using a dummy weight, we find the adequate weight, and by sticking with the two-sided tape to the eyelid, and to know which is the best weight for both the static and dynamic position. And we also make a dental this negative impression of the face upon the dental stone. This is mainly done by our prosthodontic colleague to know the curvature of the eyeball. After that, during the surgery, we put the implant just over the tarsal plate and suture there, and we can get a reasonably good eye closure the important to note is during the sleep, the patient still has to press the eye, because while sleeping, the eye can open up by the weight of the implant. So the mean weight for the implant which we have used is around 1.12 gram, and the implant length is around 17.8 mm. And almost all the patient reported satisfaction with the cosmetic and functional result. So to conclude, there is tremendous progress in dynamic facial reanimation options and the outcome over the past couple of decades. Reanimation procedures are used for intraoperative nerve excision or early palsy, whereas muscle transfer, we use it when the distal nerve is not available or long-standing palsy. Radiation therapy appears to not affect the nerve anastomosis. For eye reanimation, lid loading is noted as the most accepted and rewarding solution. Thank you.
Thank you very much, Dr. Chiram. It was an excellent presentation. And in fact, one could lot of heartening to see that such a devastating complication of parotid surgery can be salvaged and salvaged nicely. Wonderful videos of the girl, particularly younger girl, very nice results of that muscle transfer. Now, the other complication that worries every parotid surgeon is what if this tumor recurs? Either he is unable to get the adequate margins, or maybe he has got the margins and yet the tumor is rather aggressive, and one is worried that would it be possible to have some kind of adjuvant policy to prevent this recurrence in a very unsightly areas, particularly on the face. The second situation where we would like to have some consultation and some help from the adjuvant therapy is the recurrent tumors, because even the pleomorphic adenomas can recur either because of the inadequate surgery in the first place or inherent nature of the disease, or multiple times they can come into areas well away from the parotid as well. We all have seen that after very satisfactorily done parotid surgery, you still have a tumor recurring somewhere in even the lower neck. In fact, I personally have a series of nearly 6 who underwent eventually almost like a radical neck. So in all such situations, we look forward to a gentleman like Dr. Gagan Saini, because he would be probably the best man to help us out. So may I request the tech team, I can't see Dr. Gagan Saini. He's a radiation oncologist from the Max Hospital at Padpadganj in New Delhi. Could we have Dr. Saini presenting his work and his views on management of adjuvant treatment for parotid tumors or salivary gland tumors? There we are. Thank you very much, the techies. And may I request Dr. Gagan Saini to present his views on adjuvant therapy in salivary gland tumors.
Good morning, everyone. Thank you, chairpersons. I'm speaking on adjuvant therapy guidelines for the salivary gland tumors. I'm Dr. Gagan Saini. We have all just understood about various aspects of surgery, and surgery indeed is the standard of care for salivary gland tumors. But the prognosis of these is a complex interplay of locoregional concerns, metastatic potential, which is a result of histology and biological behavior. And that is what we are here to find out, how we use adjuvant treatment to mitigate that. So first things first, the stratification of salivary gland cancers. We have all heard that they are low aggressive and high aggressive, but what constitutes which histologies are low and high is given in this very nice list, which was published in 2021 in a paper on guidelines itself by ASCO. The staging for major salivary glands is not very different from oral cavity cancers in terms of the ballpark numbers of 2 to 4 and greater than 4. And then, of course, T4 are the locoregional structures which make it T4A or B. Even the nodal staging is quite similar to the usual head neck staging. So guideline number 1, post-op RT should be offered to all patients with resected ACC, which is the adenoid cystic carcinoma. This retrospective analysis by Dehanka on salivary adenoid cystic carcinoma, which was published in 2015, they showed that as the stage was progressed, as it was a higher stage, there was a poorer crude survival, and even the margins led to a poorer survival, and this was also relevant for the recurrence-free survivals. While what is most relevant to this particular talk is how adjuvant therapy benefited, and indeed when radiotherapy was given, the recurrence-free survival was statistically significantly superior and also was the loco-regional control. Another paper on adenoid cystic carcinoma, it's a patterns of care study. All papers presented in this are retrospective papers, and that is why this particular talk is important. So for the whole cohort, post-op RT benefited statistically significantly over surgery, and for positive margin, it benefited indeed, and even for negative margin. And that is the reason why we need to give radiation therapy for all patients of adenoid cystic carcinoma, because there is a 10% benefit in T1, T2, and about an 11.6% benefit in T3, T4s, which is significant. But what about other salivary gland cancers? This is a 2015 paper, retrospective analysis of 112 patients, single institution. So without radiation therapy, this is what they have reported, these survival graphs. Here you can see it is T1, T2, and then this one is T3, T4, and then this improves when radiation therapy is given. Similarly, it is for different sizes. They have broken down into 2 to 3 dozen, 2 or more than 3. And this is also benefited with radiation therapy. Another retrospective analysis, 565 patients, slightly old, but it's a Dutch head neck oncology cooperative group paper. And they showed that there is a statistically significant interplay between this, the stages and the histologies also. But what is, again, most important for our analysis is that RT, when added, led to a statistically significant benefit. Another paper, retrospective, and they too showed that in multivariate analysis, there was a lot of factors which played, T stage and grade. But as we were talking about, as we've been talking, the adjuvant RT improves survival, and basically you can see that the hazard ratio is about 24%. So that's what is being seen in most papers, being 20 to 24%, 24% benefit in survival. So this is a retrospective paper, and it can't ever be so powered that it can give you some very reliable results for histologies. But this is what we've been seeing. We are finding it yet again that the benefit is seen or it's tending to happen in all histologies, and that is how we choose to interpret this. What about intermediate grade carcinoma? So intermediate grade carcinoma, this paper explored the impact of adjuvant radiation. So this is retrospective indeed. So there were some patients with positive margins who received RT. There were some with negative margin who received RT, and of course some with positive who did not receive RT, and some with negative who also did not receive RT. So the benefit of adjuvant RT was not seen. So this is how the population has been in all the retrospective papers. But when there was benefit, you could see benefits in most of their previous results that I showed. Here you could not see. Here there is no benefit reported. So the authors, they have also teased out data in terms of negative and positive margins. So when the margins were negative, you can actually see that both graphs are literally riding on each other. There's absolutely no difference. You really don't see such graphs in oncology. However, for positive margin, these graphs break out and there is a statistically significant benefit. So you can see the hazard ratio. This is not crossing unity. So this is benefit. So for positive margin in an intermediate grade, you need to give RT. But when it's negative margin, you don't need to. But what about close margins? So this paper reports the benefit, the recurrence rate in a close margin in an intermediate group. So they report about 10% possibility of local recurrence, and the overall survival, even with that recurrence, is not getting much disturbed. Indeed, the disease-free survival is disturbed. So presently, for close margins, it is not recommended. They do talk about this variant of epithelial myoepithelial carcinoma. I think this is relevant. While it is classified as a low-risk variant, a low aggression variant, but the local recurrence possibility propensity is quite high. So come to guideline point, post-op RT should be offered when it's high grade, positive margins, even for low grade, and perineural invasion, lymph node mets, lymphatic or vascular invasion, T3, T4. Post-op RT may not be offered for intermediate grade tumors, even if with closed margins. So again, I take you back to the same table, and this is a very relevant table. You know, whenever there will be that histopathology report in front of us, we would really like to know which part of the table it falls on. What about management of neck? 22,000 patients, NCDB data, and they reported that there is a good number of occult nodes and occult nodal metastasis seen, and there is a good number of node positive patients depending on the histology, how aggressive it is. And even within the histologies, as the T size was, higher T size led to a higher chance of lymph nodes and a higher grade. This is mucoepidermoid, acinar, then adenoid cystic. You can see that the results are consistently showing that the nodal metastases are increasing. And then this is the carcinoma pleomorphic and salivary duct. Long story short, there is a statistically significantly higher chance of having metastasis as we progress along the T stage. And this is a significant number of metastases. So how about nodal relapse after surgery and post-op RT? This is a retrospective analysis of 250 patients. They were N0 at baseline, and they were treated with surgery, but no neck dissection was done, and post-op RT was given. So those patients who were given elective nodal irradiation, they did, this is the baseline for that. And those who did not receive elective nodal irradiation, they did 20% or 20-25% inferior to the patients who received nodal irradiation. So again, this was statistically significant as well. So ENI is helping these patients because there is a definite risk of lymph nodal metastasis, which is getting mitigated with ENI. What about, so this is another paper, 59 patients, N0. Some of them received elective neck irradiation, some of them received elective neck dissection. And what is important to this discussion is that there was no difference whether they received dissection or irradiation. So guideline point, surgeons should offer an elective neck treatment over observation in clinically negative neck in T3, T4 and high-grade malignancies. And definitely radiation oncologists should offer elective nodal irradiation in case surgery for neck is not being done. Adjuvant RT is also recommended for node positive neck. So what is the role of RT in inoperable tumors? This is again a 2016 retrospective paper in ACTA. And here they reported the benefits, the outcomes of surgery, then surgery plus RT and so on and so forth. But what is important here for this particular discussion is that the local regional control is at 40%, at 10 years for when even surgery is not done. And the survival, cause-specific survival too is, hovering at around 40%. So we are not looking at a very, very, very dismal option here. So radiation should be offered to patients, salivary gland patients who are not candidates for surgical resection. So it's not that some PAL chemo or something should be given. Radiation is having a definitive survival, possibility. So what does the NCCN say? NCCN is endorsing what we've just talked about, T1, T2, to go for resection according to the grade. When it's low grade, then only go for RT if it's spillage or perineural invasion. And if it's adenoid cystic, go for RT anyway. T3, T4, evaluate. T4B, go for RT. They are also talking about concurrent systemic therapy. There's another point coming up. But again, the N0 or N+, they're talking about neck dissection. And then there's these adverse features which we have talked about, intermediate to high risk, close or positive margin, and neural invasion, lymph node mets, LVI, and T3, T4. Radiation should be initiated within 8 weeks of surgery, and particle therapy can be used. However, there's no indication for using heavy particle therapy over photon or electron therapy. So it's not like it should be used or preferred over it, but yes, it can be used like protons. In post-operative RT, the high dose target should cover salivary gland and appropriate nodal levels. The dose should be 60 gray. This is how the neck failure is spread out. So you can see that 5 and level 4 are not getting those many failures. So this is how we should be thinking about the elective nodal irradiation. However, I would give far and wide radiation if the skin is involved, because that's when a tumor is very aggressive. This is how current day IMRT plan looks like. And you can see that the entire tumor bed is being covered, including the base, and you're going right up to the space. It's also going up to the base of skull. So it's a very extensive irradiation with the irradiation of upper levels of the neck as well. Guideline point: in case of perineural invasion, associated nerve should be covered with some elective or intermediate dose. These are the two most important glands: parotid submandibular for parotid seventh nerve, and the auriculotemporal nerve of the mandibular branch. And for submandibular, again, the mandibular branch of the trigeminal nerve, up to the foramen ovale, lingual nerve, and the 12th nerve along the hypoglossal canal. So this is what we localize during radiation. Just give you a little bit of idea. This is a diagram. So this is where the facial nerve will be, and this is the stylomastoid foramen. So we need to go right up to this point. So you can see that for parotid, it's probably not so difficult, but problem comes with submandibular. This is the auriculotemporal nerve. This is how it shows on the MRI. The CT scan, we can't see it. So just to give you an idea where it is, and it's quite well covered in this sort of a volume. But for some mandibular glands, we have to be a little more deliberate, because we have to trace the mandibular nerve, we have to trace the hypoglossal nerve, and up to the hypoglossal canal, right up to here, so that the elective node dose is given. An interesting paper about the impact of radiation on perineural invasion. Very quickly, this is a normal mouse. This is the normal sciatic nerve. This is a positive control. This mouse has been injected. The nerve has been injected with tumor cells. You can see this grown large. This is the mouse, which is the experimental mouse. You have given 8 gray to the nerve alone, and then you have injected the tumor cells, and you can see that the nerve has, fought off, and there's some change in the microenvironment, that this tumor is smaller. So this paper and many other papers postulate that radiation therapy to nerves actually also causes some microenvironment change. So radiation therapy is not just a physical modality, killing or burning. It causes a lot of biological downstream changes, and this paper is kind of indicative of that. It was interesting, so that's why I mentioned it. What about RT in benign disease? Princess Margaret experience, and they showed that when it's a recurrent disease, the benefit is very definitive, and it should always be given in a recurrent disease. However, in a upfront scenario, it may or may not be offered because the difference is not very significant. So they concluded that adjuvant RT in a benign tumor like pleomorphic adenoma, when recurrent, when microscopic residual or gross residual, or nerve involvement, or there's a tumor spill, or it's multifocality. The dose is not this is not the high dose of 60 gray. 50 or 54 gray is good enough. Systemic therapy. This is again a retrospective analysis from National Cancer Database. So they basically analyzed patients who received chemoradiotherapy, and interestingly, the patients who received chemoradiotherapy did worse than the patients who did radiotherapy. This is the unadjusted analysis. They also did some propensity match. So again, the difference was numerically low, but it ceased to be statistically significant. We can always argue that these were patients who were chosen to be given systemic therapy in a scenario where we already know that systemic therapy is not beneficial. So they were probably of a very high risk. So, but the guideline says that we should not be offering concurrent chemotherapy in an adjuvant setting outside of clinical trial. But then clinical trials are happening. There are quite a few of them happening, and they will answer these seething concerns that what should we do in case the tumor is very high risk and all those positive margins and large nodes. And I thank you for your attention. I hope that I've been able to take you through the guidelines and the evidence in suitable time. Thank you.
Thank you very much, Dr. Saini. It was fantastic and very heartwarming to see that so much can be done even in R+. And to the particular comment I liked very much, that you don't see such graphs in oncology often, the one you showed, where both lines are practically overlapping each other. I do not know whether we have time for question, but can you guide me on that? Somebody from the technical team? But in case there is time, I've got one question for Mudit, which I probably sure will be on minds of many. When the pleomorphic adenoma recurs, not in its original site, but at a remote site, maybe it recurs somewhere along the lymph nodes, you feel this is a malignant, and yet the final histopathology comes up at benign, and then you get one more recurrence somewhere else down the line. I mentioned one case where I had to actually do some nodal dissection, like almost radical neck. Can you guide us on that?
Sir, sometimes in pleomorphic adenoma, this dilemma is faced that the histopathology is not consistent with what we see clinically. In such scenario, we go with the tumor board opinion. And what I mean by that is that in such a situation where a pleomorphic adenoma is recurring in the lymph nodes, then it's clear that it's having a malignant potential. And in such a scenario, we should be going in for radiation therapy. Pleomorphic adenoma recurring in a way that it's likely to be malignant. So maybe that carcinoma ex pleomorphic adenoma was not picked up for some reason by the pathologist, but we should treat it like a malignant tumor. And indeed, recurrent pleomorphic adenoma is one of those situations where we should give radiation anyway. They have shown that there is benefit. So this is one scenario where we should be erring on the side of caution.
So there are, as sir is telling, there are cases where pleomorphic adenoma is found in lungs also. So it's basically a variety of carcinoma ex pleomorphic only, where different variety you are finding nodes there metastasizing. So we have to treat it, as Dr. Gunn said, that like carcinoma ex pleomorphic only. This is the variety. Case reports are there.
There was one question which I could just overhear for Dr. Chiram Singh. And in fact, he had done so beautifully that classification of find the distal end, proximal end. But still, there was one question that what will be his personal choice regarding sural versus the great auricular nerve. If he was to be doing, which one would he pick up, and what kind of advice will he give if he has to do multiple grafting, like he has to do 2 or more? Will he sort of divide the nerve into segments, or take something else, like something from the cervical roots in the neck? Is he on the line? Do we have Dr. Chiram? Well, if he's not on the line, I don't see any more questions on the box here. I try one more time. No, there are no questions. So I can hand it over back to the tech team for the next session. Thank you, all the panelists, all the symposium.
Thank you, sir.
You had been all very brilliant. My heartfelt congratulations to all of you. Gagan, Mudi, Chiram, everybody. Ravi is my own team, so I can't thank him enough because I stand tall on his shoulders. So thank you all very, very much. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Dr. Modi, you may start.
Okay, thanks. Hi, everyone. So a great conference. Let me just share my screen. Okay, so you'll have to stop sharing, right? Yes, thanks. We've had a great first half. We had a great day yesterday. At the outset, let me just thank the organizing team for this kind invitation. And without much ado, I'll be starting my presentation. Basically, my talk today essentially is in how IONM or intraoperative nerve monitoring can be used for thyroid surgery, but to great extent the principles apply to all cranial nerve monitoring in any of our head and neck surgeries. So particularly in thyroid surgery, the morbidity being significant, unilateral vocal cord palsy essentially causing hoarseness of voice, aspiration, but it is the bilateral vocal cord paralysis, which essentially is a nightmare for any thyroid surgeon, any head and neck surgeon. It can cause and may lead to a need for a tracheostomy. And there's a lot of literature regarding the course of the nerve, and anatomy takes precedence when one is operating. There is no doubt about it. However, the injuries that happens commonly is not that of the transaction nature. Most of these are invisible injuries which are either due to traction, pressure, compression of the nerve, or some injury from the thermal devices. And studies have shown that more than 75% of these injuries are stretch injuries in nature in and around the ligament of Berry. Typically, how would it happen? You may have an overzealous assistant who's kind of retracting the gland too hard, and one of the nerve, the fibers are tethering the nerve, compressing the nerve, leading to a neuropraxia or worse, a more long-term paresis. Studies show that permanent injuries are somewhere in the range of 1 to 2%. However, this is most likely an underestimate, and we know that the rate doubles when we do a routine post-operative laryngeal exam. A systematic review of 27 articles covering more than 25,000 patients showed an average vocal cord paralysis rate to be about 9.8%. So that's a pretty high number. So how does intraoperative nerve monitoring helps us? Essentially, it clears out the problem that we face, the limitation that we face as surgeons, when we feel that a visually identified, structurally preserved, surgically intact nerve may not be normal. So what we need is a test of functional integrity, and that is what we get from nerve monitoring, where we get visual confirmation. Along with that, we get electrical confirmation. So we know that the integrity of the neural fibers is intact. Now, the way we do it is we have a basic monitoring equipment setup, which has two parts. One is the recording side, which is made up of the endotracheal tube connected to the interface connector box, and it is grounded. And then there is a stimulation side where there is again the monitor and the stimulator probe. So both of these are connected to the interface connector box. So typically the system, there are multiple systems available. Medtronic is the most commonly used system. The NIM3 is a great system designed for essentially ENT and head and neck procedures, and that's how the panel looks like, and it's very user friendly kind of an interface, where what we use is we use a specialized endotracheal tube which has got recording electrodes affixed to it. So the target that we need to keep is that these electrodes need to be in contact to record the signal coming out of the vocal cords. So it is just a touch contact. There are no needles in place. There are other options of needle electrodes too, but that becomes a little invasive. And that's how one may place the tube while doing the intubation before the thyroid surgery. From the stimulator aspect, again, the stimulator probe is connected to the interface connector box. The most commonly preferred ones, and that studies have shown to be very useful, is the PRAS nerve stimulator. There are various others available. However, the PRAS nerve stimulator has found to have the ideal current spread and the sensitivity rates to pick up or stimulate the nerve effectively. Anybody interested, however, in starting new, I strongly recommend that you go through this paper. This is free to download from Laryngoscope. It's a 2011 paper given by the International Nerve Monitoring Study Group. And it focuses on how does one work on the endotracheal tube placement, and also how does one interpret in case of a loss of signal problem. So we talked about the endotracheal tube placement, and this is the most important part. Remember that when we intubate the patient is in the neutral position, and when we give extension, we know that the tube can move up to 6 centimeters. So this procedure needs to be done with complete communication with the anesthetist, especially when you're starting out, because otherwise, if the electrodes are not in contact, then the whole system will not work reliably. So this is a simple algorithm that we follow in our practice. We give induction of anesthesia, typically with a short-acting paralytic agent such as a succinylcholine. We insert the NIM tube under vision, preferably using a video laryngoscope. Patient is positioned. We wait for the patient to be a little light. As and when the patient starts to show some bucking, what we'll see is once the system is connected, we'll see this wavy baseline, which will help us confirm. These are known as respiratory variations, to know that the tube is in place. If we get enough, then we are good to go. If not, then we like to do a repeat evaluation just to ensure that the tube is in place. Tube rotation is one of the most common reasons for a false negative kind of a situation. So we follow certain standards of use, again given in this document. And the simple principle is, as soon as you have started the surgery, the first thing is you should do a pre-dissection vagal stimulation, that's a V1, followed that by a pre-dissection recurrent laryngeal nerve stimulation, lower down. Once the dissection is done, we confirm that the nerve is functional, and then we stimulate the vagus to stimulate the entire course of the nerve. What studies have shown us is if we follow this simple algorithm, we get a negative predictive value of more than 95%. Now, typically, EMG wave that we get on successful stimulation is somewhat like this. It has got a negative dip and then a positive uprise. Now, two things are very important when one studies EMG. One is the latency period, and the second thing is the amplitude. However, when we are doing intraoperative nerve monitoring, the thing that we focused more is on the amplitude. The latency will vary depending upon whether we are stimulating the vagus nerve or the recurrent laryngeal nerve, and also in the recurrent laryngeal nerve, it will vary from the right side versus the left side. The longer the length of the nerve, the more time it will take, or rather the latency will be higher. However, we look at more on amplitude. One can correct or adjust the stimulation current also and record an even threshold so that you don't have to constantly look at the screen. You can work with an audio signal. Now, there are various areas where nerve monitoring can help us. It can help us identifying the nerve. And I think the most common or the most important function of the nerve monitoring system is prognosticate the post-operative function, especially when one is planning a total thyroidectomy or a bilateral surgery. It is aid in dissection and also teaching too. So when one is talking about use of the nerve monitoring system in the neural mapping, it's very useful, especially in the revision case scenario. You're operating in a thick fibrosed area, you stimulate, and there is a pattern where you get the stimulation, and then there are areas where you don't get the stimulation. And if one dissects there, one has a high tendency of getting the nerve in that direction. So thus, especially in revision cases, extensive nodal disease, there is a lot of extrathyroidal spread, the nerve stimulator really comes to your rescue. Now, the prognosticating function is very important because thyroid surgery is a very unique surgery which has a potential for bilateral nerve injury. And we know that visual examination is not sufficient in identifying the functional status of the nerve. So what we know is among the surgeons interviewed, this is a large case series, almost 3,700 patients. Surgeons were able to identify injuries only in about 11% of the cases. So only in about 1 out of 10 cases, the surgeons were sure that they have injured the nerve before moving on the other side. Now, a signal at the conclusion of the lobectomy post dissection gives us a very high prediction whether the recurrent laryngeal nerve is working or not. So if I get a positive signal, then I know that it has got a negative predictive value of more than 95%. So I am pretty much certain that the nerve is functional. A negative signal does not necessarily mean that the nerve is paralyzed. One needs to look at why the loss of signal is there. However, it still has a reasonably high positive predictive value of about 75%. It's a great dissection, especially when you are dealing with a lot of branching of the nerve, whether the other things are a nerve or not. And extrangular bifurcation is not that uncommon in recurrent laryngeal nerve, and it can help us identifying all the branches of the nerve and preserve them, and also help in identifying non-neural structures, and thus one can effectively dissect well, especially in the revision setting. Great teaching tool when you're talking or teaching residents. One can identify the site of injury, this being the part where the nerve enters the larynx, this being the more proximal part of the nerve. And if one does retrograde stimulation along the nerve, if one is finding signal till going back, and this is a point of loss of signal, we know exactly where the injury to the nerve has happened. So it helps us in identifying that. Now there are certain extended applications. One can use this also for the superior nerve monitoring, where one can identify the superior laryngeal nerve or just slide the nerve stimulator below the innermost strap muscle and try to stimulate the external branch of the superior laryngeal nerve, and one can directly visualize, if one can see here, the contraction of the cricothyroid muscle. So especially important when you are dealing with professional voice users, when you're dealing with radio jockeys, in people where their voice quality is immensely important. Now, recently, I would say still not that common, the continuous monitoring is available. We have the automatic periodic stimulation electrode, which one can place over the vagus nerve. And this is the electrode which really helps in getting continuous stimulation and not intermittent. The traditional method is that of intermittent stimulation, and the APS electrode, one can gently dissect in the carotid sheet, identify the vagus, loosely place the APS electrode over the vagus nerve, and it's fairly loose and mobile, and it does almost a single stimulation every 6 to 8 seconds. And one gets a continuous signal while operating. Thus, if there is any damage or any impending damage to the nerve, this is where one can get alerted, especially when one is worried about too much of a stretch in extensive dissection. So it can alert us before a more permanent damage occurs to the nerve. So the idea being, when you are doing any surgical maneuvers and if you are seeing any early changes, if one reverts those early changes, about 75% of the neural injuries can be averted. Also, it's very useful in identifying the non-recurrent laryngeal nerve. When faced with that kind of a scenario, when the nerve has a direct offshoot from the vagus, one, follow the simple method of stimulating the vagus nerve very high at point A. And if one is getting a good outcome, then one knows that the system is working. And then stimulating the vagus nerve again at the foretracheal ring, roughly at that level, tells us if the signal is there or not. So if I'm getting a signal at point A and if I'm not getting a signal at point B, then I should keep a very high suspicion for recurrent for a non-recurrent laryngeal nerve product. There is also support from the American Academy now, where slowly as nerve monitoring system experience increases, one is proposing it to be used for specific cranial monitoring. Although the evidence is still not so great when one talks about using it for the facial nerve or the spinal accessory, there is some amount of supportive evidence that it helps in preventing temporary nerve paresis, especially when used for recurrent laryngeal nerve injury. So the take-home message is intraoperative nerve monitoring provides real-time information during surgery. One may choose to stage a surgery, and that is when the intraoperative nerve monitoring has an impact on decision-making. One would definitely like to use it for a difficult case, and thus it should ideally, if the facility is available, used routinely. It facilitates a learning curve. One can't predict preoperatively when one will get into a difficulty, and we wish all patients to benefit from it. So that's the take-home message. Thank you so much for patient listening.
Can I
If there are any questions, I'll be happy to. I think, yeah, Ravi is taking over. Great.
Thank you, sir. So, hello everyone. I'm Ravi Patel, Product Manager for Energy-Based Devices in Medtronic, and I'm very pleased to present our session for latest innovations from ValueLab Energy portfolio for head and neck surgeries. As you would be aware that ValueLab has more than 50 years of experience in energy field. And since the launch of first portable electrosurgical unit in 1968, we have been introducing various electrosurgical hardware and consumable to make the surgery more safer. The first set of devices are ultrasonic dissection device, and I am very pleased to introduce the latest innovation in ultrasonic dissection, that is Sony Cision Curved Jaw cordless ultrasonic dissection system. And yes, ultrasonic dissector can be cordless now. There are no wires attached to this dissector, and you can use with freedom of a cordless device. We believe in cordless freedom because you can't afford to be tied up in an OR. Cordless vessel sealing and dissection in your procedures contributes to reduced tripping hazards, easier instrument exchanges, and improved procedural focus, among many other benefits. We have redesigned our device with you can now control the energy delivery from the sterile field with single button dual activation mode. Minimum mode can give you more of hemostasis and less of dissection. Maximum mode can give you more of dissection and less of hemostasis. Now the jaw is curved and it is a durable Teflon covered with the support of the steel jaws. Now you can enjoy freedom of movement for longer than ever because our next generation reusable battery pack delivers 88% greater capacity for more intraoperative usage before a new battery is needed. It has a warranty of minimum 1 year or 200 cases, whichever is earlier. As you can see in the picture, the non-sterile battery can be aseptically transferred into the ultrasonic dissector with the help of the battery insertion guide. Now our reusable generator is autoclavable and it has a warranty of minimum 150 cases or 1 year, whichever is earlier. Now you can see the black colored generator, a small generator which can fit to your palm. And this is real innovation from Medtronic R&D, where a bulky generator is converted into a small generator which can fit to your palm and converts the electrical energy supplied by battery pack into ultrasonic energy, which helps the jaw vibration at 56 kilohertz to get the desired clinical effects. Now our charger has 4 charging bay. It means that you can charge 4 batteries simultaneously with one charger. For the multi-specialty hospitals or government hospitals where there is a requirement of ultrasonic dissector in more than one OT at the same time, there is no need to invest a huge amount in capital equipment. You can just buy another battery and another generator. with the disposable dissector, you are ready to equip another OT with the ultrasonic dissector, and you are saving this capital investment for next 3 OT. So one charger can equip 4 ultrasonic dissector usage in 4 OTs. This was about Sony season. The next set of devices are LigaSure vessel sealing device. And I would like to thank all of you for your trust on LigaSure vessel sealing technology, which has now completed 21 years of research and development. It has been used in more than 26 million procedures, and it has been backed by more than 1,300 clinical papers around the world. How does the LigaSure technology work? So LigaSure technology provides a unique combination of pressure and energy to create a permanent seal, which is formed by denaturization of the collagen and elastin, resulting into a complete fusion of the vessels. LigaSure technology has on-label indication of fusing vessels and lymphatics up to and including 7 mm in diameter. This is a small video of the LigaSure technology.
Clamping on tissue compresses the vessel walls. Current begins to flow through tissue, creating heat. Native tissue proteins denature, while water turns to vapor and escapes. LigaSure technology fuses the intimal walls of the vessel, resulting in complete lumen occlusion.
Now, most of our LigaSure devices are coming up with nano coating job. So you can enjoy the benefit of lesser stickiness, more effective cleaning, and lesser SR buildup with the nano coating layer, which is deposited in the form of ultra thin layer on the jaws of LigaSure devices. And we are very pleased to introduce the LigaSure Exact Dissector, which is, I would say, specifically made for the indication of thyroidectomy and head and neck dissection, which can help you dissect with precision and a cooler jaw. The jaw of LigaSure Exact Dissector are 160 degrees centigrade cooler than any of the ultrasonic dissector jaw. The jaw design has been developed based on the feedback around the world from our surgeons. This is a small video of LigaSure Exact Dissector.
Innovation for you and for your patients. That's been Valley Lab Energy's mission since 1967. Our LigaSure technology has been used in over 19 million procedures, and we continue to improve on our products. Introducing the LigaSure Exact Dissector, our newest device. It's designed specifically for precise dissection to increase overall efficiency while reducing the risk of tissue damage. The LigaSure Exact Dissector's jaw has a low temperature profile and is cooler than leading ultrasonic technologies, which lowers the risk of thermal spread to surrounding critical structures. The non-stick nano-coating technology is designed to mitigate tissue sticking. The curved jaw's slender, tapered tip and the device's long working length provides optimal sightlines, even while performing procedures in confined spaces. Precise blunt dissection is achieved by the slim, symmetric jaw design. And it is powered by the FT10 or LS10 energy platforms, so it seamlessly integrates into your current workflow. Now you can increase control and efficiency, all with a single device that minimizes procedural interruptions. The LigaSure Exact Dissector. Experience the advantage of a cooler, better dissecting energy device.
Next set of devices are Valley Lab energy platforms, and this is our flagship model Valley Lab FT10 energy platform, which is a combination of monopolar energy, bipolar energy, LigaSure vessel sealing technology, and underwater bipolar dissection. And it is developed based on the tissue sensing technology, which monitors the change in tissue at the rate of 434,000 times per second and adjusts the power delivery accordingly. This one is our latest addition of the electrosurgical unit category, Valley Lab FX8 energy platform. It is also built up based on the FT10 energy platform and of the tissue sensing technology. It have a touch screen and also monopolar and bipolar energy functionality. We also Valley Lab LS10, which is a standalone LigaSure generator for the OR who already have electrosurgical unit with monopolar and bipolar functionality. and doesn't need advanced energy upgrade, they can go for ValueLab LS10, standalone plug and play device for ligashore vessel sealing technology. We do have a smoke evacuator, a universal smoke evacuator in the form of rapid wake smoke evacuator, and it is compatible with all the electrosurgical unit available in the market with optional accessories, and it has a economical longer filter life, which is of 25 hours of activation time. Now I will hand over to my colleague Abhishek Taide, who will take us to a NEEM Neuro 3.0.
Hi, good afternoon, one and all. My name is Abhishek Taide, and I'm taking care of product marketing for ENT portfolio for Medtronic India. So there has been some talks around a monitor using intraoperative nerve monitor in thyroid surgery. So why monitor? It helps reduce the risk of nerve damage during surgery by monitoring EMG activity in recurrent laryngeal nerve and providing audible and visual alerts if the nerve is activated. So talking about NEEM Neuro 3.0 system, which we have in India, so it has been leading to innovation, safety and peace of mind. That's what intraoperative nerve monitoring is all about. The new 8-channel NEEM Neuro 3.0 is built on 20 years of continuous innovation, experience, and leadership in nerve monitoring. Now, improved safety plus peace of mind, as I talked about earlier also. The simultaneous monitoring during bipolar cautery, real-time continuous monitoring with APS electrode, artifact detection software to help reduce noise, up to 8 channels of monitoring, then easier to use redesigned software, which gives 3 simple environment steps, which are setup, monitoring, and reports. That's it. It is more convenient for your OT staff, more monitoring from within surgical field, incrementing probe adjusts stimulus and captures data, use of 2 simulators at one point of time is allowed, multiple USB ports for saving data, and customizable for your needs. Now, innovative features of NEEM Neuro 3.0. Simultaneous monitoring during bipolar cautery. There is no need to mute or turn off monitoring when using bipolar cautery. It provides expanded monitoring capabilities, artifact detection software, which distinguishes between artifact and TEMG signals. It mutes most artifacts for a more quiet surgery so that noise doesn't keep on coming during the surgery. The APS monitoring, which is also called automatic periodic stimulation, it provides real-time continuous monitoring. Stimulating electrode is placed on the nerve, which allows for early detection and warning of a change in nerve function. Now, monitoring mode features enhanced on-screen information for more visibility of EMG values and settings, expanded amplitude and time scales, versatility within the surgical field, implementing probes which adjust the stimulus from 0.1 milliampere to 30 milliampere. It prints or saves the current speed. 2 independent simulations at one point of time, better quality EMG information, increased sensitivity for better quality output. So improved signal to noise ratio, more signal, very less noise, enables you to hear and see lower level EMG responses due to less background noise, helps minimize nerve manipulation during surgery. And last but not the least, improved muting detector, which is more sensitive to EMG signals, less sensitive to external and internal interference, only 1 muting port instead of 4. So that's all from my end, and thank you so much for this opportunity for presenting in Fhno 2021. We'll see you all. Thank you so much.
The next is Vlog Switcher. I'll just play one video of our key Vlog Switcher portfolio. That was for Vlog Future. And thank you everyone for patient listening. And I would like to request you to fill the freedom in ultrasonic dissection with Sony Cision Cordjo cordless ultrasonic dissection system. You can scan the QR code to know more about Sony Cision, or you can reach out to our Medtronic representative. Thank you. Thank you, everyone.
Dr. Balakrishnan, will you please adjust your camera? A bit more up. Fine, fine.
Hello, can you hear me?
Yes, sir.
Okay, thank you.
Are we ready to begin? I think it's 2 o'clock.
Yes, sir, we may start.
So shall we start now, sir?
Yeah, hi.
Hi, Bala here.
Hi, Bala. Good afternoon.
Good afternoon.
You're the chairperson. Would you introduce the first 2 speakers and then you can call me on so that I can take forward on the panel?
I'll be seeing the slide of the...
Yeah, we are just seeing that slide. Yeah. So you can take over the proceedings now. You can call over the first and then call the second speaker as well. And then you call me, then I will take over with the panel.
Yeah.
Okay, perfect.
So thank you, Fhno, for giving this opportunity to chair this session. And this is a very interesting session where issues of post-chemo radiation will be addressed. And you all know that now with the organ preservation protocol coming in great way, and in near future we'll see the role of surgery is going to be only for early malignancies or as a salvage. So we need to have a proper evaluation of the primary as well as the secondary deposits, and we have Dr. Saurav Datta, who will be talking about post-chemo radiation evaluation of the primary and neck disease. Dr. Saurav Datta is a senior head and neck consultant at Calcutta, and he's a great head and neck surgeon that we have today to address on this particular issue. And another issue of post-radiation protocols with chemoradiation would be for rehabilitation of those patients who have swallowing difficulties or other problems post chemoradiation. And we have Dr. Vidyadharan also, who will be talking to us about assessment of the interventions to improve the swallowing function and the rehabilitation procedures. Dr. Vidyadharan is a director and consultant head and neck surgeon, the Head and Neck Center and Hospital at Chennai. And he has special interest in robotic head and neck surgery, advanced otolaryngology, head and neck oncology, and he has had fellowships at Adelaide, Australia. So I invite both these speakers to start on the session. Dr. Saurav Datta will be first speaking on evaluation of the primary and neck disease post chemo radiation. Dr. Saurav, please.
Just
Okay. Good afternoon. Good afternoon, everyone. Today, thank you, Fhno, for inviting me, and it's really for me the job is very clear. I have to give a talk, and if there is any question, you have to ask my boss. Dr. Devendra sir is there; he will give you the answer. So I am very safe at this moment. So today I am going to talk about laryngeal cancer, evaluation of primary and neck after definitive chemoradiotherapy. Now, nowadays, this is one of the hottest topic in any of our conference, and this is one of the most difficult scenario in our daily practice, that evaluation of post-CTRT neck. Now, before I'm going to talk about that evaluation of post-CTRT neck, we have to say a few words about the role of CTRT in laryngeal cancer. And whenever we will give a talk anywhere where there is treatment of advanced laryngeal cancer, we cannot escape three trials. One is the famous Veteran Affairs trial, which showed that organ preservation is possible in advanced laryngeal cancer by means of neoadjuvant chemotherapy and followed by radiotherapy, which was later supported by URTC trial by Lefebvre et al. And in 2004, the famous RTOG 9111 trial, which showed that giving concurrent chemoradiotherapy is better compared to sequential chemoradiotherapy. So for advanced laryngeal cancer, majority of the patient nowadays we treat with concurrent chemoradiotherapy, except in few cases like thyroid cartilage or picoid cartilage erosion, exolaryngeal state, non-functional larynx, or different histologies other than squamous carcinoma, where we offer them surgical surgery. Now, after chemoradiotherapy, it is extremely important to assess the primary and the neck. Why? Because during surgery, we completely remove the disease. So whenever we are doing a total laryngectomy, the pathology says that there is entire disease has been removed, all margins are clear. We know at least we have not left any primary disease per se. At the same time, when we are clearing all levels or some levels of the neck node, and there is sufficient nodes, we know that we have removed almost all nodes from the neck. So there is little chance there will be residual disease in the neck or in the primary. But during non-surgical options like non-surgical chemoradiotherapy, we treat the primary and the neck by chemoradiation, and we expect that the chemoradiotherapy will completely cure the disease. It will destroy all cancer cells. But it not happens in every case. And in this scenario, in which case the disease is not completely cured or there is a residual disease, it is extremely important to know, because then we can immediately take this patient for surgery for complete removal of the disease. So we evaluate after chemoradiotherapy both the primary and the neck. But we all know it is a difficult task. Why? Because whenever we are treating a patient and we suspect a cancer for a treatment naive patient, there are some symptoms, like patient will come with some symptoms like hoarseness of voice or dysphagia or respiratory distress. And we can say that, okay, by hearing his voice, I think there may be something growth in the vocal cord, or if there is a breathlessness, there is something laryngeal obstruction, we have to look for growth. But after chemoradiotherapy, these symptoms are vague, because we can get all these symptoms just because of treatment-related changes. Treatment-related fibrosis, edema can cause all these symptoms. Next, so what? We will do an endoscopy and we will see the disease, if there is any left behind disease. But again, this is not that easy, because the majority of the time, these diseases are submucosal. You will see a completely normal or healed mucosa, but just underneath the mucosa, there may be disease, which is difficult to diagnose under endoscopy. And even if there is mucosal disease, unlike the treatment-naive patient, there will be multifocal small disease there may be, which is very difficult to identify by endoscopy. Next, so what? We will do imaging and we will see there is a disease below mucosa. We will identify by modern imaging technique. But again, this is not that easy because conventional imaging methods, they are not been able to differentiate in many cases between residual disease and treatment-related fibrosis edema. So if we see one by one, what is the sensitivity of endoscopy and under endoscopy and endoscopy guided biopsy? So Brower et al. In their study, they as a protocol, after all the CTRT, they do the laryngoscopy, direct laryngoscopy, and if there is any suspicious lesion, they take a biopsy. So out of 131 patients, they found 70 patients laryngoscopy were normal in first instance. However, out of this 70 patients, 22 were false negative. That means 31% of these patients, laryngoscopy, direct laryngoscopy and direct laryngoscopy guided biopsy failed to identify the disease. Similarly, Vianney et al., they also reported very low sensitivity. Vianney and Terha, the sensitivity was below 50% in both these trials for direct laryngoscopy and biopsy. Krelin et al., they found that the sensitivity and specificity of surgeon's opinion just by looking overall picture was 46% and 98%. And you can see this is almost comparable to endoscopy and biopsy. So therefore, we need for adjunct for clinical evaluation to increase the sensitivity in this scenario. Narrowband imaging, again, it's not widely used, but may have some role. In narrowband, there is illumination of mucosal surface by narrowband wavelength, by blue light and green light, 415 nanometer and 540 nanometer. So less frequency light, they highlight the mucosal vessels, and the green light, they go slightly deeper and they enhance the submucosal vessels, microvessels. And Jabrodsky et al., they showed that if we use NBI magnifying endoscope, the accuracy of endoscopy become 94% with positive predictive value of 79% and negative predictive value were 100%. But in this study, both type of, it was not only for post-CTRT lesion. Next comes the main imaging, morphological and functional imaging. Now, first we are talking about the routine morphological imaging like CT, MRI. Now, this is one study by Varane et al., where they have retrospectively a comparative study of 42 recurrent cases, where majority were means after CTRT, they were evaluated by CT. Around 12 patients were evaluated by MRI. And they saw imaging correctly evaluated 24% of craniocaudal extension and 52% of contralateral tumor spread. They 50% of time they incorrectly classified the disease stage. So guarded outcome and if you see that the sensitivity were very low to identify the preoperative space involvement, paraglottic space involvement, paraglottic space involvement slightly high, but almost in all other like thyroid cartilage involvement, like extralaryngeal tumor spread, contralateral tumor spread, these are all 50% or at most 60% or low. So majority of the time there are a lot of false negative report by conventional imaging method. Now here comes the role of functional imaging, that is PET-CT. So in PET-CT, there is a 5-point qualitative post-therapy assessment scoring system for head and neck. This is called Hopkins criteria. I'm not going in detail, but if there is a focal intense FDG uptake at the primary site or node, that is something we are means PET CT. There is very likely there will be residual disease. If there is a diffuse PET CT uptake, majority of the time this is due to post radiation inflammation. So now there is a persist criteria which shows that means after response assessment. This is a quantitative response assessment by PET CT. If there is complete metabolic response, then there will be visual disappearance of all metabolically active tumor. If there is partial metabolic response, there will be greater than 30% decrease in SUVL peak. SUVL and SUV is almost similar. SUV is for total body mass, and if you calculate the same thing with linear body mass, then it is called SUVL. If there is greater than 30% increase in SUVL peak, then it will be progressive disease, or if there is 75% increase in total lesion glycolysis or confirmed new lesions, then it is called progressive lesion. And if any of these criteria doesn't match, then it would be stable disease. So there is relapse trial, which was means just the abstract was published in HNS, where 150 patients of suspected recurrent T2 to T4 laryngeal cancer were treated by chemoradiotherapy with curative intent. And it has two arms. One was 74 patients. They were undergoing direct laryngoscopy, and if there is suspicion, then biopsy. And 76 patients were followed up by PET, and DL-scopy and biopsy were done only if PET were positive and equivocal. Primary endpoint was direct laryngoscopy classified unnecessary based on absence of recurrence. So the tumor recurrence were similar in both this group, and unnecessary DL-scopy were performed in 72% of the conventional method and 29% in the PET arm. No significant difference in resectability or positive margin. PET as the first diagnostic procedure can reduce the need for DL by more than 50% without jeopardizing the quality of treatment. So they supported the PET surveillance in post-CTRT laryngeal cancer. So PET has a definite role for the surveillance of post-CTRT NET. Again comes the MRI. Diffusion-weighted MRI is a very good assessing tool for in this scenario. It has a high sensitivity of 92.1% and specificity is 95.4%. So again, good diagnostic performance to rule in or rule out disease, that is MRI or diffusion, basically diffusion-weighted MRI. So this is another study which shows sensitivity of 100%, specificity of 82.4%, and accuracy of 88% when the diffusion-weighted MRI were compared with histopathology in laryngeal and hypopharyngeal cancer. But it was not in all cases, means it was not for post-treatment. There are a lot of treatment-naive patients as well. So Schroeder et al., they actually compare diffusion-weighted MRI and FDG PET, and they have shown that both have 92% sensitivity in detecting residual and recurrent head and neck carcinoma. MRI actually had higher sensitivity for local PNI and muscle infiltration, and more accurately correlates with tumor size to the histology specimen. So there is an upcoming role of PET MRI, that is FDG PET in combination with MRI. And so there are a lot of studies are going on to evaluate the role of PET MRI in this scenario. Now there is also predictive role of post-treatment imaging. It was for MRI. So Lumanovic et al. In 2008, they point 3-point scoring criteria. If there was complete resolution, then the local control rate was 100%. If there was focal mass less than 1 centimeter diameter or asymmetric obliteration of planes, suspicious of local failure, then the local control was 64%. And if there was focal mass greater than 1 centimeter or less than 50% reduction in tumor volume, then the local control rate was only 4%. So there is a definite, they show that there is MRI in this scenario they definitely have a predictive role in post-treatment laryngeal cancer. Now coming to the evaluation of neck. So if we see all the studies, the recurrent rates in post-CTRT neck, patients who achieve complete clinical or radiological response to chemoradiation have a low risk or isolated neck recurrence. So all these study they have shown, and if you see that isolated neck recurrence with observation that is very low, you can see multiple studies, highest is 14%, majority of a lot of studies show 0% isolated neck recurrence. Now, if we compare different diagnostic modalities, then this is Conan et al. PET-CT. They have shown that 50% positive predictive value, 100% negative predictive value. Conventional method, the positive predictive value is by CT is 35%. If we combine CT with MRI, that is only 33%. So definitely there is a benefit of functional imaging compared to the morphological imaging. Now this is for neck. This is the landmark article by Hisab Mehana, which was published in New England Journal of Medicine, where there were two arms, one after post chemoradiotherapy. It was not only for laryngeal cancer. Majority of the patients were actually oropharyngeal cancer, but there were also laryngeal cancer patients. So there were surveillance in 282 patients were in surveillance arm, where patients underwent PET-CT after 12 weeks, and who had complete response in neck, they were not, they were just observed. Patient who had incomplete or unequivocal response, then equivocal response, then they underwent neck dissection. On the other hand, there was a conventional arm where all patients underwent planned neck dissection. Majority after 4 to 6 weeks of completion of CTRT. In some cases, in 10% cases, the neck dissection were done 4 weeks prior to the starting of CTRT. So the primary endpoint was overall survival, and it was a non-inferiority trial. The overall survival was 84.9% in surveillance arm compared to 81.5% in planned neck dissection. So clearly, this PET-CT guided observation or surveillance for post-CTRT neck were definitely non-inferior to planned neck dissection. It was definitely a cost-effective 1,000, almost 1,500 British pounds saved per person. And if you see other secondary endpoint, you can see that loco-regional control, nodal recurrence rates, distant metastasis, everything was comparable between these two arms. Quality of life, again, there was almost slightly, there was better quality of life in the first 6 months in the PET surveillance group, but it was comparable in both groups in 2 years. This study, so it is a landmark trial, and if there is a landmark trial, there have to be some criticism. So one was sample size calculation, because they calculated, they took arbitrarily that 2-year overall survival as 75%. They had a significant loss of patients after 2 years. So what happened to this patient, and what will be in longer follow-up, what will be the outcome? This is very difficult to find from this study. Majority of the patients, as I mentioned, was oropharyngeal carcinoma. So could the result be extrapolated to other side? Because we know that majority of the oropharyngeal cancers are HPV positive. So can we extrapolate this for HPV negative cancer as well? This is a big question. Only 3% were N3 disease, and there was no correlation between the disease persistence on imaging and actual pathological disease persistence in HPR. So this is unknown in this study. Now, for equivocal disease, all patients underwent planned means neck dissection. So could FNAC have been included for the workup of patient with equivocal disease? This is also a question for this study. Fateh et al. In 2008, they have also shown that PET-CT for response assessment in neck nodes comparison with HPR, that positive predictive value is 87.5% and negative predictive value of 79.15%. They took cutoff of 4.762 as a SUV max. So they showed that PET-CT actually have a good correlation with HPR as well. So now the big question is, so PET-CT guided surveillance, if there is complete response, you can just observe. If there is incomplete response, there is a PET active nodes, you have to undergo neck dissection. But what will be the treatment for equivocal response on PET-CT? Should we go neck dissection for all these cases? Because the positive predictive value of equivocal response varies from 10 to 60% in literature. So what should be, if we want to avoid neck dissection in this group of patients, what should be the next step? The next step, we can do a guided FNAC, we can take a second look PET-CT, and or we can obviously do neck dissection. So ASCO guideline mentioned that equivocal node with size less than 1 centimeter may be kept under surveillance. However, the recommendation is moderate and quality of evidence is indeterminate. So let's see what will be the guided FNAC. Now in guided FNAC, actually for neck node, we have a study for even treatment naive neck. The guided FNAC, USG guided FNAC has a very poor sensitivity. And if we see from other study in this scenario, the accuracy of FNAC in irradiated neck is very low. So it is not a good tool to decide regarding further treatment. Potential biomarker like Ki67 in FNAC sample, so immunocytochemistry, it is under evaluation. There is nothing concrete has come yet to take a decision on that. Now, second look PET-CT again. If there is a equivocal response, then what will happen if we do a PET-CT after some time? So this is a Prestige et al. They in their study they did. There were 562 patients under a response assessment PET-CT. Of these, 40 had incomplete response, and of these, 40 patients, they did the first PET-CT was done in after 17 weeks, which I think is a very long duration. Normally we do in 12 weeks. The second PET-CT they did around 3 months after the first PET-CT. The median was 13 weeks. And this, see, out of these 40 patients, 60% had complete response in second look PET-CT. The positive predictive value of second look PET-CT was 25% for primary and 40% for lymph node. Negative predictive value was 96% for primary and 10% for lymph node. But the caveat of this is this: out of these 40%, 85% of these patients were oropharyngeal primaries. Now, so Lovoli et al. They show that complete response in half of HPV negative head and neck squamous cell carcinoma on second look PET-CT. So if there is a PET-CT for this HPV negative patient, we should be very careful to take decision on second look PET-CT. Now the take home message is PET-CT for response assessment is a very good tool to assess the neck, and we should do it after 12 weeks. In positive or equivocal response at primary site, adjunct MRI with the diffusion weighted to supplement anatomic detail may be done, and to plan the treatment. High index of suspicion for recurrent or residual disease for early detection and management is necessary. Thank you.
Thank you very much. Can I invite the next speaker, Dr. Vidyadharan, to talk about assessment and intervention to improve the swallowing function post chemoradiation.
Sure, sir. I'm just going to share my screen. Can I start, sir?
Yeah, you can start.
Okay.
Right.
Yeah, for better bandwidth, I'm going to stop my video. So I just share the screen. Okay, good afternoon, everybody. I'll be talking about the assessment and interventions to improve swallowing functions of the larynx and pharynx, because the focus on post-chemo radiation related dysphagia. And with that is a session of the afternoon now. And basically, eating and swallowing are complex physiological behaviors. It include both voluntary and reflexive activities involving more than 30 nerves and muscles. And the mechanism of swallowing involves the oral cavity, oropharynx, larynx, hypopharynx, and esophagus. The swallowing is a functional priority that is very highly ranked among patients before and after head and neck cancer treatment. And it's an independent driver of quality of life, especially in survivors. So any survivor, the pharyngeal dysphagia significantly contributes to life-threatening morbidity such as pneumonia and malnutrition. So with this background, I would like to just highlight the contents of my talk. I'll be talking about the pathophysiology and issues post-radiation with specific relation to the larynx and how to evaluate these dysphagia, which test to use, the type of intervention, what and when and what frequency we do the interventions. If you generally take head and neck cancers, all cancer in general respect anatomical boundaries until its late biological stage. And unfortunately, most of our Indian patients, the treatment can involve more than one subsite because they present at such an advanced stage. And a lot of small critical structures are tightly packed in the head and neck region. So if you take the head and neck tumor, I usually try to classify with regard to swallow pathophysiology beyond the aerodigest tract. I try to classify it into two types, either an intrinsic type of tumor or an extrinsic type of tumor. If the intrinsic type, it could be kind of infiltrated, where it's fixed into the tissue, causing pain, trismus, and also causing some cranial nerve deficits. If it's an extrinsic type tumor, it can cause compression externally or also cause obstruction to the swallowing passage. Whether the stage of the cancer, early or advanced, radiation therapy is a standard management of head and neck cancer. So you cannot avoid radiation treatment while planning a treatment for any patient with head and neck cancer. So, but most of the time, our patients present with some signs and symptoms of dysphagia, and these are the commonly presentable symptoms. They usually present difficulty chewing, coughing or choking, food sticking in the throat, and they have signs of weight loss and malnutrition. So when we encounter such a patient, this is after post-treatment, usually we would take a detailed medical history, which would depend on the surgical notes, the operative note, get an idea of what was taken out, what was reconstructed, and then post-radiation therapy and post-chemotherapy setting, we would see how much dose of radiation was given to what particular structures, and also the patient's feeding history. The feeding history will basically depend on the feeding method. It will be whether the patient was on nasogastric tube feed, gastrostomy tube feed, or jejunostomy, or on intravenous total parenteral nutrition. We also do a detailed physical examination of the swallow musculature and also do observations of swallow competence, which is basically test swallows. So do a water swallow test at the bedside to assess whether the patient can tolerate a small amount of water. Feeding methods, as I told you, same with the patients on nasogastric tube or any type of tube feeding. We also see the patient respiratory status, normal saturation level, that if there's very low saturation, either they've been a chronic smoker or they've had recurrent aspiration pneumonia. And if the patient's on tracheostomy or recently on ventilator, and also the patient's mental and cognitive status to see the level of alertness and orientation, because they will be very receptive to our rehabilitation. And also check whether the patient is depressed because their expectations, the reality of the situation post-treatment did not meet their expectations. We also do a detailed cranial nerve assessment of mainly the lower cranial nerves, and also do mealtime observation. That is basically observe how the patient eats to see what type of posture the patient maintains, the self-feeding skills, and all the accessories he needs to properly feed himself. Once that's done, we have an idea of all the anatomical levels of what is affected, and we get the history of what treatment was given. Then we grade the patient's present eating status based on some of these scales, and I usually use the Foy scale. And then we confirm our findings with instrumental evaluation. And we usually do two types very commonly. One is the FEAS, or the flexible endoscopic evaluation of swallowing study, or the video fluoroscopy or modified barium swallow study. The FEAS test is performed, it can be performed at the bedside, and you gives a direct view of the anatomy of the structures, and you can evaluate the laryngeal and pharyngeal structures. You can see as in the video on the right side of the screen. It uses real food and liquid for examination, and can last throughout a meal to evaluate for fatigue also. So we can check if the patient's stamina, especially post chemoradiation. Only thing is we cannot visualize, the only disadvantage is we cannot visualize the oral phase of swallowing. You know, swallowing has 4 phases. Oral phase is 2 parts, then pharyngeal and esophageal. And during that time, we also cannot visualize during the whiteout period. As you can see in the screen, everything turns white. This is when the whole laryngeal and pharyngeal muscles contract, and the scope gets obscured of its view. And also with the recent the COVID onset, disinfection of the scopes is becoming a bit of a problem. So that's one drawback of the study. The video fluoroscopy or modified barium swallow is a gold standard test. It is because it's non-invasive, and it evaluates all the phases of swallowing, oral, pharyngeal, esophageal phase of swallowing, and it also evaluates hypolaryngal elevation, which is pertaining to this particular session, larynx. It's very important. The only disadvantage is you need a fluoroscopy unit, which is expensive, and there is radiation exposure. So examination time has to be limited. We use radio opaque contrast. If patient is having an allergy to that contrast, such as barium or gastrographin, then it becomes a problem. Once we have examined, then we score the swallow with the penetration aspiration scale, and this scale is designed by Rosenbach. And this is what we follow. We see whether the patient is just penetrating, or there's no penetration or aspiration, or the patient is frankly aspirating, and V is aspirating to what extent. And then there are many different types of dysphagia grading. We do grade. I myself have evolved over the years with using different types of score, and currently come to use the digest score. But you can see from this slide there are multiple rating scales. And for each rating scale, you can use it in both the instrumental examinations, and some of them, like the digest score, it can be used only with the fluoroscopy. And there's also the bolus residue scale, which we use in the FEAS examination. So these are the multiple scales you can use to assess the level. You can grade the dysphagia. The digest score is basically gives. It gives a fluoroscopy or modified barium swallow rating to the common terminology criteria for adverse events nomenclature. For this, and basically it just tells you according to the toxicity grading used. So you use 2 different scores. One is the from the right side, you can see the penetration aspiration score, and also the bolus residue score. With the penetration aspiration score, you can you can grade the safety, and with the bolus residue, you can grade the efficiency. And this relates to whether the patient has a risk of getting aspiration pneumonia, or also the patient is as a risk of having nutritional compromise. Now, issues post chemoradiation. So before we get into that, we need to understand the importance of radiation dose to the structures. And the structures whose damage may cause dysphagia and aspiration after intensive chemotherapy and radiation are the pharyngeal constrictors, as you can see here, the superior, middle, and the inferior constrictors, and also a part of the glottic and the supraglottic larynx. And these structures are commonly in the radiation oncology are commonly termed as the dysphagia aspiration related structures. The dose received by the constrictor muscles has been associated very commonly with post-radiation dysphagia, and the strongest relationship is for the superior constrictor muscle. In Eisbruch, from this paper, he was the first to highlight that the radiation dose to the pharyngeal constrictors and the larynx played a critical role in development of RTOG grade 3 and 4 dysphagia. They reported on dysphagia optimized IMRT, which is a step ahead of standard IMRT, where the dose to the DARS structures, the DARS, could be tailored to be contained within the limits without compromising the dose to the target volume. And this was considered to be promising and it's been used until now. From this paper, Molan et al., they showed that the mean dose above 63 Gray to the superior constrictor muscle and the middle constrictor muscle resulted in poor swallowing quality. And the same was also shown by Feng et al. For pharyngeal constrictors taken together as a whole. There is one Indian study which by Chellacott et al. Suggested that the probable limiting dose for dysphagia for the base of tongue is around 63 Gray, and for the larynx is as 55 Gray. So we need to keep in mind while planning or assessing a dysphagic patient post chemoradiation, how much dose they have received to each structure with special regard to tongue base and the larynx. A little bit on pathophysiology of radiation-associated dysphagia. During and immediately after radiation, that is the acute phase, patients may experience mucositis, edema, and erythema, compounded by taste changes, nausea, and xerostomia. This impacts on the ability and the desire to swallow, and the disuse because of this mucositis, pain, edema, and the disuse of the skeletal muscles involved in swallowing. These muscles can be weak, and this reduces the stamina to swallow. And I strongly believe that it is important to continue swallowing even with limited oral intake, small amounts, because this has also been highlighted, because to keep maintaining that stamina of the musculature. The next stage, usually after the acute stage, is the chronic fibrosis stage, where the radiation-induced fibrosis in the swallowing structures occurs due to the abnormal tissue healing formed after treatment. This is mainly due to hyperactivation of the transforming growth factor beta and the connective tissue growth factor CTGF. The fibrotic connective tissue what happens is the fibrotic connective tissue wraps around the muscle fibers, and they result in a restricted movement of the muscles, especially the muscles of the constrictors and the laryngeal muscles. And then the muscle fibers become weak due to disuse atrophy. So although some patients are able to resume eating and drinking after this acute treatment phase and moving on to chronic, others continue to constantly experience difficulties. And these swallowing difficulties can result from gradual onset of fibrosis or the late onset of fibrosis. And then they go into the further stage of denervation, where the vasculature around the nerves get fibrosed or get occluded. So then the nerves also become, that area supplied by the nerve becomes insensate. And so that is a late stage, which is usually irreversible. So fibrosis, edema, persistent edema, and disuse atrophy, and then fibrosis, and then late stage denervation all contribute to this radiation-associated dysphagia. And these are the parameters we need to look for while we are following up the patients post-chemoradiation or post-radiotherapy. Here is a Scopy video of a 60-year-old male who had a radiation treatment, who's 10 years follow-up post-radiation treatment. And this is his larynx 10 years after radiation. You could see there is a huge retrolingual space between the tongue and the epiglottis. So here's a chance that he can always be collecting saliva on food. As we go closer in towards the larynx, you could see the most of the cartilage of larynx have been kind of melted away, or you have a lot of supraglottic stenosis. and very limited movement of his vocal cord. And deep down, you can see the true chords. He actually presented with asking for 10 years after radiation, asking for improvement in his voice, and he also wanted some form of voice therapy or surgical intervention. At this stage, it looked very difficult to rehabilitate him. He was okay with eating, and he had actually over the years come down to one particular diet which he could take, and he had avoided the food which he could not. He had a lot of struggle with. Another thing is to be aware is about the association between external and internal lymphedema with the chronic dysphagia following head and neck cancer treatment. So external lymphedema is most prevalent at 3 months and begins to improve at 6 months, and it's largely resolved by end of 12 months. Whereas internal lymphedema, head and neck lymphedema, persists throughout the whole 12 months, but there's some reduction in its severity and diffuseness, but never fully resolves. And patients who are at 12 months post chemoradiation may be expected to present with internal lymphedema in the absence of an external head and neck lymphedema. Even this has some issues because the sensitivity or the laryngeal sensitivity starts to come down. Patients who have higher severity of external or internal lymphedema or have more diffuse internal head and neck lymphedema post chemoradiation may experience more severe dysphagia. This is easily a very beautiful detail in this particular paper. And coming to potential complications of radiation therapy with or without chemotherapy, as we already spoke about, the mucositis, xerostomia, sensory changes, fibrosis. There also could be dental changes leading to enamel loss, hence the importance of suggesting fluoride treatment before the patient and removing of caries tooth before the patient goes in for radiation treatment. Okay. The importance of swallowing rehabilitation. Now, why do we need to rehabilitate these patients? One, you don't want them to be malnourished and start losing weight. And if this happens, there will be poor healing. Second is the aspiration pneumonia, because that gets them in and out of hospital and delays in further adjuvant treatment. Tube dependence, they need special feed, they need to be dependent on others, and they become sometimes a social cripple. They get into depression because they cannot be able to express themselves or eat in public. Now, what we don't want for our patients is in the postoperative period to be like this. One is the video on the left-hand side. You can see a patient who's having silent aspiration. That means you can see the barium dye trickling down into the anterior wall of trachea, but the patient is not coughing at all. So these patients will keep aspirating silently and keep getting recurrent chest infections. Second is secondary aspiration, where you can see there's a holdup of barium in the postcricoid region, and a very little barium goes down the cervical esophagus, and the rest spills over. So the barium, the food bolus residue gets collected in the postcricoid or in the vallicula, and then patient ends up aspirating on it. This is because of sometimes poor contraction of the pharyngeal constrictor muscles. So they're not completely squeezing all the food bolus down into the cervical esophagus. We also want to avoid this in this kind of situation. This is the posterior cricoarytenoid myolysis. This is due to prolonged retention of the nasogastric tube, and it causes fixity of the cricoarytenoid joint on either side, and patient finally ends up having a dysfunctional larynx. So it's a dictum. We usually try to decannulate the patient within 2 months or within 6 weeks to 8 weeks after radiation treatment if they're still on a tube. If the patient is dependent for greater than 3 months, then we try to suggest a PEG, which will help with the rehabilitation also, so that they're free and they can better the mood of the patient also. So what are the interventions? Before getting into intervention, we should know what are the commonly or in general affected issues during the physiology of swallowing in post-radiation patients. Either one or combination of these following dysfunctional issues are seen among post-chemoradiation patients. One is a decreased movement of base of tongue towards the posterior pharyngeal wall. Other is a reduced laryngeal elevation and the laryngeal vestibule closure. The third would be a reduced pharyngeal contraction. They can have a longer pharyngeal delay time or delay in initiation of the swallow with uncoordinated food bolus propulsion posteriorly, and incomplete is upper esophageal sphincter opening. So they can have one or a combination of all these two issues to cause some amount of oropharyngeal dysphagia. So how do we minimize the occurrence of these issues is to commence rehabilitation prior to treatment. And there are many studies in the literature, including a randomized controlled trial, reinforcing this point. And these are the recommended strategies by these studies where they've suggested different set of exercises with a certain frequency to be performed or taught to the patient and to perform much before the start of the treatment and to continue on till towards the end of the treatment as much as they can do, and then continue in the post treatment period too. So these exercises, we can generally call them as pharyngosize, and they're prophylactic swallowing exercises prior and during the treatment. Manual lymphatic drainage is a method to help, which is commonly done for patients with treatment of breast cancer, but it can be done for patients with head and neck cancer post radiation treatment. This helps in reducing the external lymphedema and thereby indirectly the internal lymphedema of the neck. Coming to the issue of PEG versus nasogastric.
Can you be a little faster? Because we're going to start off with the panel discussion.
Sure. I'll be.
Thank you. Sorry for troubling you.
No problem. So there are two main points with regard to PEG versus nasogastric tube. One is that it is still very debatable. Both these tubes, feeding tubes, have been found effective in maintaining nutritional status in patients with head and neck cancer. And the long-term use of enteral feeding, this research suggests that if you need a patient to be on long-term enteral feeding, then a PEG tube is better than a nasogastric tube. But there's no significant difference in mortality rates as per this Cochrane study. Effects of treatment on swallowing mechanism. Depending on the type of injury, whether acute injury, conjugal late injury or delayed injury. If it's acute injury, I would usually try the non-surgical rehabilitation. That is the different types of maneuvers and exercises. If it is a very delayed injury where there's a lot of muscle atrophy, fibrosis, or trismus, and this is irreversible with even exercises, then surgical rehabilitation would be what we think. Swallowing therapy we can try of two types, is mainly rehabilitative and compensatory. Rehabilitative is also called indirect swallowing therapy, basically a group of exercise designed to improve the function of the affected muscles. Whereas compensatory or direct swallowing therapy is the food is given by mouth and some adjustments are made to bypass the dysfunction so that the patient can eat. In rehabilitative or indirect swallowing therapy, no food is given. And this is one point I wanted to bring forth, especially with regards to larynx, is the hyolaryngeal elevation. This should be kept in mind and somehow reinforce the patient to keep using these muscles, the suprahyoid muscles, to have proper maintenance of laryngeal and pharyngeal function. Dysphagia after oropharyngeal cancer treatment, what we see is usually happens mainly in the tongue base, altered borderless transit, loss of laryngeal protection, loss of sensation of the tongue base. And you can see here there's a huge space between the base of the tongue and the postopharyngeal wall. To help with to strengthen these, we have exercises such as lingual protrusion against resistance, the massacre maneuver, which is basically trying to stretch the tongue out, the chin tuck, which helps in narrowing the oropharyngeal lumen so that they can easily bypass the dysfunction. An effortful swallow to start using the constrictor muscles to really squeeze the food down. With regard to hyperpharynx, the posterior pharyngeal wall is very important because any scarring in the first pharyngeal wall can lead to impaired contraction because that's where all the constrictor muscles are attached. So we need to keep that in mind. And also with piriform and postcricoid, strictures are very common. So with this, we tried different maneuvers such as the Mendelssohn maneuver, which is to manually lift the larynx up, and the shaker exercise to strengthen the anterior neck muscles. With regard to larynx, the main point would be the cricoarytenoid joint on either side. It should be constantly mobile. So we should get tailor exercises, get the patient to keep swallowing, get the patient to keep talking as much as possible so that the cricoarytenoid joint does not get fixed. And if there is a dysfunction or a glottic gap, then supraglottic or supraglottic swallow can be taught to help overcome the dysfunction and to swallow. This is an example of a patient who's had intractable aspiration because of fixity of the cricoarytenoid joint. You can see the joint does not move, and the other joint has been treated by, which must have been affected by a tumor, and it's been treated. And you can see here the patient is frankly aspirating because of the stenosis in the supraglottis. And with regard to timing of swallowing therapy, there's no consensus regarding optimal time to begin therapy. As a general guideline, we have to do it as soon as possible. One important thing is to try to downsize the tracheostomy tube if possible, or decannulate it early. And the role of transcutaneous neuromuscular stimulation, that is still debatable. There is no current prospective or RCT data to support the use of these electrical stimulation, especially for radiation therapy. Patients with dysphagia post-radiation therapy. In the meantime, we recommend as much as general exercises and prophylactic exercises as possible. These are the commonly encountered strictures in different parts of the pharynx, and the most common would be the postcricoid or the hypopharyngeal strictures. And in this situation, there's no way we can try to overcome this either by modifying the diet, or we need to do some kind of surgical intervention. To conclude, although curing cancer is the primary goal, the patient's post-treatment function and quality of life are also important considerations in choosing the type of treatment, because each treatment has a potential side effect and sequelae. Given the wide complexity of underlying anatomical structures and overlapping neural mechanisms, it may be challenging to have a rationalized algorithm for ordering a specific test or workup for dysphagia. There is no one standard test. We need to work out based on an individual basis. And it's prudent to understand each diagnosis test modality and mechanism, the pros and cons of each test, and in individual patients for optimal management of dysphagia. Thank you so much.
Thank you, Dr. Vidyadharan. May now invite Dr. Devendra Chokar to lead the panel discussion on post-chemoradiation issues and management.
Thank you, Dr. Balakrishnan. I will start sharing my screen now. Where is the screen? Give me a minute. Give me a minute. I'm having some problem sharing my screen. Just give me a minute, please.
No problem, sir. Go ahead.
Yeah. It's not showing yet. Can you allow me to share screen? Yeah. Call Mama.
So the technical support can help you out. They can, I think they
I
have.
don't know. I have the slide open on my desktop, but it's not showing in the share screen.
Maybe technical team can do that for you.
Maybe. Can the technical team help me out? I can't see the.
Are you using the Windows?
Yeah, no, I'm using this MacBook.
Okay. So once you select, have you already opened that file?
Yeah, it's open on my desktop.
Okay.
Should I save it on my desktop?
Yeah, please.
I have not saved it yet. Should I save it first?
Please save it first, then it will happen.
Okay. Give me a minute. How do you save it? Where is it? I can't share it. I've opened it on my desktop. Hello,
So now try share screen.
Yeah, it doesn't show. It's not showing. Can I mail it to you?
Yeah, please. I'm texting you.
So quickly mail to any of us. We'll try to share from here.
Yeah, rather do that. Give me a minute. I'm just sharing my presentation, okay? Rohit, I've sent it to you. I'm sending it to you right now. Is Rohit there? Hello? I've sent it to Rohit. Is Rohit there? Hello?
I think Rohit is not there probably. Can you send it to Neeraj, the technical?
Neeraj, I don't have your... Anyway, I think we'll start.
Send to projects4@meetingsandmore.com.
Sorry?
Open the chat box and they've given an email for that. Projects4@meetingandmore.
Projects4@meetingandmore. Give me a minute.
Projects, the numerical 4@meetingsandmore.
Just a minute, please. Projects.
Number 4.
Yeah.
At meetings.
Yes, I'm sharing it right now.
And more, yeah.
Yeah. Okay, I'm sending it to you. It's sent to you. Right, we'll start the panel. We are already run out of time. We have only 15 minutes left for the panel. But so I would like to invite all my panelists at this point. We have 3 surgeons on the panel. We have Saurav Arora, Abhishek Vaidya, and Sajid Babu. We have 2 radiation oncologists, Kumaraswamy and Suman. And we have a medical oncologist, Sushil. So let's get started. We have heard great talks, 2 great talks on treatment or issues in salvage laryngectomies. Let's get on. It's a known fact that organ preservation is here to stay. And we'll be called upon more and more to treat salvage cases. So during this panel now, I will not put up cases as such, but I will take up issues in management of this. Can the organizers share the screen, please? Is it possible? Okay, so let us start. The first case is a elderly gentleman, 55-year-old, who's treated for a T2N1, so stage 3 CA larynx. He was treated with CTRT in January 2020. And then he was apparently okay at 3 months, and then he lost to follow-up in COVID. And now he's presented to us with increasing hoarseness, pain in his throat. Now, when a patient presents to you like this, I have images of his endoscopic images, which show kind of a necrotic area in the anterior commissure. He had a lesion which was straddling the anterior commissure, T1B lesion. Now there is some necrotic area in that region. So my question to the panelists is, when you see such a case, patient presenting with pain, hoarseness, the endoscopy shows laryngeal edema, a bit of necrotic tissue in the anterior part, how will you approach this patient? What will be your next step? Surgeons, any one of you, please go ahead till the screen is shared.
So obviously you would want to do fiber optic scopy and an imaging both. As Saurav very elegantly pointed out in his presentation, the imaging of choice would be a PET CT scan. However, there would be a time limitation of the PET CT scan. The best results with the most accuracy of a PET CT scan would be obtained typically at 10 to 12 weeks post-treatment. So if you have that much of time in between your treatment completion and your time of assessment, you could go for a PET CT scan.
Right.
Or at the very least, you could do a endoscopy with biopsy.
So, yes.
If the because you said the patient was treated initially in 2020 and there is a gap of the treatment. So
Yes.
and the patient was on follow up with us. We have seen a normal larynx in between, and now that an ulcer or necrotic area has come, surely we should think of recurrence rather than a residual or any necrosis. So I think a straightforward biopsy would be also fine.
Right.
So
yes,
my take is we have to see the patient airway also. If it is airway is okay, then I will like to do the biopsy under GA. If airway can be compromised during general anesthesia, patient need tracheostomy, I will do an endoscopic office procedure biopsy.
Right. So what is coming out? So let us talk of imaging. And Saurabh, is the technical team ready with the presentation? Is there a problem there? Should I log off and log in again?
So we are downloading. Just take 1 minute, sir.
You got my presentation?
Yes, yeah.
Lovely. Okay. So Saurabh in his talk very elegantly told us that CT scan, you will see bubbles, you will see some necrotic areas, you will see some tissue which is or collapse of cartilage that you cannot differentiate very well what is a recurrence and what is necrosis. But if you do a PET scan, if you see an intense focal uptake as opposed to a diffuse low-grade uptake, that is usually a clincher of necrosis versus recurrence. Okay, and Saurabh elegantly showed that paper, the relapse trial, where they randomized patients to clinical workup versus PET-guided workup. And in that randomized trial, they showed that when you do a PET-guided biopsy, so if the PET is showing you it is a recurrence, versus if the PET has a very low-grade uptake, you can avoid 50% unnecessary biopsies, and you can only target biopsies if the PET is showing you a recurrence. So that's one indication, because the second part is how many biopsies we reduce. Yeah, okay, the screen is up. Let's go ahead. Can you go ahead, please? Yes, go ahead, please. Go ahead. So this is the, so he presents with horses. Go ahead. Next slide, please. Next slide. So that's the CT scan. So when you have soft tissue necrosis, the CT scan will show air bubbles, as I said, and the PET scan will be a clincher. Go ahead, please. Next slide. Next slide. We finished this. Next slide. Next slide. Next slide, please. Yeah, next. 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 Next slide, please. Yeah, okay. Keep it at the previous slide, please. Right. So now Abhishek said that we'll go in and biopsy. Now it's not very easy to biopsy in a relapse case, right? There's a lot of edema. Most of the recurrences are submucosal. You biopsy it, you get a negative biopsy. Sajid, Abhishek, what are you going to do now? You think there's a recurrence. Sajid thinks that yes, he's come back in a year and a half. It's probably recurrence. You biopsy it, it's negative. What do you do next?
If the PET is also showing a strong evidence for a recurrence, straight away we will have to counsel the patient and then take up for surgery directly, because however we do a biopsy, repeated biopsy, it is unlikely that we will get a positive result. So in those cases, we may have to depend on the PET report and then proceed.
So Sajid, the point well taken, but I'm a little scared of docking of somebody's larynx, and we'll come to the extent of surgery a little later. But I'm a little scared to knock off somebody's larynx, especially if it is functional. We'll talk of when you operate a chondronecrosis or a soft tissue necrosis, to knock off some functional larynx without a positive biopsy. And also the flip point, and I know why you're saying you won't go ahead with a biopsy again, because the more you punch this edematous necrotic area, the more chondronecrosis stroke soft tissue necrosis you're going to set in. So it's a very tight balance. So anybody else on the panel, would you like to do something else?
So I will give this patient a month time. I will give the antibiotic treatment, conservative treatment for a month. It will not change my laryngectomy or my surgical extent in a month time, and I will repeat the scan in a month time. If it is showing same or increasing trend also clinically, then I will definitely counsel the patient for laryngectomy, but I will give some time.
Okay. So next slide, please.
I'm
So this
also
relapse,
going to.
yes, Abhishek, please go ahead.
I'm
Next.
also going to functionally assess the patient. If the patient has significant aspiration with this, he already has a dysfunctional larynx, I probably wouldn't think twice going in with a laryngectomy.
Right. He's not having a dysfunctional, like you're not doing a laryngectomy. Okay. So this relapse side told us that if you have a PET which is very suspicious, then only go ahead and do a biopsy. Next slide, please. But anybody on the panel wanting to do a CT guided biopsy? Next slide, please. Anybody on the panel wanting to do CT guided biopsy? Because most of the recurrences are submucosal. You punch the overlying mucosa, you'll get a negative biopsy. But there is an intense uptake on CT scan. There is an intense uptake, focal uptake on PET CT. Why not send the patient to the radiology suite for a CT guided biopsy? I don't have the exact figures, but there are some patients whom we have done a CT guided biopsy and hit the target. Any comments on this?
CT guided FNAC can be done. Biopsy is difficult.
Biopsy, I mean FNAC, getting a tissue diagnosis.
Yeah, FNAC also I have done couple of patients.
Right.
So if the lesion is entirely endolaryngeal,
yes,
then and if it is not accessible through the thyroid membrane, remember that the FNAC will have to pass through the thyroid cartilage, and that makes it very difficult. If there is a slight exolaryngeal component to it, or if the endolaryngeal component is adjacent to the thyroid membrane, then it is easier.
Right. So yeah, but it is possible to target it CT guided, so that you should keep it in mind. Try to get a positive diagnosis before you knock off the larynx, especially if it is a functional larynx. Next slide, please. Next. So as Saurav said that, next slide, please. Coming to chondronecrosis, this is the first part, right? So you have two diagnoses. It is either a soft tissue necrosis or it is recurrence. Now, suppose the PET scan, your CT scan and one biopsy has told you, yes, it is not recurrence, you're going to manage chondronecrosis. My radiation oncology colleagues, how do you manage this soft tissue necrosis? Kumar Swami, Suman, anybody on the panel? Do you follow this Chandler's classification and manage it as Saurav said, give symptomatic treatment for stage 1, 2? And what's the role of HBOT?
Yeah, the problem, of course, the symptomatic care is this is Dr. Kumar Swami here. Am I audible?
Yes, you are absolutely audible.
This soft tissue necrosis symptomatic care is the basic treatment. But about the HBOT, there is controversy regarding whether it will sort of encourage recurrence subsequently because of therefore it is not used upfront. But maybe if all the measures fail, it may be tried, but still then surgical intervention may be better than the HBOT.
Next slide, please. So this is a kind of a algorithm that has been given to us. Grade 1, 2 give symptomatic treatment. Grade 3 start steroids, start antibiotics, do a bit of debridement, and at grade 4 dysfunctional, non-functional larynx, do surgery. Next slide, please. HBOT, like in mandible, and there is a lot of controversy whether to give HBOT or not. But there's hot off the press now. You see the Green Journal today. There is a Dhanka 21 today or yesterday it is published. The Dhanka 21 study, which is a randomized study for HBOT in mandible necrosis, osteoradionecrosis, which says that the healing was 70% in the HBOT arm versus 52% in the non-HBOT arm, only surgically debrided arm. So clearly, it was not statistically significant because of the underpower of the study, but there was a huge difference in the mandible, the recovery of the necrosis in the mandible. And also in larynx, there are a lot of studies which have shown HBOT to improve the rates of healing. Yes, Dr. Kumaraswamy.
Yeah, the healing is not an issue.
Right.
Yeah, it heals well. Effectiveness is not the question.
Right. But I think it may feed the cancer. But we have already kind of established that there is no cancer here and it's soft tissue necrosis.
No, future. The microscopic disease that is not there.
Okay.
Then if there is a recurrence, there will be an issue. And I think most of the HBOT consent form has that as the first point, the possibility of recurrence in the future, increased recurrence in the future.
Next slide, please. Let's go ahead quickly. We have only 5-10 minutes left. So HBOT is an option. Next slide, please. Right. So let's come to now. Let's manage the residual disease. Now, considering that we have a positive biopsy, I'm putting out options for treatment. We have transoral options. Laser robotic will come to that. We have partial laryngectomy options and we have total laryngectomy. I'm going to go to the surgeons, but I have not put something here. Next slide, please. Is the role of re-radiation with or without chemotherapy. My radiation oncology colleagues first, and then Sushil, I want you to comment on how many patients, say it was a T1 to begin with, has received radiation. 3 years down the line now, he's got a similar T1 recurrence or T2 recurrence. Is re-radiation or stroke radiation with chemo possible again? Before we turn on to the surgeons. Dr. Kumaraswamy, please.
I mean, I would be sort of reluctant unless it is a very localized, very small recurrence. For volume of recurrence would be the point.
Yes. So even if it is a small recurrence, next slide, please.
Yeah, I agree with Dr. Kumaraswamy. Recurrence post-radiation ideally should be considered for surgery.
Right. So clearly, our radiation oncology colleagues are not very comfortable, and rightly so, because the toxicities are quite high for re-radiation of the larynx because of the important structures that are in the close vicinity. Next slide, please. So now I'm back to the surgeons. So let's start one by one, and we'll quickly go through these options. I just want indications of transoral. Next slide, please. Abhishek, Sajid, anybody? When will you do laser surgery? Or before that? Before you start thinking about treating a recurrent case, what comes to your mind? Next slide, please.
Okay, so here are a few factors. You want to know the current staging. You want to know the staging of the disease which was treated with radiation or chemoradiation prior, and you want to know the disease map of the initially treated disease. If the initial treated disease map was resectable with either of these conservative options, then this conservative option can be tried again, provided it is still a limited stage disease. And then finally, you look at the functional assessment.
Right. So Sajid, Abhishek spelled out the criteria for doing local, and we'll come to that for doing transoral resection, and we'll come to that a little later. But what comes to your mind when you're treating recurrent cancer? Are you a little bit uncomfortable doing these anything less than a total laryngectomy, and why?
Yes, surely, because the first choice will be total laryngectomy.
Why is that?
100% because that is the gold standard. We don't need to worry about anything else. It is very tempting to do conservative treatment in small volume diseases, but always we have to keep these things in mind, which Abhishek had already alluded. Probably those early lesions like T1, I would say only T1, which if it recurs as T1 again, probably we can consider something like a laser surgery. But that has to be selected very carefully unless we don't want the total laryngectomy in that patient.
So the panelists are saying that usually 80 to 90% would land up with a total laryngectomy. The reason being, most of the recurrences are higher stage recurrences. There is a lot of exolaryngeal spread. There is multifocal disease usually, and there is submucosal multifocal disease, which can be missed when you're doing any partial procedure. Right. Next slide, please.
And next is the type of radiation. The type of radiation which the patient has received, because there are lots of this thing. If he has got a conventional radiation, it is very difficult to do a conservative surgery, even if it is open surgery, because it may land up with troubles later.
Next slide, please.
Dr. Devendra, I think if you are going to do with a transfer laser for the recurrence cases, even in the T1 or very early T2, they should not be anterior commissure disease. They should not be posterior paraglottic at least. Maybe anterior paraglottic just going there, but the fat is free. Those kind of cases you can still do with a transfer laser, but not the posterior paraglottic or anterior commissure disease. They are a big no-no.
Right. So coming to conservative surgery, I'm going to sum it up for want of time. If the initial disease was amenable for conservative surgery, be it laser or open partial, the recurrence is the same stage at the same site, and the recurrent disease amenable to conservative laryngeal surgery are a few cases, 5 to 10%, as Sajid said, where you will attempt conservative laryngeal surgery. Else, 80 to 90% of the cases where the tumor is upstaged, usually you will end up with a total laryngectomy. So next slide, please. So what are the options of, so we have decided when we are going to do conservative. Which conservative open partial laryngectomy do you do nowadays? Next slide, please. Anybody? Saurav, Abhishek?
Supracricoid.
Supracricoid is what we have the most experience with.
Yeah. So usually recurrences which are anterior commissure, maybe involving the cartilage focally, but you have mobile arachnoids and mobile cords. In those patients who are amenable to conservative laryngeal surgery earlier, you may attempt supracricoid laryngectomy. Now, a couple of points. The oncological outcomes of open partial laryngectomy are said to be better than transoral surgery, but the functional outcome, because you have handled the cartilage and you've taken out the cartilage, are little inferior to conservative laryngeal surgery. Is that accepted? We'll move ahead. Next slide, please. We'll go ahead to the next scenario. Okay, right. Next slide, please. Next slide. Next slide, please. Next. Right. Next. Fine. Next. So we've done total laryngectomy. Next slide, please. Right. So we've done total laryngectomy, right? It's an endolaryngeal disease. You've got a good amount of mucosa. What are you going to do? How are you going to close this mucosa? Primary closure, I'll give you three options. Primary closure with an onlay muscle flap, or a primary closure with what we call as a patch, either a free or a PMMC. What are your options and why?
So in all my post-chemo radiation or post-radiation reconstructions or pharyngeal closures, I'm using an onlay PMMF flap. I'm using a patch or an augmentation of the mucosa only when the mucosal, the width of the mucosa is insufficient for primary closure. But all others receive an onlay PMMF flap.
Even my belief was same, but of late, for the last 2 to 3 years, I've not been using onlay muscle flap. Even without onlay muscle flap, the whole thing heals well.
You patch it and you close it primarily. No, you patch it.
No, patch. Patch is good enough, because if the mucosa is there, we can patch it and that heals well. Because the muscle is not going to help in any way unless we have cavities which are there because of the removal of the nodes or anything. We don't need to fill it up, because the onlay muscle is going to complicate the matter more, because it will prevent the skin for closure. We will have to put additional skins there.
Okay.
So,
yes,
so Dr. Devendra, two issues. I do only muscle only if it is feasible that to close the mucosa adequately. The issue is, number one, if you put a patch, there is a stenosis issue can come up later and patient may have swallowing difficulty. Number two, with the patch, the voice is with the TEP is not better. It is if you are doing primary closure, the voice will be better, but I will definitely do the only in the recurrent cases. If there are mucosa is shrunken or is less than 2 centimeter or 3 centimeter, then I will put a patch.
Right. So great points. Next, I'll just sum it up quickly. Next. So generally, what is the philosophy is that primary closure, because it is a radiated tissue, heals poorly, and you need to get a vascularized tissue. You can either put a vascularized tissue on top of the primary closure, or you can do a patch with a vascularized tissue, be it radial, be it PMMC. There is no difference in the outcome of PMF versus patch as far as leak rates and swallowing and speech outcomes go. But primary closure has better functional outcomes, but higher post pharyngocutaneous fistula rates. So clearly, as of now, most of us would get a vascularized tissue, be it onlay or be it a patch PMMC, right? So that is, but as Saurabh correctly said, in most of the studies, they have shown that a patch is associated with higher rate of stenosis as compared to a primary closure. And that is why generally most of them close primarily and put in a vascularized patch over the top. Now, next slide, please. Let's go to the next scenario quickly, and then I'm going to have a last slide on for the radiation and medical oncologists. Next slide, please. Right. So next slide, please. Right. Next slide. So we've talked about PMF, onlay primary closures for decreasing the pharyngocutaneous fistula rates. Next slide, please. Next slide. Lovely. Two questions quickly. Use of salivary bypass tube and use of TEP. Do you put TEP in a post-radiated case primarily? Because if it leaks, then it's a mess. That trachea necrosis off. And do you do it secondarily, or you're okay with putting a primary TEP because it's away from the field of closure? Quickly.
If it is a recurrence case, if I am putting patch, then I will don't put the TEP at the same time. If I am doing a primary closure, then I put the TEP.
Right. So if you go primary only PMF also, you will put in it. Any other thoughts, Saurabh? Abhishek, Sajid?
Always secondary.
Always secondary. Okay.
In fact, I do not prefer a secondary TB. I do not want to go in with a previously radiated and operated mucosal field. If the mucosa is good, I will go for a primary TB. Good and sufficient.
Right. So no real right answer or wrong answer to this. The problem in doing a secondary Sajid is that sometimes the axis gets deviated. It is that much more difficult. And studies have shown that the voice outcomes of secondary, even in the per primum setting, are inferior to voice outcomes in the primary setting. But your point is well taken. If you are doubtful of your closures, if there's a problem, if you're thinking, because sometimes when you have a pharyngocuteus fistula and the rates can be high as 30%, there can be necrosis of that upper tracheal ring, and then you are in a mess. You'll have to remove the TEP. So it's not a bad strategy if you get a primary closure to wait for everything to heal, settle down, and do a secondary TEP. But usually you will have lower rates of speech and ability to do the secondary TEP because of picture if the patient is leaked and because of change in the axis of the patient. So we have last 5 minutes. Next slide. Let's come to the neck, right? So now we have decided how we're going to close it. We have decided we're going to do a TL. What do you do with the neck? So let's say this was a T2N1 disease to begin with. He was treated with CTRT, was controlled. Now he's got a recurrence, primary. How do you evaluate the neck? Saurav told us do a PET scan, right? Are you going to go by the PET scan or are you going to operate the neck? Yes, Saurav, please.
So definitely PET scan is definitely on. If in the PET scan there is a suspicious node is there, like in the PET neck study is there, I will definitely do a FNAC.
Let me come in. Saurav, let me quickly come in. PET neck study was to look at the neck after the primary was controlled. Am I correct?
Yeah.
Here we have a recurrence at the primary side.
Okay.
And now we are talking of the neck. So there's a little bit of difference. I agree with you that PET neck has told us that PET scan is good enough. Go ahead.
No. So I will always do a FNAC if there is a suspicious node. If it is positive, then PET is negative or positive. I have no. Right. But if it is negative, then the PET has come into the picture.
So what Saurav is saying that even if PET is negative and your structural changes or structural disease there, you will put in a needle and check whether it's a viable tumor cells or not. Sajid, Abhishek, your thoughts.
So for me, most of my patients would have received PET. If the PET shows no uptake in the lateral necks, then no neck dissection. If the patient has not received a PET CT scan, then I go by the initial 3-tier imaging criteria, which was described for salvage neck. And if the pre-treatment neck nodal volume was high, then I would go in for neck dissection in most of these cases.
Right. Sajid, your thoughts? Next slide, please.
The threshold for doing a neck dissection will be a little high because it will add up to the complications there. So if the PET is negative and if the patient was to start with node negative patient on a salvage, I will try not to do a neck dissection. Okay. It will be the minimum possible.
That's perfect. Next slide, please. Next slide, please. Next. So the number of meta-analysis, and let me summarize this. The rate of occult positivity is 11 to 17% when you do an elective neck dissection. There is no difference in survival when, in the studies which have seen neck versus no neck. Of course, if you have positive neck, you must do the neck dissection, but I'm talking of H0 now. And there is some studies have said, and the debate comes basically because some studies have said that when you do elective neck dissection, there is a higher chance of pharyngocuteus fistula, not proved by any prospective or randomized trials, but there some studies do say that, and that is why the debate, if you want to do the neck or not. So clearly, the dictum is that if the neck was positive to begin with, or higher stage neck disease, and now the PET, even if it is negative, some people will go ahead and do the neck, or if the PET shows disease or there is structural disease. Yes, sir, a quick point from you.
So in most of the meta-analysis, it's come out that T3, T4 diseases, supraglottic, and in the glottis, if it is in the glottis, if it is T3, T4, then the paratracheal lymph nodes are usually positive.
Great.
So there are 3 points.
Thank you, Saurav. That's a very important point. Next slide, please. Next slide, please. Yeah. So here it is. T3, T4, T4 tumors, especially if they're supraglottic, transglottic tumors, pre-radiotherapy, high neck stage, and whenever you require a flap and you want to do vessel dissection, you do the neck. So excellent, Saurav. Thank you for that. We do the neck for supraglottic tumors. The incidence of metastasis is higher, and when you have higher primary or recurrent higher stage, then we do the neck dissection. I'll come to my last scenario. We're already 15 minutes over time, and it's not fair for the next panel. We started late and I had a little bit of a technical issue for 5 minutes. But let's come to the last scenario. Next slide, please. I want to get my radiation and medical oncologist in. Next slide, please. Next slide, please. Yeah, this is fine. No, the previous slide. Right. So now we've done surgeons have done their job. They've done a salvage laryngectomy. The histopathology comes as it's a cartilage involved. It's a exolaryngeal spread of the disease. There was one node positive with extracapsular spread. This is 3 years down the line after you have radiated the patient. Radiation oncology and medical oncology colleagues. Will you give this patient re-radiation for control, or will you give him CTRT, or will you ask the surgeons to observe because of the toxicity? Your thoughts, please. Maybe the radiation oncology colleague first, and then Sushil can take it.
Adjuvant RT, yes.
You would give adjuvant. What factors will you consider to give adjuvant RT for this patient? Maybe the initial dose to the spine, condition of the neck wound. Are there any factors that you will consider while
Definitely the earlier radiation dosages and all are of a concern. But here the gap between the second surgery is 3 years, as you said.
Yeah.
So that gives.
So what is the minimum gap that you're comfortable, Suman?
For re-radiation, anything after 6 months is now acceptable.
Okay.
But the more the gap, better it is.
Perfect.
For the patient.
Right.
But in post-op setting, yes, because of lot of morbidity, it is challenging.
Yeah. So you'll take a judgment call depending on the preoperative dose, depending on the disease-free interval, and depending on the condition, local condition of the skin and the neck, whether it's worth giving this patient radiation.
Right.
Finally, looking at quality of life. Is that correct?
Yeah, true.
Sushil, any data saying that you need to add chemotherapy in the postoperative setting?
Sir, in this setting which we are talking about, we are going into a curative intent therapy. Yes. But the problem here is it is in a relapse setting where we have done a salvage surgery. So the most important thing is to look into the general condition of the patient, previous toxicities, age, comorbidities. And chemotherapy just is a additive thing, because the primary thing is a radiation here. And if the general condition permits, then only I will go with the chemotherapy, otherwise no.
Right. So Sushil, hang on. Saurabh, I'm coming to you in a minute and we want to finish in the next 2 minutes. Sushil, now Suman did not like the condition of the wound or there was a lot of problems with the skin. She did not radiate this patient, right? And now the patient in a year's time has recurred. What options do you have with palliating this patient? I'm sure the surgeons don't want to re-excise it. All surgeons agree with me that the now resurgery in a already operated neck, parastobal recurrence, most likely you're not going to operate this patient. Sushil, what are the options?
So when the surgery and radiation is both are out, then it lies on the mercy of medical oncology. So the options are limited, but there are very good options we have, and this depends upon what exposure he has in the previous settings. If the taxane has been given, or is it in a fit condition to take treatment, or what are the PD-L1 status of the patient, affordability, and general condition and comorbidities. Because this is a very complex situation here, and the decision has to be very individualized rather than generalized in this situation. So option which we have is either with the combination chemotherapy, if the patient condition is good, no comorbidities, and not received the taxane initially. If they had been exposed to that, then the option here comes is PD-L1 testing. And if it is on the higher side, maybe CPS score more than 10, then it's a very good candidate for immuno-oncological therapy. And in my setting, what we do is we have limited options, and we mostly end up getting a metronomics, which they tolerate fantastically.
You have good results with metronomic chemotherapy.
Yeah.
Suman, are you okay radiating now if you're not radiated for the second time? A local recurrence in the larynx, parastobal disease. Are you okay radiating it again?
Radiating again then depends on not many factors, the general condition and the toxicities and other things. But yes, there is a window.
Right. Perfect. So like Dr. Guru said yesterday in his panel,
only thing I want to add is that the only thing I want to add, Dr. Suman said, is that we have we need to consider the volume of re-radiation. The most critical factor is that a smaller volume of radiation we can get away, but with a bigger volume, it is very difficult to face the subsequent complications.
Thank you, Dr. Kumarswamy. That's a great point you made. As Dr. De Cruz put it yesterday, surgery rarely, most of the recurrences are treated with radiation therapy for palliation, as Dr. Kumar Swamy said, by limited field radiation and by doing the newer techniques of IMRT or stereotactic radiotherapy. And if nothing works, then we go to Sushil and tell him, now you manage this. We have lost our battle with the patient. Saurabh, your last comment, and then we'll close this. We are already 15 minutes ago.
So same, you have asked for the patient recurrence, laryngectomy, 1 node positive, EC positive, 2 patient operated 2 years back. And after radiation of 1.5 years of the first radiation, both patient has been given at my place with Dr. Gagan is there, chemo radiotherapy, and both are fine at present. So you have to see many things. You have to see the patient condition. Have you put a vascularized flap or not? That is also very important to give re-radiation field, and patient overall condition and general condition of the patient, if he can take the therapy or not.
Absolutely. Point well taken. The local condition matters a lot when you're deciding between re-radiation. Any last comments, Sajid, Abhishek, Saurav? We've run out of time. We are actually over time because we started with 15 minutes, and because of the glitch.
Still you have covered a lot.
I think we did manage. We've eaten into 15 minutes of the next panel. So thank you very much for sticking, for answering to the point. Thank you, everybody. And I'll hand it back now.
Thank you very much.
To organizers.
Thank you. Thanks.
Good afternoon. Am I audible?
Yes, Ashok, you are audible. Hi.
Yeah, hi, Rajesh.
How are you?
Yeah, fine. Can we start the session?
Yes, please, please.
Yeah, so I welcome.
Can you hear me?
all the... Hello.
Ashok Das, can you hear me? All the panelists.
Yes, we are hearing you. Yes. Good afternoon, everybody. On behalf of my co-moderator Rajesh Kantri and me, I welcome all the esteemed speaker in this session. Thanks the organizer for giving us this opportunity. So I'll request Rajesh to introduce our speaker and let's start the proceeding.
So good evening all, and I welcome you all for this session of hypopharyngeal malignancies. We have got 4 speakers, and the topics are well covered. We have chemoradiation as organ preservation, and then we have upfront surgery versus chemoradiation for organ preservation. We have Dr. Atul Sharma who is going to speak on it. Then we have Dr. Nirav Trivedi who would speak on upfront surgery and salvage surgery. We have Dushyant who is going to speak on reconstructive options. And then we have Sir Dr. Ashok Fhno, who is going to speak on the post-cricoid malignancy. So in the interest of time, I would ask Dr. Atul Sharma to start with his presentation on chemoradiation for organ preservation. Dr. Atul Sharma, please.
I am surprised to see a different Dr. Atul Sharma, and this has happened in the previous FHNO meeting also. So, gentlemen, the photograph being shown is of one of my younger colleague who is working at Apollo New Delhi, and I am working at All India Institute of Medical Sciences. Nevertheless, I would like to thank the organizer. Just a minute. So I believe his screen is visible now.
Yes.
Yes, it is visible.
All right.
Dr. Sharma, please go ahead.
All right. Just a minute. I think always there are some kind of technical. Good afternoon. Would like to thank the organizer for giving me this opportunity. I'm going to speak on organ preservation in hypopharyngeal cancer, induction chemotherapy or concurrent chemoradiation. This is highly desirable to have organ preservation in locally advanced laryngeal or hypopharyngeal cancer to maintain natural speech, swelling function of the larynx. The option includes organ preservation surgery, radiation alone, concurrent chemoradiation, induction chemotherapy followed by concurrent chemoradiation, which we call sequential treatment. These
Yes, it is a recorded one.
strategies should be
the slides
used
are not moving in
to
that.
maintain or to
just a
provide
minute.
functional preservation, but that not necessarily means that they also provide survival advantage over total laryngectomy. Who are the patient who can be given the option for these are the fit patient, locally advanced laryngeal or hypopharyngeal cancer.
So the slides are not moving, sir. in that. Dr. Sharma?
Organ preservation in locally advanced laryngeal or hypopharyngeal cancer to maintain natural speech, swelling function of the larynx. The option includes organ preservation surgery,
All right. Is it
radiation alone,
moving now?
concurrent chemoradiation, induction chemotherapy followed by concurrent chemoradiation, which we
No,
call
sir.
sequential treatment.
It's not moving.
Not moving.
These alternative strategies should be used to
Just a
maintain
minute. I
or
close
to
this one
provide
and
functional
probably
preservation, but
I
that
close
not
this and go
necessarily
live.
means that they also provide survival advantage over total laryngectomy. Who are the
So now the slides are moving. You may do the presentation.
All right. So good afternoon, everyone. Sorry for the technical glitch that happens many a time. I would like to thank the organizer for giving me this opportunity. And I'm going to speak on organ preservation strategies in hypopharyngeal cancer. So as you know, I think this is one of the very widely desirable and recommended option for the locally advanced, not only laryngeal, but the hypopharyngeal cancer also. We need to have the natural speech and swelling function of the organ larynx. And the options include our surgical options, whereby we probably do some kind of the organ preservation surgery, radiation alone, and combination of chemotherapy and radiotherapy in different schedule, which may be induction chemotherapy followed by local treatment, concurrent chemoradiation, or the sequential induction chemotherapy followed by concurrent chemoradiation. I would like to highlight that the various kind of the surgical techniques have not been directly compared with chemoradiation. And these alternative strategies are basically employed to provide functional preservation, but that doesn't necessarily means that they also provide the survival advantage over total laryngectomy in locally advanced patient. So who are the patients who can be offered these kind of alternative options? This is recommended for the patients who are fit and are able to withstand the prolonged course of treatment and associated toxicities and they are also able to participate in various rehabilitation studies as and when required. Also, the patients who have extensive locoregional disease but inoperable but have the fit general condition, they also may be considered for these kind of the non-surgical options. The only important thing we need to keep in mind is that preservation of the larynx is not the exclusive determinant of quality of life, which is very, very important in head and neck cancer. We also need to see that the patients are able to maintain their speech, they're able to have the adequate swallowing, and also airway patency. These are the critical endpoints in the organ preservation options. And based on these things, an international consensus panel has recommended that a new endpoint may be used in the future studies, and this has been defined as laryngoesophageal dysfunction-free survival. And what does this include? This includes any kind of the death, any reason, local relapse, total or partial laryngectomy, tracheostomy at 2 or more years, and the presence of a feeding tube at 2 or more years. So there is no point in salvaging or keeping a dysfunctional larynx which has inadequate airway or which does not have adequate swallowing function, because this will not serve the purpose, and that is not aim of the treatment. Though the RTOG 9111 trial was made for the laryngeal cancer, but taking a clue from that, we know that one may prefer induction chemotherapy for the patients with the relatively high risk of distant metastasis, mainly like those who have the advanced nodal burden. This induction chemotherapy may not be as effective as concurrent chemoradiation for locoregional control without using salvage laryngectomy. This may have a better survival, not better, but not statistically significant survival compared to concurrent chemoradiation, because we know many times because use of induction chemotherapy may lead to reduced distant metastasis. The most standard non-surgical treatment in locally advanced head and neck cancer, concurrent chemoradiation, is widely applied or used in many centers, most of the centers, I would say. But it does come with a price tag, not only with regard to the acute toxicities, which may be in tune of 50 to 75%, grade 3 or grade 4 compared to radiation alone. And there are also long-term toxicity, which is probably evident from the free RTOG studies, where we may have significant number of patients experiencing laryngeal and pharyngeal dysfunction. Another issue which is being recognized more often nowadays is that many a time it is being reported that the patients who were treated with concurrent chemoradiation, they have the more chances of dying from non-cancer death, whether this is because of some kind of aspiration pneumonia, other problem, or issues with the chemotherapy which may cause some kind of the cardiac events in the time to come. We don't know for sure yet, but this is one of the important aspects to be kept in mind whenever we are using these approaches. On the other hand, we do have the induction chemotherapy, and there are some advantages and disadvantages of induction chemotherapy also. It does decrease the tumor volume, thereby probably have better local control and symptom control. It also does sensitize the tumor cells to radiation, and responding patient may give us an idea whether the patient is responding, likely to have the better response and organ preservation. And those who are not responding to the induction chemotherapy may be considered for the surgical or locoregional treatment otherwise. The downside of induction chemotherapy is that since we are using combination chemotherapy, and nowadays many centers prefer 3-drug combination, the toxicity may be substantial. There may be delay in local treatment, which may be counterproductive in some time, because if the patient progresses, then intent of the treatment instead of radical or curative in nature probably will be considered as palliative in nature. So the two important studies which established the role of induction chemotherapy in the recent years, the 3-drug combination I'm talking about, taxane-based, were TAX 322, 3 and 324, and these employed the two kind of the induction protocols, 2 drugs versus 3 drugs, But what they shown is that the induction chemotherapy using 3-drug combination may produce significant responses, but at the cost of toxicity. We need to use as many times prophylactic antibiotics and also growth factors. The new thing which is being considered for the non-surgical treatment with the patient who present with large primary tumor or the nodal disease is sequential treatment. Here we expect the induction chemotherapy probably will reduce the distant metastasis and thereby improve function and improve local renal control as well. Whereas concurrent chemoradiation part will be helping in the improving local renal control. The various non-surgical treatment used in the hypopharyngeal and laryngeal cancer has been in practice for last 3 decades or little over that, starting from the Veteran Affairs trial in the laryngeal study. Then we have the URTC 24891 for the hypopharyngeal cancer, and various RTOG trials. The point I would like to highlight here that other than the few studies which have just focused on laryngeal, hypopharyngeal, or larynx and hypopharyngeal tumors, most of these studies have used the patient from the other subsite also. Of course, they all are the locally advanced cancer. Let us review few of these studies. The first publication in mid-90s from the URTC study established that the induction chemotherapy using the 2 drugs compared to the surgery and post-op RT probably will not decrease the survival. And number of these patients, about 1/3 of these patients were able to maintain their laryngeal function at 5 years and over that. The initial publication was in mid-90s and the recent was in 2012 in Annals of Oncology. The study by the Spanish cooperative group reported in 2014, they had unresectable N2, N3 locally advanced head and neck cancer. About 1/5 of these patients with hypopharyngeal tumor, and they used the 2 types of induction chemotherapy, cisplatin 5-FU and with or without docetaxel, followed by the concurrent chemoradiation versus chemoradiation alone. The primary endpoint of PFS and time to treatment-free failure for this study could not be met, and there was no difference in the PFS or TTF. Around the same time, there was another publication, DECIDE trial, where they have used the 2 cycles of TPF and followed by the systemic treatment plus hydroxyurea and radiation and compared it with the chemotherapy plus hydroxyurea and radiation. In this particular study, the primary endpoint was overall survival. Unfortunately, it did not meet its primary endpoint, and because of poor accrual on this thing, the study was halted in between or prematurely closed. The 3-year OS in this study was 75% versus 73%, and this was considered really high overall survival for patients who present with N2 or N3 disease. One of the reasons being mentioned is that these patients, in the concurrent chemotherapy also they have used the 2-drug combination, 2 drugs along with the hydroxyurea as the radiosensitizer. In the recent years, the only study which has shown that the induction chemotherapy followed by concurrent chemoradiation may be superior to chemoradiation alone was reported about 4 years ago from Italian group. This was a phase 2-3 studies where 420 patients were randomized to these 2 arms, and primary overall survival was kept as primary endpoint was kept as overall survival. About 1/4 of these patients were hypopharyngeal cancer, and rest were oral cavity, oropharyngeal, or laryngeal tumors. In this study, there were 2 randomizations. One was between chemotherapy and induction chemotherapy. And among both these groups, there was a further randomization. One was chemotherapy using the concurrent chemoradiation using the chemotherapy, and second using radiation with the radiobiotherapy, that is cetuximab and radiotherapy. In this study, they have shown that the sequential arm had the significantly improved overall survival compared with chemoradiation alone. And also they had the improvement in the PFS at 3 years.
Dr. Sharma, Dr. Sharma, sorry to interrupt you. We have a
Yes.
time constraint also. Please try to conclude.
I think I was allotted 15 minutes. Am I 15 minutes through?
Actually, we lost few of this time. So anyway.
All right. So I quickly try to finish that. Okay, I'll just take 2-3 more minutes. In this study, if you see the improvement in overall survival, are basically this is the oropharyngeal cancer, PFS and OS. Improvement in OS was mainly because of the non-oropharyngeal tumors, and half of them were the hypopharyngeal tumor. This is another recent publication by Gotek 2007-02, and this study about 1/4 of these patients were for hypopharyngeal tumor. It did not improve the overall survival, but if we consider distant mets as one of the primary endpoint, there was significant improvement. There is some Indian data also in neoadjuvant chemoradiation from the Tata Memorial Hospital, suggesting that this may be one of the options in the patient who present with advanced stage of the disease. I'm not going to discuss this thing. I briefly touch upon the meta-analysis which presented a couple of months ago. In this particular study and the previous meta-analysis has suggested that larynx and the oropharynx are the cancers which derive maximum benefit from concurrent approach, and surgery may be preferred in oral cavity cancer. That's suggesting that the oral hypopharyngeal tumor also may not derive that much of the benefit with concurrent chemoradiation. And if in this particular meta-analysis, if you compare concurrent chemoradiation versus induction chemotherapy, there were 8 comparisons using 1,200 patients, and so all endpoints showed that there was patients who were in concurrent chemoradiotherapy, they had significant superior outcome with regard to OS, EFS, and local renal failure also. So this is the same, showing that for the distant mets, only induction chemotherapy may be superior, but rest all parameters, it is the concurrent chemoradiation, which probably should be treatment of choice. I'm just not discussing. This last 2 slides, our own experience when we had analyzed about 1,300 patients, and about 200 of these patients had the hypopharyngeal tumor. The point I would like to highlight here is that concurrent chemoradiation, particularly for the subsite hypopharynx, is not that great. Outcome is significantly inferior compared to larynx and oropharyngeal tumor. In this particular analysis, we found that laryngeal primer, they had this median overall excess of 140 months compared to just 33 months in hypopharynx, suggesting that maybe that we need to do something more than simply using concurrent chemoradiation. These are the multivariate analysis, and one of the factors is primary tumor. Larynx probably had the best survival, and the hypopharynx had the worst survival. Would like to conclude by saying that role of induction chemotherapy, sequential therapy versus chemoradiation alone remains controversial due to conflicting results. Hypopharynx is one where one may think of using induction chemotherapy because results with or outcome with the concurrent chemoradiation is very poor. The group that is likely to benefit most are those with bulky N2B, N2C, or N3 disease or bulky primary tumor. Based on these studies, decide Gotek and Stallion study. I'm sorry for the technical glitch. I would like to apologize for that. And thank you very much for patient hearing. Happy to take questions now or later on. Thank you very much.
I think we'll take the questions at the end of the 4 presentation. And may I invite Dr. Nirav Trivedi with his presentation. Nirav.
Thank you, Rajesh Bhai, and all other seniors. Am my slides visible?
Yes, Nirav. Just check whether they are moving. Okay.
Is it moving?
Yes, yes, yes.
I'll just give a brief overview. About 3% of total head and neck cancers are hypopharynx cancers. As Atul sir mentioned, it's aggressive biology and poor prognosis compared to other subsites. Unfortunately, more than 50% develop recurrence within a year. Many of them present with distant metastasis, and improvement in last decade in survival is negligible. Now, overview of management. We have to consider all subsites separately: pyriform fossa, postcricoid, and postopharyngeal wall. Generally, it's multimodality treatment because most of them are advanced stage disease. And there is an increased emphasis on functional organ preservation. You also have to remember when we talk about quality of life that quality of life with single modality is always better over multimodality. Now I'll directly move on to surgical considerations and I'll take each subsite separately. When we talk about pyriform fossa, early lesions T1 and T2, when we talk about surgical approaches, there are two broad surgical approaches. One is minimal invasive, either endoscopic laser or TORS, and then there is an open partial hemilaryngopharyngectomy. When we talk about moderate diseases, T2, T3, and N0, as Atul sir said, there is a role for non-surgical organ preservation. But at the same time, I personally feel, as he rightly pointed out, that the survival or the outcomes with organ preservation for hypopharynx is not that exciting. And I think all of us in practical point of view, a T3 tumor with a large node, we would probably offer radical surgery. And for all advanced tumors, definitely a radical surgery with appropriate adjuvant treatment. Recurrence and residual disease, most of us would prefer a radical surgery in form of total laryngectomy and pharyngectomy. Now let's talk about early pyriform fossa lesions. What are the conservative procedures? So the indication for conservative procedures are when the lesion is small, either involves medial, anterior, or lateral wall of hypopharynx or pyriform fossa. So what are the contraindications? If tumor has reached apex, then most of us would not attempt a conservative procedure. If it's involving postcricoid, we would not. If it's a multicentric disease, definitely not. And if it has gone into paraglottic space and vocal cord is fixed, again, we would not generally opt for a conservative procedure. So the key is proper, if you are considering for a conservative laryngeal procedure, it has to be proper evaluation with imaging and endoscopy. Now let's take one by one surgical options. So one of the first one described was supraglottic hemilaryngopharyngectomy. My honest admission that I have not seen that or never done it, and I think it's rarely been used now. From the literature, one of largest studies, 85 patient studies, showed 3-year survival of about 60%, but almost 34% of them had local recurrence. And also the study demonstrated that there was high rate of permanent tracheostomy and gastrostomy too. So with his morbidity, I don't think this type of procedures is regularly performed anywhere. Now coming on to other open partial surgery, which is described by Lacuraci et al. Supracricoid hemilaryngopharyngectomy. Again, I have personally not done that, and all the contraindication remains the same as for other conservative procedures. They showed a very good 90% larynx conservation at 3 years, 3.7% perioperative mortality, and 10% of major complications. They also recommended that you should either do a neck dissection or address the neck through radiotherapy because very high incidence of regional metastasis. Now, these are the pictures from his publication. So once you put a neck incision and raise the skin flap, the side where you want to remove, you have to go right onto the lateral aspect of the thyroid cartilage and retract the strap muscles with the perichondrium, expose the thyroid cartilage, and lower end, as you can see here in the figure C, you enter the thyrocricoid membrane and then use a scissor to vertically divide the cartilage and remove half on the ipsilateral side. Once you open, you can see the opposite side vocal cord here, and this is epiglottis here, and this is the side of the pyriform fossa that you want to remove. And once you remove the half that you really want to remove, you mobilize the remaining posterior pharyngeal wall mucosa medially, like they have done here, and then suture it to the remaining thyroid cartilage, epiglottis, and hyoid bone, and then reinforce it with the strap muscles that you had already lifted off. So this is how they perform supracricoid hemilaryngopharyngectomy. And this again, I don't think many of us are doing it because now the technique with transoral laser microsurgery or TORS is very well developed. So we talk about now laser microsurgery. It's technically slightly more challenging compared to laryngeal lasers because the anatomy of a pyriform fossa is multidimensional, medial wall, lateral wall, apex. So its entire lesion is very difficult to be seen in a single frame. You also need to have a proper neck extension and proper mapping of preoperative, so you can plan properly. It will be a piecemeal resection, but in a standardized way, so you can achieve negative margins. This is again taken, I don't personally do this, so taken from one of the atlas from Sultan Pradas sir. You can see an early pyriform fossa lesion, this is ideal for your laser excision, and a very good job, good post-op oncological and functional outcome. When you look at the literature for the outcomes for these procedures, a 5-year overall survival for T1, T2 lesion is about 65 to 80%, while for T3 and T2 it will fall down to 35 to 45%. Larynx preservation rate in various series ranges from 78 to 98%. In most of the cases, you can remove the Riles tube, within 10 days. And oncological outcome is also significantly better if you give adjuvant treatment for close margin or node positive diseases. So this is a summary of literature for early pyriform fossa lesion treated by transoral laser microsurgery. Now let's move on to transoral robotic surgery for early pyriform cancer. There are few advantages of robotic surgery. One, the vision is much better compared to transoral laser surgery. It's a 3-dimensional vision, and you can have the entire area in a single view, so you can plan an en bloc resection. Multiple small studies have shown its feasibility for early pyriform lesion. This can also be used for posterior pharyngeal wall lesion. But there are certain challenges that if the neck is too narrow and the tumor is quite deep, then your arms collide, so it becomes technically difficult. Also, we use a monopolar cautery, and compared to laser, this do have more collateral damage to the vocal cord area. So these are technical limitations. And now I picked up one of the studies which had a decent follow-up of 60 months of 38 patients. They showed margin positive rate of about 8%, 21%, 8 patients. But 5-year disease-specific survival was 100% for T1, T2, while about 75% for N+ disease. And average Riles tube removal and tracheostomy degeneration time was 15 days. And only 1 patient had permanent gastrostomy and 3 patients had permanent tracheostomy. And they said that the outcomes were better for pyriform fossa compared to posterior pharyngeal wall lesions. Now, there is no study that has directly compared TORS versus translational surgery for early pyriform tumor. So in my opinion, it would depend upon the availability of equipment and your surgical expertise. But one thing is very sure, that if you are technically skilled, then this is a better procedure to perform compared to open procedure, because all the studies says that functional outcome are much better with endoscopic microsurgery for early cancer. Now we move on to early post-cricoid and posterior pharyngeal wall lesions. And we all have to remember that there is no conservative surgery for post-cricoid when it's always the total laryngopharyngectomy plus menoesophagectomy. TORS is feasible for posterior pharyngeal lesions, and technically skilled people may do that. But for an open, if there is an isolated posterior pharyngeal wall lesion, then through an open surgery, you can do a lateral pharyngotomy, expose the lesion, just do a wide action, and then reconstruct it with a flap, either a radial forearm or a pec flap. So that is technically possible, but you have to weigh compared to the results of radiotherapy, which is not the purpose of the talk today. Now moving on to advanced lesions, let's do certain basic considerations. So for advanced hypopharyngeal lesions, radical surgery in form of total laryngectomy with partial or circumferential pharyngectomy is treatment of choice. We always do this for T3 and T4 lesions, but sometimes with large infiltrative T2, T3 tumors, with large node also. This becomes a treatment of choice, definitely along with appropriate adjuvant treatment. Now, for post-cricoid tumor, Dr. Ashok sir is anyway going to describe in detail. So you operate either without esophagus or with esophagectomy. Always remember to do bilateral neck dissection, and for advanced lesion, always an appropriate adjuvant treatment, either RT or CTR. Now let's look at surgical consideration, and then I will handle each of the considerations separately so we can understand the challenges that we face. So hypopharynx is located laterally in the laryngeal complex, and when advanced tumor it goes out through the parapharyngeal wall, it abuts to the carotid vessels. So the plane to carotid is the first thing that you need to consider. Second thing is prevertebral fascia, as posterior pharyngeal wall directly sits onto the prevertebral fascia, so it's very close. The third thing is hypopharynx tumors are known to have submucous extension or skip lesions. Fourth is remaining pharyngeal mucosa and how you plan reconstruction. Again, we have a separate talk on that. Then fifth is what to do with esophagus based on the lower extent. Pharyngocutaneous fistula management is again an integral part of your surgery for larynx and pharynx. Most of these patients do have dysphagia as an initial symptom, and that's why malnutrition leading to healing issues is very, very common. And majority of them are smokers. So again, you have to worry about the chest morbidities. Now the first aspect, the carotid. Now, when you see a patient with advanced hypopharynx coming out through the pharyngeal wall, on a CT scan, it will always look that the carotid is abutting. Anytime it's like encircling the tumor and all that. But in our personal experience, if it's a de novo patient, not a salvage patient, the carotid vessel is very, very resistant to tumor invasion. So majority of time, if you plan your surgery properly, you should always be able to spare a carotid. So generally, just don't rule out curative surgery just based on a CT scan. When you start, you always start on the side of concern. Gradually separate your sternocleidomastoid and interjugular vein. And once you reach the carotid, have a principle to expose the carotid. Don't keep a layer of fascia over carotid to protect. Only when you see the carotid, you will be able to nicely dissect it. And rather than trying to mobilize the larynx, the first thing is to dissect the entire carotid in the length and separate it. Automatically, your larynx is mobilized. In this way, you can very surely preserve your carotid. On an upper part, if external carotid is involved, you can always ligate it and sacrifice it. Also remember that you cannot ligate internal jugular vein on both the sides. So one side of internal jugular vein preservation is very, very essential. So these are the things that you keep in mind while you are planning your surgical step. Second thing is prevertebral fascia. For me, this prevertebral fascia, when you look at the scan when the posterior pharyngeal wall is involved, it will always say abutting prevertebral fascia or involving prevertebral fascia, or there is plane or no plane. But I don't pay too much attention to that. What I do is I ask the patient to flex the neck, relax the neck, and then I mobilize the larynx side to side. If there is a decent mobility side to side, I feel very confident that my prevertebral fascia plane is okay. And now this can be a challenge when you talk about salvage surgery post CTRT. Sometimes the larynx doesn't move properly. In that case, if you have doubt, I always give a chance. And then when you are doing the exploration, before I commit to my proper surgery, from the lateral side, I would enter and try to free the prepharynx plane, the prevertebral fascia plane. And if you get a good clearance, then only go ahead and then proceed for the further surgery. So again, for me, this is more of a clinical decision rather than imaging. Imaging will only tell me if it's grossly invading into the prevertebral fascia, and this, which I can always, even make out through if it's completely fixed. Now moving on to submucal extension or skip lesion. So if you look at the literature, three type of submucal spread is described. So I'll show the publication. So the first type is our common type, where ulcer, and beyond that there is a significant induration. So it's in continuity. You can easily palpate that. That's your type 1. Then type 2 is generally seen in post-radiotherapy setting, where you will see various islands of, like finger-like projections and islands. So these are the cases where you really need to be careful when you are doing a salvage surgery. And many of authors and surgeons recommend to actually do a circumferential defect, a resection, when you are treating the salvage hypopharynx. And third is the true skip lesion. You can see here beyond this, and this is so if you look at the data, it's only less than 5%. Most of things are type 1 and type 2. Now, how do you handle this submucous spread while you are operating?
Nirav, sorry
Yes.
to interrupt. I'm requesting the speaker to stick to their time. Hello.
Yeah, just 5 minutes. Just 5 minutes. Sorry. So how do you do that? So proper evaluation, you always open from the opposite side and expose the larynx, palpate it properly, inspect the surrounding area, and take at least 1 or 1.5 centimeter of margin. And once you remove that, you always check the remaining mucosa for skip lesion. I'm not going to go into the closure at all, but you have 3 options: primary closure, patch PMMC, or tube flap. For me, threshold is very, very low for putting a flap, and I generally prefer a flap reconstruction over primary closure. Now, what do you do with esophagus? So this is a manubrium sternum here, and on a lateral examination of a scan, if I see a disease limiting, at least I need to have a couple of centimeters here to be able to decide if esophagus has to be preserved or not. And when you mobilize, it's circumferential defect. When you go down, you always palpate and then take an adequate margin here. So you always have about a couple of centimeters lower esophageal margin. Just a word of caution: always have backup for stomach pull-up when you are operating on a post-cricoid tumor. Then I generally, if I have preserved esophagus, I try to do a primary TEP, and most of the time it works fine. When you are doing a stomach pull-up, the most important thing is while you are mobilizing from the neck, membranous trachea, preserve membranous trachea, don't damage because it's a very delicate structure. And while making a tube, I don't do a bimanual from abdomen and neck. We put a varicose vein stripper from here through the esophagus, tie the lower end, make the stomach tube, tie through the thread, and then just strip the esophagus off. There are many advantages of not damaging pleura or azygous vein, and there's an immediate tamponade, and it's a very simple procedure. I'm sure Ashok sir will describe it in detail. Pharyngocutaneous fistula management, again, very, very important. My philosophy is prevention is better than treatment, so I always put a PMMC. But if you haven't put a PMMC and it's like a big leak on a day 1 or 2, probably you have to explore and put a flap. If it's a small leak after 5 to 10 days, conservation mostly will help you close the fistula. Most of the time, you should be able to close the fistula with a local mobilization. The concept is it has to be a tension-free repair. So you both the side you need to elevate a flap properly, refresh the edge, and do the inner closure as well as the outer closure. When you mobilize fistula, you always have 2 layers, inside and outside. Both need to be closed, and even larger defects can also be mobilized through this. There are other issues like malnutrition and chest physiotherapy that you really need to address. And for salvage surgery, most of the things that we discuss hold true. Only thing is, when you are planning a salvage surgery, always do a PET scan so to rule out systemic spread. Then one of the most important thing is skin. The skin will retract when you lift, so I try to use it with knife. And when you put a flap, the flap will become very bulky in the neck. So most of the time you should be able to, use a skin graft to cover the defect. And this is something. Otherwise, all the points are same as what we do in a primary surgery. Just when you want to do a tube, the tube becomes very bulky in the neck, so the skin doesn't get closed, and most of the time tube opens up. So what I do is I take a PMMC and then use prevertebral fascia as a patch, and then put a large muscle over it as a secondary healing, so that even if there will be a fistula, but it will heal very nicely with this large muscle cover. And if the skin doesn't come, you can put a nice skin graft. And after a couple of days, we always put an elastocrep bandage. Also, when there is a fistula, try to lateralize the fistula so the salivary leak doesn't go into trachea and create trouble. I'm sorry for overshooting the time, but the summary is that for early hypopharynx, you can do a minimal invasive surgery. But for advanced stage, most of the time we do a total laryngectomy. Thank you very much.
Thank you, Dr. Neerav. May I invite Dr. Dushyant Jaiswal to present his talk on the reconstructive options after hypopharyngeal defects. Dr. Dushyant, please.
Thank you, Rajesh. I would like to thank the organizers for giving me this opportunity. Can you hear me?
Yes,
Rajesh,
we can hear
me?
you. Please go ahead.
Yep. You can see my screen too, right? Okay.
Yes.
So my preceding speakers have made my task easier. Almost all the concepts have been discussed in brief. I'll just elaborate on the important points which I see from a plastic surgeon's eyes. So essentially, when you have a hypopharynx defect after a total laryngopharyngectomy, morphologically, the answer will be in one of the three. Either you have enough remnant mucosa, which can be closed primarily to retain your speech and swallowing function, or there is some which requires augmentation, what we call a patch, or there is no remnant pharyngeal mucosa and you need replacement by a tube to restore the alimentary canal continuity. Now, apart from the amount of mucosa which is left, I think there are two more things which are very important while taking this decision. One is whatever donor site you choose, is it available and is it compatible with the size of the defect and the habitus of the patient? And the other is the associated comorbidities. So if we look at these things one by one, the conventional treatment limit has been 3 centimeters. So anything more than 3 centimeters, which is good in quality as per vascularity, pliability, and preferably not too bad a radiation effect, can be closed primarily over a Leitstrahl's tube. Anything which is less than 3 to some remnant which can hold sutures is amenable for a patch. Now this patch could be a pedicle flap or a free flap. And when there is no mucosa remnant, there are two things to decide. If the suture line is too low or the cut is too low where esophagus has to be removed, you get a stomach tube replacement, or you choose a tube, either a skin or a bowel tube. But I think a lot of our resecting surgeons must have often seen this situation where your variable mucosa remnant is actually, the mucosal remnant is variable. In some parts it's too thin, some parts it's almost gone, and the other parts it's more. I think you go and convert it into a defect by which is the most critical element. So I tend to judge it as the least part. Most of the defect is what component. Like in this defect, I'll treat it almost like a total mucosa loss and convert it, replace it with a tube. Now, when you look at reconstructive options, I like to divide them in two things. One is the most common practical options which we use routinely. PMMC, of course, is the workhorse. When you move into the free flap zone, you have radial artery and ALT as fasciocutaneous flaps, which you can use either as a patch or as a tube, and jejunum most commonly as a free flap or tube replacement, or the stomach tube in the neck as a pedicle flap. There are other options too, which we rarely use or were used earlier, or I would call them a little fancy. Of these, only supraclavicular flap, I think, has some promise to be used routinely as a replacement of radial or ALT, because it gives you tissue of that pliability and quality. The donor site closure might be an issue. The availability of that perforator vessel integrity in presence of previous neck dissection or radiation might be an issue. But when their presence is confirmed, I think it's a good option. And everything else from superior thyroid artery perforator to infrared to FAM, submental, DP, I think all these flaps suffer from the problem of not being very predictable. And for a buccal mucosa, centimeter necrosis might be tolerable, but anything in pharynx which leaks leads to a clinical cascade of events of leak, stricture, dysphagia, sometimes bleeding. And one thing you always have to do in pharyngeal reconstruction is to have your reconstruction very robust, so that these simple complications which can blow out into a major event don't happen. So when you start looking at these donor sites, I think it's very important to judge these donor sites before you select them. Though PMMC is a default option, beware of it in a female patients, especially when the chest is very ptotic, or in male chests which have a female-like consistency with gynecomastia. Even with the radial forearm, if you choose, the Allen stress should be favorable. Again, in ALT, you need to have the right thickness and perforator availability. And anything from the abdomen, just be cautious about previous surgery, tuberculosis, or any ischemic inflammatory bowel disease. Apart from these, when you have to look at the comorbidities also. In an equidistant patient, doing a pedicle flap might be favorable over a free flap. So the comorbidities are high. In a patient in whom there is poor lung reserve, you will have a very high threshold to convert to a stomach tube and prefer to do a jejunum because the morbidity of removing an esophagus and stomach would be taken care of. And again, as with severe coagulation morbidities, you'll treat carefully with a free flap. Now, if you look at the three options, first is the primary closure of the mucosa. I think Nirav has talked about it very well. I think you do it when you are in no doubt, basically. If there is an iota of doubt about the vascularity, pliability, radiated status, you just shift to another, to the next step, that is a patch. Now, I think there is enough evidence, enough people do either simple, continuous, use all types of sutures. I think as long as there is adequate and vascularized mucosa, everything works. And if technicality, you have sutured it properly. Again, there is an issue whether to buttress this or not, buttress it with a PMMF or convert into a patch. I think I'll leave it to the individual surgeon's discretion, but the general consensus is now, if you have a doubt, you put a PMMF, or if there is a leak, you put a PMMF. Otherwise, primary closure is good enough. So the next stage is augmentation or a patch. So generally, when you have a doubt with the primary closure, you go for a patch. If you have a doubt for a patch, you go for a tube replacement. Now, the design of a patch, I think it's you don't have to go with any prefix designs about centimeter and size. What I prefer to do is to make a pattern for every defect, and the patch should match. Now, that whatever dimension it is, that is it, and be a little generous in replacing it, but not too generous, because mismatch, trying to suture mismatch suture lines is most often common cause for a leak. Again, suturing techniques and suture material multiple are described. My preferred for all pharyngeal suturing is interrupted sutures with PDS, horizontal mattress, preferably extramucosal wherever feasible. So this is just one example of a PMMC. Again, you can, I prefer to design it along the vascular axis of the PMMC and often sacrifice the nipple, let it go in the pharynx or remove it. It's okay. Vascularity is more important. And even a misplaced nipple, even if you preserve it, it's not going to look great. The absolute argument for muscle is that it gives you an exceptionally good second barrier to any fistula or any leak if it happens. But if you give me one flap to do for all patch or tube defects, I think I would choose a radial forearm flap. The pliability is unmatched. The vascularity is super robust. The ease of insert is unbeatable. There is no bulk in the neck. Neck skin always closes, and it gives you an option of a chimeric island when it is when there is a skin defect also. It's just that we have a PMMC, so we think that the muscle will buttress the leaks. But with the radial, if your suturing comes out generally so good that there's no question of a leak. You can do the same thing with an ALT, which is relevant in Indian situation because a lot of our patients would have a very low BMI and thin. And this would give you the option of closing the donor site also primarily with very minimal donor site. And it also gives you an opportunity to make it a chimeric flap where you can replace any skin defect with another skin island. So this brings us to the last third option where you have to replace the tube. Now, as Nirav said, you can replace it with a tube PMMC. You can use the PMMC as a patch. In case of a tube defect also with the posterior pharyngeal wall, prevertebral fascia serving as a tube. But I think the thickness of the PMMC is not very amenable to a tubing. And more often than not, it often leads to simple leaks. And the problem with pharyngeal leaks, again, is the clinical cascade. And these patients then don't go to reach the stage of where they can eat properly. My personal preference is jejunum for all tubes. And a very high threshold is converting to a stomach tube also. If my needle can reach in the thorax, I will suture it to a jejunum for. That's my protocol. So in rare cases where there is a contraindication to opening the abdomen, you can do a free tube radial artery forearm flap or a tube ALT with a skin island like in this case and get away with it. But more often than not, I would do a jejunum. This was the earliest reported free flap actually, but then it not really fell into disrepute. Just the need for open surgery in high BMI and morbid patients in Western world, it didn't take up much. But if you ask me, in Indian situation, I think it's a very good flap because the patients are not very thick. You can get this out with a very small incision, sometimes laparoscopically. It's super robust. The donor cost is zero because a jejunal anastomosis always heals in no time. You don't have to keep the patient NBM for more than 1 day. As per the ERA's protocols, which generally GI surgeons follow, even Wickles patients start eating day 2 or day 3 these days. And if you look at it as a substitute, morphologically, it's the closest match to esophagus. Apart from the length and all we can get from it. And all the arguments against it about short ischemia time, I mean, anyone who will dare to do a jejunum will do it in good time. You have to finish the micro in 1 hour. And I think speech and all also you can easily put a TP with it, so it's not that much of an issue. Veins are supposed to be thin, but it doesn't happen often. They're okay. So another argument against jejunum has been that suture line doesn't match the upper end of the tongue base, upper defect. But you can easily spatulate it. Just opening it along the antimesenteric border gives you an extra length. So you have to add the width of the upper end to the length when you harvest the jejunum and consider it. And you can easily create monitoring loops also for it to work. So now, the whole debate about these skin-lined circumferential tubes versus intestinal tubes is centered on leak versus healing, stricture, speed, swallowing, and donor morbidity. Now, if you see the literature everywhere, speech they have considered either fasciocutaneous to be better or equal. Swallowing rates, less leak rates, and stricture-wise, on all these counts, intestinal tubes, especially jejunum, either does better or it's equal. And donor profile-wise, ALT is shown to be better than radial on all counts. This was one of the largest meta-analysis of tube flaps, and this really supported these conclusions. Nothing is without complications. They might be far and few between, but sometimes you'll have these radiological leaks which you don't need to do anything about. Sometimes they'll manifest clinically. More often than not, the genesis of these leaks is not the type of flap you have chosen, but in the technicality. Either there has been some tension due to some reason, or the patient has violently moved their neck, but it's a rare event. And if you have enough tissue, you can still get away with suturing them back or adding a PMMF. Very rare flap necrosis you'll have with jejunum. So now, as Neerav said, when you look at salvage options, I think PMM pectoralis major is your best friend. Any minor leak over a primary closure patch or a tube, PMMF comes in. For major leaks, PMMC comes in. You have a tube complication, loss of a jejunum or ALT, then again, you'll have to go back to the stomach tube. Deltopectoral flap is your one-stop solution for all skin defects or dehiscences which needs to be covered. I think this is an often situation you face clinically, where you will either have a patch or a tube defect with a skin defect. My recommended approach for this situation is that do a DP for all skin defects. The skin is thin, it's locally available, the vascularity is good for this amount of reach, donor site is likely to close primarily, and you address your pharyngeal defect on its merit. And that's the approach I often follow. Even with free jejunums, I put a DP whenever there is a skin defect. It tends to work very well. Now, the whole debate about what choice to make is centered around swallowing outcomes conflicting with speech outcomes. And it's not just in India. Even if you look at Taiwan, there are the Fu Chan Wei group, which prefers fasciocutaneous tubes for better speech. And Hang Chi Chen does intestinal tubes for better swallowing outcomes with sometimes biological valves and shunts for speech. My personal philosophy in this is I prefer jejunum for tube defects and give swallowing priority because swallowing is a very absolute thing. You have a leak, it heals with a stricture. Generally, patient never eats properly. They go to a gastric tube or forever on Ryle's tube. Even if there is a suboptimal speech outcome with a well-healed reconstruction, the speech can be supplemented by gestures, by messaging, by writing, by facial animation. Swallowing is a very absolute thing. If you lose it, it honestly never comes back. So That's the final. Thanks a lot.
Thank you, Dr. Dushyant. And now we'll move on to our last presentation by Professor Ashok Shenoy. So I would invite Sir to give his presentation on post-cricoid malignancy.
Can you hear me and see me?
Yes, yes, sir. We can hear you. We can
Thank you
see
very much,
you.
Ashok and Rajesh and all the other panelists. Now my presentation today is to answer this specific question. Is there any current alternative for gastric pull-up after an oncologically necessary total laryngopharyngectomy in advanced post-cricoid cancer? And this was a 2-decade study done at the institute where I stayed for nearly 3 decades. And there are a lot of people who are involved in the study. You can see them in as the co-authors. And basically, I'm going to address the issue of where you cannot get a complete resection because the disease is going down into the mid esophagus or the cervical esophagus, specifically beneath the thoracic inlet. Next. Can I have my next slide, please? Neeraj. Yeah, thank you. The history of gastric pull-up, it's been done first time in 1913, and it was reported in cadavers. In 1936, you had successful approach reported for intrathoracic esophageal cancer. And the largest cases that came up were the Lekessen and Ranger in 1966. And thereafter, we had Dr. Harrison also popularizing this issue. Now, the segmental blood supply of the esophagus, the submucosal spread, which Neerav alluded to and was presented as the Hayes-Martin lecture by William Way, saying that you must take at least a 1.75 centimeters around the margin to get a clear field, is basically because of the field changes. And this is the biologic support for the TLPE, what is the gastric transposition plus total laryngopharyngoesophagectomy. So this is the issue that I'm going to specific case. And I believe that India is a place where you are gifted with a lot of cancers. So we go on to the next slide. Next slide, please. Now, what are the issues? The CTRT is dismal here. Most of the people are totally dysphagic. They are younger population. They may smoke, but we see in Karnataka a reasonable amount of people who are young women. And I suspect that this is going to be a thing that has come of the Plummer-Vincent syndrome. It's a nutritional disease. And the surgery and anesthetic advances have diminished the morbidity and mortality, as I'm going to show you. Cost remains high because of intensive care, but if you are careful, you are working in a high volume center, this can be maintained. And you need adjuvant therapy for these cases because these cases are always, the disease is very, very advanced, both at the primary site and more at the neck. Importantly, the high points of this procedure is a one-stage procedure, one anastomosis. Basically, the anastomosis is the gastropharyngeal anastomosis. So if you have disease going into the nasopharynx, maybe this is not a good thing to do. The stomach tube is reliable in respect to blood supply, and it is resistant to any leak or stricture, and therefore most of these patients start swallowing at the end of the first or second week. Minimum morbidity you can achieve, as I will show you, and the good gastric speech can be there if you use, this has also been published from a center. Next, please. Next slide. So when is an advanced post-cricoid cancer amenable to curative option? The disease should be stage 3 or 4A with minimal extramural extension, minimum tracheal posterior wall infiltration, no prevertebral fascia invasion, and preferably, this is the most important point, there should be only disease in one tracheoesophageal groove. Because if you have disease in both tracheoesophageal groove, then it predisposes to you to do a bilateral paratracheal clearance, and this may not be theoretically possible to leave the one parathyroid on the contralateral side. So this is a very important point that the nodal disease have to be resectable. Usually we do not operate if it is less than 1 centimeter, but these tumors were almost always the disease in the neck or the primary were amenable to the disease. The patient factor, as I told you, they are dysphagic. Good, they should have good performance status. They should have reasonable life expectancy and fit for major surgery, and a good teamwork is necessary. Next slide, please. So the contraindications is, as I told you, bilateral TO groove or thyroid gland infiltration. This is not tenable. Innominate vessel infiltration, lower tracheal wall infiltration, bilateral paratracheal nodes which are positive, and therefore these are the areas. This is submucosal disease. The field changes makes it very difficult to assess, and therefore we do not do this as a salvage procedure. So we need to work up these patients well so that you get an opportunity to make a decision right up. Next slide, please. The position of the patient, you know it. Patient, important thing is we need arterial lines and central line, a urinary catheter. These are absolutely necessary, and this cannot be traded for because this is a major surgery. Then you need to intubate. If you have a good airway, you intubate orotracheally. Otherwise, you can do a tracheostomy. But important thing to do is to do a bronchoscopy to assess the posterior tracheal wall involvement. Then you prepare the abdomen. Today, we are moving away from a formal laparotomy to a laparoscopic approach. And I'm sure in the days ahead, you'll use the robotics also to mobilize the stomach and do the intrathoracic dissection to minimize morbidity. Next, please. Can I have the next slide? So there are 3-4 phases, and I will take you through these 3 phases. One is the cervical phase done by the head and neck. The second is the abdominal phase done by the general surgical team or the laparoscopic team and maybe the robotic team. And the last is the mediastinal phase where we join hands and try to mobilize the stomach through the posterior mediastinum to deliver it without tension into the neck so as to effect a pharyngogastric anastomosis without any tension. Next, please. Next. So important thing right at the outset, please try to rule in operability. You should not have disease in the bilateral paratracheal area, and the tracheal wall should be not infiltrated low down. In such a situation, it's probably better to abandon the procedure, do a tracheotomy and a judge and come out. The important thing is to preserve one thyroid lobe on a pseudo-mesentery, which I'll show you, which contain the veins, arteries, and logically the parathyroids. Next, please. Next. So this is the cervical phase. I didn't have to go into it because my friends have already done it. Bilateral necks have to be given addressed, and the margins, as I told you, Dr. William Way said that we will have 2 centimeters of margin. Next. Next, please. Preserve the thyroid lobe at all instants. As I told you, this is a dissection plane and you need to use it. There should be no disease in this plane. And after you do this and you preserve one thyroid lobe, next, please, ensure a tumor-free dissection. And then you do the superior mediastinal opening by head and neck surgeon and dissect the esophagus right down along the posterior wall first from the prevertebral fascia and then between the membranous wall of the trachea. So you have to be very, very careful here. And important thing is you have to cut the vagus and also cut the lymphatics. If you don't do it nicely, then you will have a chyle leak. Next. This is the pseudo-mesentery with both vascular pedicles preserved. And you see the TO groove clearance. This is very, very important. In the lower slide, you can see that the TO groove is nicely cleared and there should be no disease here while you are in the neck or at least 2 fingers below the supraclavicular notch. Next. And then you go, meanwhile, our friend, the abdominal surgeon will mobilize the stomach and based on the right gastroepiploic and right gastric artery, cauterize it. And today we use a lot of laparoscopic approach and the patient doesn't have a large scar. and all these things like pyloroplasty and feeding jejunostomy will be done, and the patient will have the cardiac juncture transected. Next, please. This is the stomach tube being made. The stomach tube is made using a stapler. And if you make it, the advantage is that it avoids the ballooning of the stomach in the posterior mediastinum, and thereby causing the suffocation which happens in most gastric pull-up patients. You also need to sometimes dissect the crura. So all this can be done endoscopically now, and you can use the laparoscope and dissect the esophagus from the membranous trachea right up to the lower end of the esophagus. Because this is very important. If you do this, the morbidity becomes much less. Next. And this is the post-op care is important. This is a specimen that has come out. And earlier on, we used to be very happy that we're not punctured the pleura and avoid keeping ICD. But today, I believe that ICD on both sides are imperative because you need to allow the lungs to expand. Give epidural analgesia so that the patient is comfortable post-operatively. You have to consider prophylactic antibiotic appropriately, and coagulation also is important. Keep the patient in a state to avoid a deep vein thrombosis. Next. Can I have the next slide, please? So I will just share with you, before I close up, I have 3 decades data, 78 cases. The first 78 were done on groups of 20 cases each, and final 18. The second case were a prospective study started in 2008 and was carried out as a fellow's thesis. And we looked at all the parameters and the quality of life and survival at 2 years. Next. The first 20 patients, the mortality was 25%, prohibitive. But as we went down, the second cohort, it was 15, third cohort, it was 5. And finally, in the prospective series, we had only 2%, 1 death amongst 50 cases. Then we had the morbidity that is there, which is, it shows the same parallel situation. The first cohort had a lot of intrathoracic problems like pneumothorax, chylothorax, biliary peritonitis, tracheal tear. However, as we went on ahead, we found that these complications became less. And next, can I have the next slide? And as we went on to the final lot, we found that by putting bilateral ICDs in all patients and doing very aggressive physiotherapy and aggressive parenteral nutrition, we had most of these patients going home in the 14th postoperative day, 14th to 16th postoperative day. And the intrathoracic problems became less. More importantly, the hypoparathyroidism became virtually nil because we used to protect one lobe with its vertical intact. Next. Can I have the next slide, please? I have only 2 more slides, I think. Next. So disease-free survival, again, if you look at it in the first cohort, it was 20% 2-year disease-free survival. And as we go down, go to the next slide, please. As we go down with better experience, our survival, disease-free survival improved. Next. We found that at the last cohort, which was the prospective study, we had at least 34 out of 50 patients doing well. And if it was the follow-up was minimum of 49 months, but if it was projected to 5 years, we expected that it will touch another 10% higher. So the cost cutting due to minimal, then we go on to the next slide. We show that most of our patients have not had any kind of, they were not T2, they were T3, T4, and N+. And the neck was upstaged in 58% of the disease when we did a clinico-pathological study. Next. Next, please. So what are the options for cure? In 100 cases, laryngeal functions were sacrificed due to facilitate early feeding in almost all cases. Disease control plus adjuvant ABRT plus CT at 2 years was 51%. This was our data prospective study. Mortality diminished from 20 to 2%. The serious resection associated complication, initially it was 60% in the first cases, and then it came down to 20%. So you're going to have a issue where there is going to be a issue of complication because this is a major surgery. Non-surgical option, I would just like to do what our own study here during that time where patient refused the surgery or were deemed unfit. unfit, I will not take. Patient who were considered, they said, we don't want such a major procedure. So in these patients, we had to do a feeding procedure. We had to, the laryngeal function was poor. The pharyngoesophageal dysfunction rate was very high. And most importantly, the disease-free survival was very poor. It came to about 13% at 2 years. And this is our data much before that, because of which we embarked on a total laryngopharyngoesophagectomy plus gastric polyp as the treatment and choice in young patients who are reasonable life expectancy and who want to eat normal food at the end of the treatment. Next slide, please. Next one, please. Next one. So I think I come to the end of my presentation. Dr. Ashok Das and Dr. Rajesh Kantaria ji and all my fellow panelists. I would like to emphasize that in India, where we have post-cricoid cancers still a looming threat and occurring due to some nutritional cause, we need to consider this important issue in those where the disease goes down beneath the thoracic inlet. You can perhaps definitely do away with the mediastinal dissection if it is not, and you can use a complete tubing as was aptly shown by Dr. Dushyant. You can use a jejunostomy, jejunal repair. I don't know why. I was there in Liverpool with Dr. Stell long time back and I saw him do it, but somehow it is not really picked up in the country. I don't know why. Maybe Dushyant will be able to, is it more complicated or is it an issue that it requires too much of, you need the clearance, and suppose you don't get a clearance and you have skip lesion which is left in the remaining stump, then it becomes a catastrophe.
Yeah,
so with this, thank you. I'd like to thank Dr. Thakkar and all the office bearers of FHNO, for giving me this opportunity to share with you. Thanks very much.
Yeah, thank you very much, sir. And on behalf of the FHNO, both myself and Dr. Ashok Das would thank all the panelists, because we have to move on to our next session. I think we will not have any question answer session, but only one question I want to ask to Dr. Nirav and Dr. Atul. When Nirav, you will send an advanced pyriform sinus cancer to Dr. Atul, and when Dr. Atul, you will send it to Dr. Nirav.
I think I'll ask Atul sir to go first.
Dr. Atul, are you here with us?
Okay, so Rajesh bhai, case where you have an advanced primary with large multiple nodes, you already know that this hypopharynx is it's a bad biology. Even though your PET is negative, there is a chance of micrometastasis. I might send a patient for kind of an biological triage, neoadjuvant chemotherapy with 3 drugs. I think that is something where I would send a patient for an see. I can't see anyone else, Ashok sir or Rajesh.
I would like to suggest the patient should be fit. In fact, he should be fitter than for surgery. In fact, people think that since CTRT is non-interventional, it is something like a cakewalk. I refuse to believe that, because even in the RTOG 91 travel, you see the death was 5%. And how many patients have we lost in a year? Our mortality rate in head and neck department in a year was less than 1%. So really, I would not be able to say that it has to be a fit patient. And of course, the disease has to be exophytic and non-infiltrative and less burden in the neck. If you have less burden clinically in the neck, then probably these people will enjoy the fruits of chemoradiation and probably be able to eat for a short duration before the disease recurs. So this has been my experience, except if you're talking about T1 and T2, that you can do whatever you want.
I was very specific. It was about advanced pyriform cancers. So thank you again, all the panelists, because I am getting, repeated messages from the organizers. We'll have to stop here, so have a good evening, and we will meet sometime again. Okay. Yeah. Thank you very much all. Ashok, you just want to thank? Ashok?
No, I just want to thank all of you. I've been in Patna doing a lot of head and neck recently. It's the head and neck capital of India, I believe. But really, it has been a great challenging exposure. And for me, FHNO is a great homecoming because all you guys were there when we started it, and you're still with us. So thanks very much for keeping the flag up. And I'm happy that we have made it a specialty organization, and hopefully it is still democratic. So I hope it will just grow and grow and grow as this program seems to be.
Sir.
Thanks a lot.
Thank you, sir. And we close.
Thank you, Dr. Bipin.
Thank you.
Yeah. Okay, chai karta hai. Speed, they were telling me here to wind up. I was the last speaker.
Full on speed, no? So one thing.
But I did it, I think it went off.
Just, yeah.